Dr. Milnali, good morning. Could you please unmute your microphone and open your camera? Let's we'll test this system. Am I audible, Dr. Milnali? Okay. Dr. Milnali, could you unmute your microphone and open your camera?
Sure. Yeah, sure. Am I audible?
Yes, yes, you are audible, but echo is coming. I think there are two devices. Please,
One second.
thank you.
Am I audible now?
Yeah, you are audible.
Okay, okay.
Hello. Hello.
Mrinalini, could you please start the session because we have both the speakers in the meeting room.
A very good morning to all the dignitaries and my dear participants. Firstly, I would like to extend a warm welcome to all the Nopconians on the second day of our webinar, focusing on recent advancements in the diagnosis and management of orofacial pain. We'll be commencing today's program with the very first talk by Dr. Cheena Singh. Dr. Cheena Singh, an associate professor at PGI Rohtak, brings over 6 years of experience in oral medicine and radiology. She holds a bachelor's degree from MDU Rohtak and completed her post-graduation in oral medicine and radiology from Tirthankar Mahavir University. Dr. Singh is a recognized expert in forensic odontology with fellowships from SDM Dharwad and Smile USA, Rutgers University. Currently pursuing a PhD at Desh Bhagat University, she actively contributes to PGI as a medical board member. Specializing in orofacial pain and TMJ disorders, she has treated numerous cases. She is recognized for her significant contributions in age estimation through forensic odontology and holds an accredited certification in cognitive behavioral therapy. She is also a certified specialist in tobacco cessation. In acknowledgement of her research excellence, Dr. Cheena Singh was recently honored with the Young Researcher Award in the year 2023. We cordially invite Dr. Cheena Singh to share her expertise on trigger point injections, a conservative method for treating myofascial pain at our forum. Ma'am, please.
Dr. Minali, my slides are visible. Dr. Minalini, my slides are visible.
Your slides are visible. You can go on a
Yes, ma'am, yes, ma'am.
share screen mode.
No, it is fine, Mrinalini.
Yes, ma'am. You can put it on the slide share mode. So that,
I'm not able to see on my screen, Mrinalini.
okay.
Can you please help me out in that?
Yes, ma'am. Bottom corner, just where 69% is left, ma'am. Can you just go left to that? There's one icon of the screen. Can you click on that?
Which icon, Mrinalini?
The bottommost corner, there's 69% open is there towards the right side. Can you see that 69%?
No, I can't say 69%, Mrinalini.
Okay.
Dr. Chena, can you just go back and again do the share screening?
Okay, yes, ma'am. Will do, ma'am. Ma'am, I have shared again, ma'am.
Can you see your presentation in front of you?
Yes, ma'am.
Yeah, there is a battery icon, battery percentage of 69% remaining. Down, bottom right column. Yeah, go next to that symbol. There is one more symbol.
This one, ma'am.
No. Go up, little bit up, little bit up. Now click on that. Click on it. Click on it again, ma'am. Go to right, little bit more, little more in the center of that icon.
Here, ma'am.
Yeah, go to the right. The center of the icon, you just go to that icon itself and just click on it.
It is not working this time.
Dr. Chena, the icon that shows the full screen just next to your 69%.
So, but on my screen, these all mute, stop, video, security, they all is coming, sir. Those
Can you present in this mode itself? Will you be able to present it this way
Yes,
by
ma'am.
pressing the down button? Yeah, that will be great, doctor. Continue from here on then.
Yes, ma'am. A very good morning to one and all. Myself, Dr. Sheena. Today, I'm going to speak on the topic of trigger point injections, a conservative method for treating the myofascial pain. I'm going to cover my topic under these contents: introduction, from old to new, what is a trigger point, history, etopathogenesis, classification, perpetuating factors, type of needling, wet and the dry, selection and the angulation of the needle gauze, different type of anesthetic solutions, local anesthetic used for the wet needling, maximum needling solutions and the frequency of the needling, clinical guidelines for application of needle therapies, post-needling procedures, and possible reason for failure of trigger point injections. As we today's all are suffers from the pain. The pain may be the central and the peripheral. The central pain is due to the neurogenic inflammation, but the peripheral pain is due to the trigger point injection. As the pain is the first step is the nociception. So first I would like to introduce to you the new and the old definition of the pain. According to the International Association for Study of Pain, the pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage or described in terms of such damage.
Ma'am, sorry to interrupt. Can you put it on full screen? Your slide.
I'm not able to do that, ma'am. Sorry, ma'am, for that. I'm not able to see the icon, ma'am.
Try function key 5, F5. Top of your 5.
F5, sir?
Yeah.
Function key and F5. Yeah.
Yeah.
Yes.
Okay, thank you, sir. Thank you very much. In 2016, the Amanda C. et al. They again introduced a new definition of the pain as pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and the social components. From the old to the new, you can see there is the more involvement of the areas of the body, that is the sensory, emotional, cognitive, and the social components. In again 2020, the pain was again classified by the International Association of Study of Pain as a unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Then when the pain affects the peripheral areas, the most affected areas is our trigger. There will be the formation of the trigger points. So what is the trigger point? According to Shah et al. In 2015, a myofascial trigger point is a discrete hyperirritable nodule in a taut band of skeletal muscle that is palpable and tender during the physical examination. It is a discrete, it will not be localized in a muscle. Hyperirritable, whenever it is palpated, the patient will be hyperalgesic. It is a nodule in a taut band of the skeletal muscle that is palpable and tender during the physical examination. They produce pain locally and in the referral pattern. Moving towards the little bit of the history, from 15s to the 2000s, from 1538 to 1660, Guillaume de Bellius, they were the first from the France to write about the muscle pain disorder. Then 1846, Balfour is explain it as a thickening and the nodular tumors in the muscle with local and the regional muscle pain. In 1904, Gowers described in the fibrositis and created as a hard nodule. From 1904 till now, the US physician Janet Travels, he is working from his work has been appreciated from on the myofascial pain. The most accepted theory for the myofascial for the trigger point formation is the energy deficit theory. What this theory says? It says that whenever there is a action potential reaches to the axon terminal, this is our axon and it is its terminal. So there is the opening of the calcium gates. Whenever the calcium gates will open, it will stimulate more and more of the acetylcholine to release. And this is our neural part and this is our muscular part. So the junction is the neuromuscular junction and this is the presynaptic cleft. So more of the acetylcholine will release and they attach to the sodium channels. So sodium ions flow across the membrane into the muscle and they will leads to the sarcomere contraction. So what will happen after the sarcomere contraction? There will be the compression of the muscles, of the vessels. So whenever there is a compression of the vessel, there will be the decreased blood supply. So decreased blood supply, more acidification will be the hypoxia and there will be the more contracture of the muscle. Then the classification from past to present. Earlier, we called it as a myofascial pain distress syndrome, but nowadays, according to the DCTMD criteria, that is a diagnostic criteria. There is a one more criteria, research diagnostic criteria, but for in our clinic, we mostly use the diagnostic criteria. Local myalgia, myofascial pain, and myofascial pain with referral. Local myalgia is whenever there is the muscle on the face and there is the point of pain is there that is local to that muscle. That is the local myalgia. Myofascial pain, the pain with the muscle palpated with spreading of pain beyond the location of palpating fingers, but within the muscle, as in case of the masseter. Not as in earlier in the local myalgia, the pain will be localized to the particular area. But when along the knot, the multiple areas the pain is there, that is the myofascial pain. Myofascial pain with referral, pain with the muscle palpation beyond the boundary of the muscle. Apart from the masseter, the pain will there in case of the temporalis muscle, as in case of the trap, the patient will feel the pain into the occipital region area, and that is with the referral. So there are the different etiology behind the myofascial pain. If there is the muscle hyperactivity, muscle fatigue will be there. That can lead to the myofascial pain dysfunction. Then the dental irritation by the high points of the restoration, muscular overcontraction, muscular overextension, contracture, that is the pain length, shortening of the muscle, occlusal disharmony, internal derangement, that is anterior displacement with reduction, without reduction, degenerative joint disease, as in case of the rheumatoid arthritis, they all lead to the altered chewing pattern and thus to the myofascial pain dysfunction. So what are the perpetuating factors? Perpetuating factors are they alone stood alone, they are not responsible for the disease, but somehow they contribute to the formation of the trigger points. Gonadal hormones, subclinical hypothyroidism, nutritional deficiency, mechanical factors, and the psychosocial factors. So under the gonadal hormones, testosterones in the males, they have the anti nociception property, and in case of the female, the estrogen have the same. Subclinical hypothyroidism, nutritional deficiency, vitamin B, vitamin D, iron deficiency, they are more, the patients who are suffering from these problems, they are more predisposed to the trigger point formation. Mechanical factors includes the postural postural is not correct, then a structure of the body is not correct, as it is too high of the table or the chairs, and we are typing for a long time on the computer or anything, then it can leads to the muscle fatigue. Improper position of the chair can lead to the trigger point formation, though they all include the mechanical factors. The patients who are hypermobile, joint hypermobility, they are also suffers from the trigger point formation. Psychosocial factors includes the stress, which is a major factor nowadays. Then what is the trigger point? How does it look? This is the normal band of the muscle. This is the normal band, but this dark color and this red eyes, these are the trigger points, and these are the taut bands. So this is the magnification, the magnified form of your trigger points. You can see these bulging areas. These are the contracture nodes, and these are the normal muscle. So more of these contracture nodes, they leads to the formation of the trigger points. So what are the methods of palpating the trigger points? There are the two methods of palpating the trigger points. One is the cross fiber flat palpation, and second is the pincer method. So how do we perform the cross fiber flat palpation? In cross fiber flat palpation, we have to, if there is a trigger point to this area, you see, then we have to first put the finger on this side and then to this side. Then you have to put finger like this, and you have to see the trigger point in between. You have to see the subjective response. You have to see the eyes of the patient, and you see the body language of the patient. Patient will give the jump sign that I will show into the live cases. Today I'm going to show the few cases also. So then again, second method is the pincer method. You have to, with your digits, you have to stretch the muscle like this. Then you have to release it, like you will feel a taut band in between your fingers, and that taut band is your trigger point. I have already told how to palpate the taut band. This is the flat, because our hands are flat like this. Our hands are flat. Okay, and the second method is the pincer method. Then what are the different type of needling? There are the two types of needling, wet and yes, okay. Why without adrenaline? Because if the patient muscle is already hypoxic, if we use more of the adrenaline, that will lead to the vasoconstriction, and that will increase patient's pain, or you can say that will increase the patient pain threshold. So we should always use without the adrenaline. And there is the one more thing, local twitch response. Whenever you put the needle into the trigger point, you will see a little bit of bouncing of your the needle. That is the local twitch response, and that is also a diagnostic method that you are right into the trigger point. Then the second is the dry needling. In this, as the name is telling, it is dry. So no injectable solution you will use in that. So you can do it with the vigorous in and out movement of the from the trigger points. So which needle to use during the dry needling or the wet needling? There are two type of needles, hypodermic needle and the filiform needle. Hypodermic needle that we usually used in our clinics, that is the bevel cutting edge needle we use. and you can see the diameter is 1.60 millimeter. The matchstick is just to place here to compare the thickness of the diameter of the needles. So the filiform needle, that it has a conical point, or you can see it as a diamond shape, the point. It is used to treat the area which is very close to the vital structures. As in case of the trap, you have it is very near to the upper lobe of your lungs. And in case of your sternocleidomastoid, which is very near to the external jugular vein. And yes, in case of the temporal muscle, which is very near to your temporal arteries. So from 21, 23, 25 to 30 gauge of needles we can use depending upon the where the muscle is superficial or deep. So these are the different type of needles which we are using commonly in our clinic. This is the 23 gauge needle and this is the 26 gauge needle. And the angulation of the needling gauge should be 30 degree. This is the position of your needle, and this is your trigger point, and this is your angulation. And there is the methods of the trigger point injection. How should we give the trigger point? The word giving in our articles is the fanning. Few people prefer the fanning and few people don't prefer the fanning, but I will prefer the fanning because it includes the more surface area of your muscle. Whenever you inject the muscle to that area, you just do a fanning, a fan like this. Just the fan moves, the fanning. So it will covers the more areas into muscles, or it may includes both the active and the latent trigger points. So what is the active points? What is the active trigger points? Active trigger point is the trigger point for which the patient has come to you. Clinical complaint. The patient has come to you for with that complaint. But in case of the latent, the patient will not have any pain there. Whenever you palpate that area, the patient will tell, yes, I have a pain there. It have the same referral pattern of your active trigger point, but the difference is one, which is that the patient will not come for that to you. That is not the clinical complaint of the patient. So anesthetic solutions for the wet needling, lignocaine, bupivacaine, saline, steroid, and the neurotoxins. We have a Botox nowadays. It's very high demand, Botox. It's a neurolytic component. So in our clinic, the available is a lignocaine 2% and the bupivacaine 0.5%. I would like to add one thing in that. Please don't use much amount of bupivacaine because it is myotoxic. We have just to irrigate the waste products, just to inflammatory products, the interleukin 6, interleukin 4, and P substances from that area. So just to irrigate that area, we need not to use again and again. The patient is coming to you until unless patient is not in high pain, in more pain. The patient is not hyperalgesic. If the patient is in more pain, you can use the bupivacaine. But every time the patient came to you, please don't use the bupivacaine because it is myotoxic. So use the saline or the lignocaine. So maximum needling solution and the frequency of the needling. Maximum needling solutions which can use per trigger point, I'm telling per trigger point, is 0.5 to 1 ml. And the frequency 5 to 10 needling sessions at one visit, or the amount of the needling the patient can tolerate. That amount of the frequency of the needling we can do. Sorry for interruption. Here I wanted to show a procedure for the dry needling. Then with the help of sterile wood, we will see that then ask the patient to clench his or her mouth so that it palpate the messenger properly. Then we will hold the trigger point in between the two. Then we will check at the angulation point. Inward, outward, abruptly, inward, outward. Then we will take it out. This is the procedure how we will perform dry needling. So before proceeding to any procedure, whether it is the dry needling or the wet needling, proper patient medical and the dental history should be taken. Patient positioning should be proper. Reproduce the pain, and if the in case of the children or the needle phobia, we can use the ethylene chloride as the vapor coolant spray. So this is what is the procedure for the wet needling. This is the temporal muscles. Here I am doing the procedure of the wet needling. This is the patient of the migraine. Basically, I am treating the migraine also here, and this is the area where we can inject. So the care should be taken not to go directly into the temporal artery. How to mark a trigger point? You have to place a cross to that area. So that is the trigger point. And there is the chart given in a book of which is the Bible for the myofascial pain, that is the Simons and Travails. You see a dark point here and the dot here. So this is the question mark pattern. And what does this dark points and the light points will tell? In the more the studies, the more the maximum amount of the patient will show the pain into the dark areas, and into the light areas there are the less number of the patient will tell the pain. So these are basically the study based table, and you can use this table during your clinics to see the referral pattern so that you can treat the patient very well. So sharing the few cases. See the jump sign. The patient is giving the referral pattern to the forehead region. This is the second case. See the jump sign. The patient is telling the pain is going to the forehead region. So this is the typical referral pattern. You see that I have palpated the trap, but the patient is feeling pain into the forehead region. So this is the referral, typical myofascial pain with referral. You can give the diagnosis of myofascial pain with referral. So we have already discussed the marking the trigger points. So always palpates with the finger, never palpates with the two fingers. This is not a correct method of palpating your active trigger point. So care should be taken for the vital structure safety. As in case of the sternocleidomastoid, always hold the muscle while the patient is sitting in the erect position and then slightly rotate the muscle. Then stretch it by the using the pincer method. You see here we are using the pincer method medially. Never inject laterally, because in lateral position you see the you will have the external jugular vein. You have to inject medially, not to laterally to the patient. The care should be taken while injecting the posterior muscle, because there is the suboccipital triangle, and in that triangle you will see the vertebral artery. So unnecessary avoid puncturing the vertebral artery. Care should be taken how to inject to the posterior cervical muscles. Care should be taken to inject into the temporal artery. How it can be prevented? Whenever the patient come to you and you see a local myalgia into the temporal muscle, then ask the patient to clench, release, clench, release. You will see the uplifting of your fingers. Wherever you see the uplifting of your fingers to the temporal area, that is your muscle, and there you have to inject. These are the other muscles, that is the lateral pterygoid, masseter. And what are the journal guidelines for trigger point injections? Palpate and identify the anatomical landmarks. If you are not aware from the anatomical landmarks of your orofacial region, don't touch the patient of the trigger point. Palpate the taut band with cross fiber, flat or the pincer palpation. These are the two methods which we have already discussed. Identify the trigger points and fix with either the pencil grabs or the flat palpation as you feel comfortable or you are skilled in any of the method. Needle with a straight in and out motion, elicit a local twitch response, draw the needle back to the subcutaneous tissue and redirect the needle to treat other trigger points. Don't try to inject once and you think you will treat all the trigger points. No. For every trigger point, you have to take your needle out and then inject into the other position so that you can target the other trigger point. Provide the hemostasis immediately. Apply a post-needling intervention for reducing the post-needling soreness. Ask the patient to place a cold fermentation into that area. Trigger point injections are contraindicated in case of inadequately trained practitioner, needle phobia, cognitive impairment, patient unwillingness to be treated, patient's inability to give the consent, local skill lesions as in case of the vesiculobullous lesion, locals or systemic infection, needling directly over the implants. Precaution should be taken during the first trimester of pregnancy, any vascular disease, abnormal bleeding tendency and a needle aversion. What are the reasons for the failure of the trigger point? The main reason behind is the disregarding perpetuating factor. It's fine you have treated the trigger point locally, and every time the patient is telling, I have only 10% relief, 20% relief, and then on the first visit it is fine, second visit the same result, third, then you should target to the perpetuating factors, systemic factors also. You can't rely only on the local factors. If you are not getting the proper result, it means some systemic factors are also involved into the myofascial pain. Needling a latent trigger point, not active trigger point. If you are not targeting for the patient has come to you, there is no need for that. There is no usefulness of the treatment. You have to first target the active trigger point and then the latent trigger point. Moreover, if you will do the fanning, the latent trigger points will be covered in that also. Needling the area of refer pain and the refer tenderness. Note the trigger points, therefore providing the incomplete temporary relief. See, there are the two things. One is the source and one is the site. So you have to first target the source, not to the site. If you will target the source, the site is automatic will come into the circle. Failure to needle the trigger point itself, inappropriate needle goes. Always use a stiff needle. Never use a flexible needle because you will not able to target the trigger point. Inject a solution with an irritating or allergenic bacteriostatic preservative. Inadequate hemostasis followed by the irritation of trigger point due to local bleeding. Overlooking other active or the associated trigger points that are contributing to the patient's pain. Failure to provide post-needling care, including hemostasis, full stretch range of motion, postural and the position instruction, activity modification, and neuromotor retraining. What does it mean? You have to ask the patient to not to do any movement for minimum of the 3 days because you are providing a physiotherapy in some manner. Failure to establish a home exercise. So take home message is that a proper history from the patient and the good skill and knowledge is required so that you can treat the orofacial pain treatment, orofacial pain patients. These are my bibliography. And below I have given my email. If you have any query related to any case, you can give a mailed to me, and thank you for the patience. Last but not the least, I would like say thanks to the National Health Academy and especially the Noodle sir, again giving me a chance as a speaker. Thank you very much, sir. Thank you.
Thank you, ma'am, for such a wonderful talk. Your concise explanation about the trigger points, how to identify them, and the management of it through dry needling and needling, it was truly remarkable. And you had incorporated a lot of cases and the videos which really simplified the topic for us, ma'am.
Thank you.
So there's one question from Dr. Pinky. She wants to know if we need to take consent for dry needling.
See, in case of the for every patient, you have to take because you are doing, somehow you are touching the patient. In my opinion, if you are touching a patient in somehow manner, before you should take a consent. Even uh, if I am taking the photograph of a patient, I take a consent. So if you are doing whether the dry needling or the wet needling, take a consent from the patient, because in case of also the dry needling, a post needling soreness is there. If you have not told the patient earlier, then it can create a problem for you. But for the, in my opinion, for the both cases, whether it is a dry needling or the wet needling, we should go for the consent, because you are touching the patient, and before touching the patient you should go for the consent.
Yes, ma'am. The other question is if we can use insulin syringe.
Yes, we can. A 30 gauge syringe is basically an insulin syringe, so we can use it. But I will prefer for the, see, the length of your needle will be decided on the basis of your the muscle. If the muscle is the superficial, as in case of the superficial masseter, you can use the 30 gauge needle. If the muscle is deep, as in case of your lateral pterygoid, there is no need for using the 30 gauge needle. So in case, or in case of the trap, there is no need for using the 30 gauge needle, because that is the very thick muscle and the deep muscle. So in case of the superficial muscles, you use the 30 gauge needle you can use, and in case of the deep, you should use the long, the 23 gauge, 26 gauge you can use. If I would like to add one more thing, if you want to go for the insulin syringe, better you use the 26 gauge needle, which is of less length, 1.5 inches. You use that. That will be the good replacement for your 30 gauge needle.
Ma'am, the other question is if we can aspirate before injection. If we should aspirate, I think, before injection.
Yes, if we should do the aspiration before the injection. If you are not aware from the anatomical areas of that area, of that region, and you are in a doubt that there can be some artery to that area, yes, you can do the aspiration to that area.
And one more question is there any role of prolotherapy in trigger point injections?
See, prolotherapy is basically a regenerative, right? So there is the very less evidence for that. Prolotherapy is more to be into your TMJ joints, which we are using nowadays. That is case of the joint hypermobility. So I think the main reason behind the trigger point formation is the contracture. So we have to relax the muscle, hypoxia, acidification. We have to clean that area basically. So what is there are very less evidence for the trigger point we are using the prolotherapy. Not much evidence is there for using the prolotherapy, because the etiopathogenesis of the your trigger point formation, that doesn't suit the for the prolotherapy.
Okay. Thank you so much, ma'am.
Okay.
So moving on to our next speak for the day by Dr. Tatu Joy. Dr. Tatu Joy, TMJ Center's founder and lead physician, is an oral medicine and radiologist specializing in neuromuscular dentistry and temporomandibular function with 21 years of experience. A dedicated advocate for TMD treatment in India, he has pioneered initiatives such as establishing India's first exclusive specialty diagnostic center in Kochi and the first CBCT imaging center in Kerala. In 2015, he inaugurated India's first exclusive NM dentistry clinic, now known as Dr. Tatu's TMJ Head and Neck pain care, reflecting his
Right.
commitment to providing quality family care. I kindly invite Sir to deliver his expertise on the myriad dimension of neuromuscular dentistry. So please.
Thank you, Dr. Mrinalini. Am I audible?
Yes, sir, you are.
Okay, my screen is shared.
Yes, sir.
Oh, good. Thank you. We are set to go. Okay, good morning and welcome everybody. Thank you, Dr. Nurul, for inviting me to speak at this venue. I love when I'm called and I don't have to move from my house. So I love the invitation. Thank you so much for that. And yeah, we've been hearing a lot of speakers throughout from yesterday onwards. And so my perspective, and see, about 20 minutes is not enough time to express or discuss 20 years of experience. So I would try to keep it as simple as possible. And I see that yesterday we had around 70 participants. Today we have around 55. That's still a good number because that means the 55 who are there are people who really want to do something about the problem. So, good morning to one and all of you. I come from this beautiful place, Kochi, Kerala. And those who want to follow me, I am on Facebook as this name is a very singular name. So, I don't think that spelling can get you anywhere else other than to my Facebook page. So, that's a joy. Otherwise, my website is drtatustmjcare at gmail.com. Okay. And so that's with that, let me just not waste much time. So we have a familiar problem here. All of us from different parts of the world have been talking about this. And it reminded me, these slides, by the way, were mixed up yesterday evening after hearing the other speakers. So we are like those 6 blind men. And imagine, even if they are not blind, it's their perspective that matters. One is holding the ear, so he thinks the entire thing looks like that. One is holding the trunk, his perspective is something like a snake or whatever. So it's about perspective. TMJ, I understand it's caught up a lot of interest quite recently. Now, that interest is very good because there are a lot of patients who are really suffering. Developmentally, as you see, the jaw sizes have been shrinking for ages. There is ample studies that suggest that. But the tongue size, luckily for all of us, we have not ceased to use the tongue. Of course, the new mobile phone is something that will stop the usage or reduce the usage of the tongue. But that is not in our lifetime. Maybe in another lifetime, people will have to wonder about those. But right now, the problem is very simple. The jaw sizes are shrinking. So the tongue doesn't have enough space. And when I cleared from Dharwad, Seema Kurup was my batchmate. So when we were studying most of the cases, we were thinking in terms of macroglossia. Sorry, and but actually, it's not macroglossia. The tongue size is normal. It's just that the cage for the tongue has become very small. That is essentially the problem that I see in most of my cases. Okay. So from this may be a problem because all of us are seeing this different perspectives of the DMD. Now, to all the novices or people who are really keen or learning about all this, don't take just one perspective. I would recommend you go through all the 6, you can call it specializations in the TMJ dysfunction correction or management patterns. Like Dr. Chino said, there's trigger point injections, there's physiotherapy, there is orthopedics, there is neurology, there is lifelong medication, there is surgery, there are so many options. I don't say follow all that. But as Dr. Mrinalini said, I am an oral medicine radiologist, so I prefer to be conservative. I don't like to do brush treatment. And my teachers have been my patients, essentially. Some of the patients who come to me, I've been able to properly diagnose thanks for my teaching from SDM Dharwad. So we could do the diagnosis properly As Dr. Okeson's textbook says, the diagnostic part was comfortable. We could say it was an ADD with reduction, without reduction, stuck disc or whatever. But then I realized that nobody was actually treating it. When you say you've treated an TMD, you should have at least 5 years or 6 years. Like even cancer says 5 years is good enough to be accepted as successful treatment. So when your cases are more than 5 years old and asymptomatic all those years and continuingly asymptomatic, that is when you talk about it. Okay, this is my principle or my policy. So most of the cases that I'll be showing you are old cases, and I have very old cases. But the problem was in those cases I lacked enough of documentation. So either the case record is missing or they're just questionnaires. So I needed data. Now, what can I leave as a legacy for the next generation? When you think about it, I cannot leave a set of questionnaires. I cannot leave a set of papers that say that, okay, patient came with a 9-point symptom chart and then now is 1 point. And that is arguably, can be distorted or may be distorted. But if I can set data, like this is what we need, this kind of things that we are looking at, then that is where I think I will be more successful. And so, if I may sound a little bit brash, technology has always helped us. Technology has always been helpful. Now, can we say CT scans or MRI scans because of their MRI for its cumbersome nature or CT for the radiation that has happened did not help? It did help. Absolutely, it did. Every technology that is developed in the TMJ field too has developed over years. Now, the problem is these are still expensive because the cliche of people or the niche of people that are using it is very limited. The moment it increases in number, the cost prices all will come down. Now, for those who feel, I don't want to spend so much, um, you are looking at yourself. You just want to see how I can finish the case. Okay. But I would like you to look more, this thing. In fact, I have all the equipment that is most of it that has come into the market. Kinesiographs, I have the TENS machines, I have the EMG machines, I have the T-scan. I do all this. Now, another problem with these machines is there is a big learning curve. In fact, for T-scan, I think some of the trainers itself have asked me, you're attending now almost the 13th course in T-scan. And to be frank, I always like to see there must be something that I have missed out. If there's one word that comes out of a meeting or a thing, then that may be useful to few of my patients. That is more important. So I appreciate everybody who's joined in on a Sunday morning here. So the simple solution to that other problem is if all the six work together, then we can lead this elephant to a destiny that is useful for the next generation of physicians who are coming in to treat this problem or understanding this problem better. The measure of intelligence is the ability to change. Of course, you know who's there on the screen. He was never a great student. That's why I like him. I love him because he was always inquisitive, and I think that's the only trait that I share with him, and I'm very proud about that. Now, this is a statement that I've created. Okay, it has gone well, and it has not gone well with a lot of my colleagues. If we are the ones best capable to treat it, then we must have created it. At least 70 to 80% of my cases, I have seen that it was created by us dentists. Okay. Now we have to unwrap it or unseal it, and most of the time, majority of the problem that I see is retraction orthodontics, where there is serial extraction and retraction of the dental teeth. Even now, I think 90% of the orthodontists do that. I don't know, because you are not looking at the tongue space, you're not looking at the airway, you're not looking at the posture. Yes, you would have successfully completed a beautiful set of 28 teeth, or if the wisdom teeth are already gone, 24 teeth. Okay. So, but Problem is this patient has landed up in neurology. This patient has landed up in psychiatry. This patient has landed up in chiropractic. So, but they'll never come to you because they never knew you were the etiologist. Okay. These are some of my teachers. You can see they're from all over the world. This is Russian. It's an Italian. This is Dr. Rajesh. He's an Indian. This is Julia from US. Patrick from Canada. Prabhu from US. Curtis from Canada. Vikas from Delhi. And this Fatso is me. Okay. Now, to show you some few data, I spoke about data. So just to show you what changes do we do when we do neuromuscular dentistry. I went through all these schools, all these 6 schools that you're talking about. I have been to all these schools, and most of the questions that I couldn't understand, it's probably my ignorance, because as an oral medicine radiologist, it's not easy to learn occlusion. Okay, it may be my ignorance, but what I realized is so many questions remained unanswered. And for me, luckily, neuromuscular gave me all the answers, and I was able to go through all these with zeal. Okay, and I'm very glad that I took up this science, and probably that is my I told you my guru's persistence. And those are my patients who persist with me and say, at least you could palpate where I had the pain. The guy you sent me to treat them didn't even know where to touch. So that's how I became, as Dr. Mayakar yesterday said, I wouldn't call a specialist. Uh, I look specially into neuromuscular dentistry. Okay. So you can see there's the tongue posture was bad. This is a 76-year-old gentleman who came. He's a Malayali from Kerala, but he's working in Dubai. He had a few lost teeth, and you can see his dentition was quite bad. I'll show you if the other pictures are there. He had a restricted airway. Now, the minimum area that I've seen across, I don't know if there are many articles, but what I've seen is when it's 30 cc volume, cubic capacity, you have a decent volume. Okay. And when the minimum area is about 200, you have a very decent, and the max should be at least 750 above. So there is a restriction here, but not that severe. But the tongue posture was bad. Plus, look at the neck posture. It is a reverse curve. It's kyphotic. Okay. So, but the same patient after treatment, I didn't do much. I just put neuromuscular position. I repositioned the mandible with the appliance and got where it should be. And you can see how the shift in the jaw position and the tongue and how the areas have all improved. You can see this has become 39, 449, 719. And you can see the change in the neck architecture. Now, this is a 76-year-old. I cannot perfect it, but this guy has been asymptomatic for over 6, 7 years. Whenever he comes to Kerala, he does visit us for some scaling and all that. And yeah, he came with all the problems. This is a testimony in 2019. But this patient was lost to follow up, I would say that, because he couldn't come back due to COVID. And and actually, I don't know. And once one of my colleagues contacted him, he said he was asymptomatic and he's still carrying on with the orthosis. But I couldn't finish this case, I have to tell you. But I liked the way he spoke to me. Is the audio clear? Is the audio clear?
Yes, sir.
Yeah.
Yes, sir.
So I'll just skip through a little bit because I've been limited to 20 minutes. So let me just, what he liked about were the mechanics. That's why I put he was diagnosed with trigeminal neuralgia. He was on medication. So we just gave him an appliance, okay, neuromuscular orthosis, and
Sir, it's not audible.
oh, that's what I was asking. Okay. Okay, I'll just quickly go through. He was asymptomatic in a month's time. Okay, and that's and he liked what he's an engineer, so what he liked was the machinery and the equipment and the measurements, because in our place we don't keep patients in the dark. We always tell them what to expect, and in fact the treatment plan is entirely explained before I take them up for treatment. And I don't take them up immediately for treatment. I send the entire details, whatever clinic, chief complaint, clinical features, radiographic features, diagnosis, what is the treatment plan. The entire thing will be written down in a mail and sent to the patient, and they have to confirm they have received it, because that is also a consent. Okay, this is how I've been. You cannot just say that I didn't know anything, because you already had the email. Okay, so all these ways, other than the specific concerns in the clinic, we also do this, so that it's a foolproof method, so that you don't have any problems. And one more thing is, when you forget, a few things about this patient, you can always, get back this email and maybe rethink, as some of the earlier speakers were saying, to step back and see what we missed out. So those are the different ways that we do in our setup. Then most of us think that it is usually the 40, 50-year-old people who have problems. Now look at this girl. She came with her jaw totally shifted to the right. So in our assessment, the mandible was of optimal size, balanced on its end. Maxilla was okay. So the problem was a disc indifference. Okay, so we did this is a TENS machine, a small TENS machine. And this is another girl who came, she's 10 years old. It's a weird complaint. She wasn't going to school because she had backache. And I don't know how they landed up in my place, but before that, they had landed up with all you can expect physiotherapy, all those things. And in those days, this is very quite, I think 5 years back. And so I gave her an appliance which was neuromuscularly balanced, and you can see how the shoulder. Because I like this photograph because she always wears these garter belts, and you can see the shoulders droop to the left and see how balanced it is. And we didn't do anything other than wean off the orthosis. She uses it and then comes off the pain, and the disc is recaptured, and so was her back and the entire posture. And then she was discharged. That's it. So we didn't do much involvement. But I think I gave her a myfunctional appliance when she was around 12 or 13. I use Myomanchi, which is imported from Australia, and it's only locally available in Australia. So when somebody's traveling, I ask them to get some sizes, and then I give them to this kid. So I don't generally like to start with ortho or run amok with all kinds of treatment. But we start off with something like this, see if the problem is corrected, and most of the time it does. So I don't think I've been searching elsewhere. This itself has been giving me enough of solution. And this is a patient who sent with postural dystonia. I'm trying to show you different cases. How we've treated at least 8 to 10 cases of burning mouth syndrome with neuromuscular orthosis. In fact, one of the patient didn't want to do the second phase of orthodontics or anything because she thought I accidentally got her corrected. So she didn't want me to do another accident and get her back into the burning mouth. So some of them are lost to consults with like that. But anyway, I appreciate their concern, and considered as a treated case. And they've not come back for 5, 6 years. So I guess either she's no more, or this is a very elderly patient, but or she's asymptomatic. So this is postural dystonia. She sent this from her shop, ski shop in Austria. This video, you can see how the postural dystonia takes place. So we asked her if she can come over, we can try. Now she had done all kinds of treatment in terms of DTR and medications and supplements and everything. And her body was evaluated for biochemistry, and everything was fine. So she didn't have any clue. So when we saw her, we saw that it was a postural issue coming out from the bite, not not teeth alone. I'm talking about the way the jaw were related. So we did a tense, and you can see how stable she is immediately after the tensing. So just half an hour of tensing. So this is the kind of results that we are speaking about. You don't expect all cases to have this kind of results. But most of the time, if you are spot on, then absolutely you're going to see this kind of magic. And I encourage all of you who are here to take it up seriously, because as I told you, evolutionarily our jaw sizes are shrinking. So there will never be any dearth of patients who have these problems. So I think it's the earlier into the boat, the better. So this is Jeevan. He came with trigeminal neuralgia. And he was actually sitting in my waiting room because he was fed up of medications and 8 years of trigeminal neuralgia. And he had medications enough to, calm an elephant. But then we put him off these medications, and he has completed his treatment. It's been quite long, at least 10 years now. But luckily, I could find these videos. If you can't hear the audio, I'm sorry. There's something technical about it. But then he's just sorry about the plan, the local patient. Anyway, this video can tell you that it's a trigeminal neuralgia. But 2 weeks into an appliance, and you can see how he comes back. He has the orthosis in his mouth. You can see he's off medication as well. He was so frustrated that he just stopped having. I never advised him. He just stopped having by himself. Okay. Then this is a dystonia case. I used to work in Sri Mugambika Institute in Kulashekaram, close by around 6 hours from my place. So this is how the patient, this was referred from neurology to physiotherapy, and both of them said they couldn't do anything. So they referred it because she didn't have teeth, they referred to the dental department. Luckily, oral medicine is the first department they come, and I was sitting there. So this is how she presented with cervical dystonia. Okay. And this is after 2 sittings of TENS. You can see how the dystonia has come down. But you can see, of course, the ACM and all that are quite rugged and rigid. And this is Rocobado. I've not been able to go to Rocobado training, but I follow him closely. So whatever little I learned from him, I've been using at wherever possible. I do neck stretches, I do manipulations, I do adjust, I do dry needling, I do trigger point injections, I do almost everything that is possible. And first thing is to earn the trust of the patient. That's why I do all that. Those are not solutions to a problem. Those are just quick fixes. Earning the trust of the patient. Once the patient trusts you, how are you going to finish them completely, asymptomatic for lifetime, preferably, but at least 5 to 10 years? This is what I've been looking at. So this is that same patient. You can see how the reverse curve, then kind of straightened out and fully lordotic after the Rocobado stretches. And she was asymptomatic. We had to give her just complete dentures because they couldn't afford the implant supported dentures, although I prefer implant supported dentures. Moderator, please let me know when my time is up. I keep speaking, so you need to hold me when it's time. This is the kind of orthosis that we use, and this is the kind of bite. These are the palatal cusps. Okay, you can use tooth colored or clear. Most of the time, I prefer cleared ones. I don't like these colorful ones because earlier days there was only one shade, and it was too bright. So it was very obvious. When you use a clear one, it is not that bad. This is a DTR testimonial, at least 5 or 6, no more than 6, I think. This is an MBBS student. When we did the DTR, she has a retained canine. I presume you still can't hear the audio. So I'm just explaining what's here. So because she had exams during that season, my actual treatment was orthosis and Damon expansion orthodontics and DTR. But since she had exams, she requested if I can do DTR, and I did DTR, and she's been ever since asymptomatic. So this girl, she's almost completed PG, and I keep asking her, any problems, please to come back. Now, this is another nurse and for those who think, you don't need machines, okay, this is the way that we do it when we are in a place where they can't afford machines or do expensive treatment. This is a nurse who didn't have kids because of the headaches and neck pains, of course, you know how the family life is affected when you are in pain. And then the vertical you can see is lost here. It was a deep bite. Then we corrected it like this, and these are the final this thing. So these are for people who you don't want to do a expensive investment into TMD. These are your options. Okay, this is the LVI golden vertical, and this is how the entire thing is derived. Okay, if you can take a screenshot or something, keep it, it's useful, or check for LVI golden vertical and you'll get this slide. Okay. So in this particular case, it was at college, so no machines, nothing was there. So I saw that the vertical was really bad. So I just trusted my instinct. I just hoped that the yaw and roll of the mandible was not affected. So I was just thinking in terms of the pitch. So I did this calculation according to the golden vertical and gave her an orthosis based on that, and that's how we came to these images, and she's been asymptomatic, and she had two kids. And unfortunately, I left the college, but every time she had a kid, she came to meet me and thank me, but I was never there. And my colleagues are there who are, they were nice enough to call me and say she had come with one baby, and then after 2 years, again, another baby. And so this is how our work affects families. So neurovascular dentistry, earlier days, I would say yes, there were a lot of things that we just raised the vertical and we just, built big crowns and too much of work is being done. It's just for the money and all that. A lot of allegations were there. But actually, the science is so beautiful and sweet. And it's how we practically apply it in our cases. And this is how beautiful you can make a patient also. This is my cousin sister. So that's all. So we start with the problem. It was Costin who identified it, Costin syndrome. Okay, this we Costin 1934. These are all the different things. I'm just going a little bit fast because this slide is a very important thing. Now, why TMJ? Why is it so important? Have you thought about it? It is the highest joint in the body. There is no joint above it. Okay, it's the most frequently used joint. You will accept it because I saw my son, who is now around 23 years old, when in my wife's womb, the ultrasound, he was thumb sucking. Obviously, he has to use the joint to come suck. So as early as that, you start seeing these joints in function. So let's look at the force. A regular bite is 200 to 400 Newton force, but a maximum bite you can generate up to 500 to 700 Newton forces. Okay. Now, an elbow joint, these are from sports journals. Elbow joint, I think baseball pitchers, they studied and they found that it can generate up to 400 Newtons. A knee can, those are from the American footballers. The knee can develop around 600 Newtons. Spinal column and toto around 2,400 Newtons. So imagine a single bone that can create maximum force is the TM joint. This is very important because that is one of the reasons why we all have work. Okay. Now, the oral cavity being the primary intake unit in your body is exposed to all the environment and regular damage, repair processes in abundance. It's only prudent to expect damage, repair, and symptoms. Now, definitely, that is another reason because the oral cavity, you have restorations, you have fillings, you have crowns, bridges, whatever, orthodontic work, and whatever, a lot of changes take place. Unlike, let's say, the foot. How many people undergo foot surgery or foot orthotics, accidents that have hurt the feet? Are very limited to the amount of dental treatment that you've done. So that it is only prudent to expect some damage there. Now I've started thinking a little more into the oral cavity. I've gone to the tongue. I've gone to the airspace, the volume. All these are very important, and these are directly linked to the postural chain, and that is studied. So these are lever principle. I just skip some of these because class one liver is, dental textbooks tell us it's our masticatory system is a class three liver because they have not considered these muscles in the posterior neck, okay, or the SCM or temporalis or trapezius or scalenes. None of them were considered. So, but I consider this as a lever one, and this is how your head, all this you would see throughout these lectures today. A forwarded posture, how much of pound increase happens, and this is the classical thought. This was the fulcrum, this was the load, and this was the effort. So this is why they used to think in terms of a lever 3. But I prefer to call it a lever 1 system. Okay. Okay. Let me go. So there is something called the closed chain kinematics. I think Dr. Sandesh was speaking about it. When you know if there is pain here, and if there is pain here, then you will know where else the other pains are. That is closed chain kinematics. I'm just going through the motions. I'm using Janet Travel as a beautiful textbook and a beautiful lady who did research on that. She worked along with the father of neuromuscular dentistry, that is Dr. Jangilson. So I know her in those terms because her work, textbooks, everything we've been going through. So I've been trying to link all this, but quantifying it or presenting it as data is going to be difficult. So we are just string puppets, or you could say marionettes, to be more precise. Yeah, the line of gravity is very important. This is how your posture should be. If you have a pelvic tilt or something like that, then and this is also an image to tell you there are two ways that you can have a GMD. One is a descending order, that is what majority 90% of the time happens, and that's what I've been talking about. That means from the TM joint downwards to all these joints. Or it could be an ascending disorder from the feet upwards. So all these things you will get on the net. It's there, all these problems you can see. So what would have been ideal? The mouth. Now, this fellow, I like him because he was a cancer patient and he's become a superhero. He possesses accelerated healing factor, but he still has a mouth that is closed. I don't understand why. He's called the Merc with a mouth because he won't shut up. Okay. But again, like this, I don't know. It's a, or you can have this. And in fact, why I put this is some of our colleagues say you're chewing more on the right. So I think two patients, you should chew on the left. Do you think that is possible? You just can't do that because your brain has already mapped your right side as a better occlusal or masticatory efficacy, and it will not permit you to go to the left. Yeah, maybe one or two bites you can consciously do it, but the fourth bite definitely will be on the your preferred chewing side. So that is why, again, occlusal, why people say why T-scan, occlusion, BGR and all that. You need to make the body sense that as a 50-50, at least, or close to 50-50, so that you're comfortable in chewing on either side. That means your brain has no preference. There are patients who came to me with just facial asymmetry, and I had just adjusted the tooth, and that too even without the T-scan, just the papers. The only thing is I used from 8 microns up to 180 microns. So all the papers, everything is available. So depending on, as somebody pointed out, a high point or whatever. If you're talking about a high point, you should know that it is high, right? So how will you know that? You can't keep your pinky or your little finger there and get the bite and check whether it's high or not. So you need a sensor there. That is where T-scan and all that come in. So every technology, about technology again. Now,
Sorry to interrupt you, sir. We have a little bit of time.
sure,
Okay.
sure. I'm winding up. Just give me 1 minute to wind up.
Sure,
Okay.
sure.
So technology is good. Definitely, it's very useful. But unless you go through that, this is all the technology or the instruments I'll go through. Unless you go through all that, now this is the father of neuromuscular dentistry. And unless you go through all, this is all my sorry, these are all my CT images, okay, MRI, all that. I said, no, this is all the airway and all that. Okay, so we've done lots of studies with this. Okay, I'll just put you on my thank you slide before I wind up with my closing remarks. And always check for these lateral pterygoids. The lateral pterygoid muscle is attached to the lateral pterygoids for all the radiologists. When there is too much of cramping of the lateral pterygoid muscle, obviously the pterygoid lengthens. This is also an indicator for TMD dysfunction. Okay, so unless you buy equipment, like let's say I initially started off with the conventional, dark room procedures and OPG and all that. Then we went digital. I think Dr. Munal is talking about. See, whatever new that I feel is going to be useful for my patients. That's all. My patients, that is underlined. I will buy. Come what may. Whichever bank will give me a loan, I'll take it. But then I'll work my butt out to finish that loan. This is my motive. So this is my clue for being, efficient in your area. And then I went into digital OPG or SEF. Then we went into 3D. Kerala's first 3D machine was my CBCT. So like that, we did that. Now, after so many years of 3D images and all that, when I see a patient, even a panoramic that they get from wherever they have taken, I prefer CBCT. But if they come with a panoramic, I can understand what the CBCT image would look like. Okay, it's not necessary that I take a CBCT if I can get the data preferably from that OPG. So if I had to go through that learning curve to get to the OPG back, then likewise is your learning curve in TMD treatment. You have to go through all these machines, see them. I had a friend of mine who told me in 2010, I asked him how, he's a prosthodontist, I asked him how was the T-scan. He said it's a glorified articulating paper. Now, recently, in fact, today's 15th, I should be in Kuwait talking to a group of dentists there. But because of the war, I couldn't go. They didn't issue visas. He called me to talk about T-scan in that forum. Imagine how life changes or changes take place. So, being skeptical about machinery is not going to help you anywhere. Wherever you think you need to learn it and do it, please go ahead and do it. Okay. AI is coming in next. Now, if you are not better equipped than the AI, then God bless you. Okay. So thank you very much for your patient listening. I'm sorry if I've gone overboard. That is usual about me. But 20 minutes is too short for me. Thank you so much to the organizers and to all of you who had a patient listening. I would like to take any questions if there are.
So we'll take the questions in the end. Thank you, sir, for such a wonderful speech and such interesting presentation. And it was very clinically oriented and systematic. So thank you so much.
Thank you.
So moving ahead with our third talk of the day by Dr. Priyanka Sakwalkar. Dr. Priyanka Sakwalkar, a distinguished dental professional, completed her MDS in Oral Medicine and Radiology from MGV's KBH Dental College and Hospital in Nasik. She achieved the highest aggregate in her post-graduation, earning the Suraj Gupta Award and a gold medal at the final MDS examination. Recipient of the JRD Tata Gift Scholarship, Dr. Priyanka pursued her MSc in Advanced Biomedical Imaging from University College London in 2017. Subsequently, she was invited and received a 5-year funding opportunity for her PhD in radiobiology and diagnostic imaging, focusing on children's brain cancer research in the UK. Recognized for her outstanding contributions, she has received several research awards, including the prestigious Magna Cum Laude for the Best Research Poster at the European Society of Radiology. She is an internationally recognized speaker with publications and conference papers on TMJ, MRI, orofacial pain, and cancer imaging at esteemed organizations. I warmly welcome and extend an invitation to Dr. Priyanka to share her valuable insights on the application of low-level lasers in orofacial pain. Ma'am.
Hello. Yes. Thank you so much, Dr. Mrinalini, for your warm introduction. A very good morning and warm welcome, everyone. I would like to thank Dr. Nurul for organizing this session today. I will start with the quote of Julius Caesar. It is easier to find men who will volunteer to die than to find those who are willing to endure pain with patience. So pain is a very important topic, and today I will be covering different non-dental orofacial pain and not just TMD. And I will be sharing few very simple cases. So this is the case one. He was a patient with who was 28-year male, severe pain due to multiple ulcerations in mouth. He could not eat, and he was in severe distress. And this is a video showing low-level laser therapy in mouth ulcer. Patient was in severe pain, and so wanted to hold his own lip. He was not even allowing assistant to hold his lip. And with the low-level laser therapy, he got immediate relief of pain, and he was happy after the treatment. Now, this is another case where a 26-year-old female with inability to fully open her mouth since last 15 to 20 days. She could not open her mouth. She could not eat. OPG showed no bony abnormality. And on examination, this patient was having tenderness over right TMJ masseter, and she was deflecting her mouth to the right side. Mouth opening was 34 mm. And this patient was treated with low-level laser therapy. Around 0.3 watts was given for 30 seconds, and this was repeated 3 times over both the joints in open and closed mouth positions. And immediately, patient mouth was opened. There was no reflection, and her pain was relieved. So I have been treating muscular and joint pain, acute pain with lasers, especially ulcers and other oral conditions since a while now, and I have found it very useful. For patients, it has been like magical. Just by using light, pain disappears, jaw opens, and patients feel comfortable. Now, with this introduction, I would like to start my presentation, and I will be giving a broad overview of applications of this therapy in orofacial pain. Due to paucity of time, I cannot go into too much of details, but it will be a brief overview. So I'm Dr. Priyanka. I'm consultant oral medicine and radiology specialist, and having my own exclusive oral medicine clinic in Nashik. And I have done my MSc and PhD from UK after my MDS. Now, what is low-level laser therapy? Laser is the light amplification by stimulated emission of radiation. LLLT is a non-invasive light source treatment that generates a single wavelength of light. It emits no heat, no sound, or no vibration. It is also called as photobiology or photobiostimulation. It is believed to affect function of connective tissue cells, accelerate connective tissue repair, and it acts as an anti-inflammatory agent. Coming to the mechanism of action, this is the video I've taken from YouTube.
Uses a process called photobiomodulation to change the condition of damaged tissue by stimulating cellular metabolism, thereby accelerating the healing process. A large convex treatment head can be used to compress superficial tissues, displacing excess fluid and enhancing laser penetration to deep structures. As light pours into the tissue, photons will be scattered, reflected, and absorbed. Lasers operating in the near-infrared spectrum from 650 to 1300 nanometers can penetrate to deep tissue structures. Light that penetrates into the tissue can be absorbed by melanin, hemoglobin, oxyhemoglobin, and water. Energy from these absorption events will be dissipated as heat, generating a soothing warmth in the tissue. The primary target for photobiomodulation is the cytochrome C complex, which is found in the inner membrane of the mitochondria. Cytochrome C is a vital component of the electron transport chain that drives cellular metabolism. As light is absorbed, cytochrome C is stimulated, leading to increased production of ATP, the molecule that facilitates energy transfer within the cell. In addition to ATP, laser stimulation also produces free nitric oxide and reactive oxygen species. Nitric oxide is a powerful vasodilator and an important cellular signaling molecule involved in many physiological processes. Reactive oxygen species have been shown to affect many important physiological signaling pathways, including the inflammatory response. In concert, the production of these signaling molecules has been shown to induce growth factor production, to increase cell proliferation and motility, and to promote extracellular matrix deposition and pro-survival pathways. Outside the cell, nitric oxide signaling drives vasodilation, which improves microcirculation in the damaged tissue, delivering oxygen, vital sugars, proteins, and salts while removing wastes. These mechanisms of action have been proved by over 40 years of laboratory experiments using lasers of minimal power. The recent development of higher power Class 4 systems affords the clinician the ability to efficiently deliver adequate doses of light deep into the tissue.
So to summarize, low-level laser therapy reduces inflammation, it leads to pain relief, and it also promotes regeneration by stimulation of cell proliferation responsible for healing. So types of laser is again a very broad subject. Here I would like to just mention that low-level laser therapy lasers are non-surgical lasers. It might be the same unit, but we use different handpiece for surgical lasers and low-level laser therapy. And it uses a very low level of energy. Now, according to Poston et al., properties of low-level lasers are power output of lasers being 0.001 to 0.1 watts. Wavelength is 300 to 10,600, but in general, in dentistry, we use up to 918 nanometers. Pulse rate again varies. Intensity, dose of 0.01 to 100 joules per centimeter. This 0.01 to 100 joule per centimeter is a very large dose. In dentistry, up to 4 to 8 joules is sufficient in most of the cases. Now, there are other uses of lasers in different orofacial pain conditions. Lasers are very effective in oral ulcers. It is effective in oral lichen planus. In burning mouth cases, they are effective in post-extraction pain, muscular pain, neuralgia. And one very important indication of this low-level laser therapy is oral mucositis. Now, many of you might be aware that oral mucositis is a very debilitating and painful condition seen in patients treated for cancer. Patient cannot speak, eat, or at times they cannot even drink. Low-level laser therapy works wonderfully in these patients. Ulcers heal faster and patients start eating with very few sessions. Now, this was my case. This was old lady, 50 years old, and she had her radiotherapy few months back. So almost 10 months back, she had taken her radiotherapy and she was in pain, could not eat, but just few session of lasers and she started eating. If you could see the inflammation, this was before and this was after. The patient was very happy. Now, this is another case of severe oral mucositis. This patient was recently treated with radiotherapy and you can see bleeding, ulceration in his mouth. Unfortunately, he could not open his mouth completely after radiation since radiation fibrosis had set in. But with laser in all these areas, he felt very comfortable and he started eating very early. Ulcers healed very well after low-level laser therapy. Now there is a lot of focus on TMD in this seminar. Hence, I will speak a bit more on TMD. This therapy can be given specifically to the trigger points like trigger point injections, but this is non-invasive and non-painful. And you may use a broader handpiece or can give energy to the larger area instead of just trigger points. It is effective in reducing muscular pain. It has analgesic anti-inflammatory effect. It helps muscular relaxation and improves mouth opening in patients with muscular pain. Now, if we compare it with TENS, the studies suggest that multiple studies they have conducted and they suggest that low-level laser therapy is more efficient than TENS in cases with TMD. Now, if we are talking about splint, which is a very commonly used in patients with TMD, there has been a study where total 40 patients were involved and they were divided equally into two groups of the cases and control. And they were evaluated. The low-level therapy was applied to patients in study group 2 times per week for total 10 sessions. And patients in the control group were instructed to wear occlusal splints 24 hours per day for 3 months. And functional examination was done in these patients. And it was found that there was decreased tenderness to palpation in both splint and low-level laser therapy group. There was improved vertical movement in both splint group and low-level laser therapy group. And so this particular study suggested that this low-level laser therapy is as effective as splint in the management of temporomandibular joint diseases. And this study was again, this conclusion was again supported by another study which was recently carried out and published in the Journal of AIOMR, that splint and low-level laser therapy show equal efficiency in treating these patients with orofacial pain. Now, if we are talking about dosage or recommendation, I could find only one paper. It is a meta-analysis which has given the dosage or recommendation for using laser therapy. The laser therapy was found to be good in improving pain, mouth opening, jaw protrusion. What they have given is that wavelength of 400 to 800 or 800 to 1500 nanometer and dosage of less than 25 joule per centimeter square. What I found is rather we don't need to go up to the 25 joules. Only after 4 joule, 4 to 8 joule is sufficient for inhibition of pain. And up to 4 is generally used for nerve stimulation. Again, for arthrogenous TMGs, they have given diode laser and wavelength between 400 to 800 nanometers. For myogenous TMD, wavelength 800 to 1500 and dosage of less than 25 joules. See, whenever we talk about different dosage, it is more important that we focus on the dose that is delivered to the tissue rather than the nanometers of the laser unit that we are using. Because above 400, all lasers are generally accepted for low-level laser therapy as long as you are sure that you are delivering a particular dose. Now, advantages of low-level laser therapy. All the studies show that it is instant, it is painless, it is efficient in diminishing TMD pain. It is non-invasive, it is reversible, and it has very few adverse effects, or you can say there are no virtually adverse effects. It may also improve psychological and emotional aspects of patient associated with TMJ since it is instant and it is non-invasive. So this is a very promising modality for a different orofacial pain conditions. Now, contraindications, yes, there are few contraindications of this therapy. First is never use low-level laser therapy in the treatment in the primary tumor area. So if there is any ulcer or any wound where you are suspecting cancer, please do not use it because its safety is not proven in these areas. So even if you're treating oral mucositis, make sure that you are not irradiating the area of primary cancer. And it is also not recommended to use it in the region of thyroid glands. Now, there are controversies with the use of lasers. There is no consensus about the wavelength, duration, etc. Since all the studies use variable parameters, it is difficult to standardize this therapy. There is overall increasing research with low-level laser therapy, but it might take some time for this therapy to come into mainstream. Now, coming towards the end, the key to effective laser therapy is diagnosis, and diagnosis. So it is very important that you are sure that which ulcer you are treating or which condition you are treating. Then it will help you to decide the right dosage. It will help you to avoid complication, and it will also help patient to get immediate pain relief when used in the right patient with the right dosage. Now, take-home message, low-level laser therapy is very effective in different orofacial pain conditions. It is non-invasive, instant, and relatively less or no adverse effects when used properly. Thank you so much for your patient listening. If you have any doubts, if you want to get in touch with me, I am available on all these platforms. Thank you.
Hello, good morning, ma'am. I
Yeah.
have a question.
Yes, please.
As you told, ma'am, laser can be used in arthrogenous and myogenous pain associated with TMG.
Yes.
So exactly the point of application, ma'am, on the trigger point or up to the radiating area?
See, it really depends. There are two ways of treating it. You can use it. It depends upon which handpiece you are using. If you're
Okay.
using small handpiece, I've got one video. If there is time, I can show that video where they are using trigger point application, and I found it very good video. Unfortunately, I don't have documentation of my own cases.
Okay. Okay.
So if you have Yes, so if we have smaller handpiece, we can use it directly onto the trigger points. And if
Okay.
you're not sure of the trigger points and you don't know where to apply, then you can use broader handpiece. There are different handpieces with low-level laser therapy unit. And then you can use it in a general area where patient is showing symptoms or patient is saying pain. You can apply it overall over the TMJ area with the broader handpiece.
Okay. Thank you.
Thank you, ma'am, for such an insightful session. And in this very brief time frame, you made us all develop a special interest in this field. So thank you so much, ma'am.
Welcome. Okay.
Without any further ado, we'll move to the next session for today by inviting Dr. Ruchika Sood. Dr. Ruchika Sood, a prominent figure in orofacial pain management, operates a private practice in Mumbai, focusing on patients with orofacial pain, headaches, TMJ problems, and obstructive sleep apnea. Graduating in 2000, she initially practiced dentistry with roles at 3M India Private Limited and Fortis Healthcare. After a decade of professional experience, she pursued a full-time residency in orofacial pain and TMJ disorders at Rutgers University, earning diplomate status from the American Board of Orofacial Pain in 2013. Dr. Sood furthered her education with an interdisciplinary pain course at Jaslok Hospital, Pain and Palliative Care Studies at ANS Delhi, and a workshop in comprehensive interventional pain management in 2014. Recognized for her expertise, she received an award at the South Asia Regional Pain Congress in 2014 for a case presentation on exercise-induced analgesia. Dr. Sood is an accomplished presenter at national and international conferences, contributing as a reviewer to the editorial board of the Indian Journal of Pain. As an active member of various national and international dentistry and pain societies, Dr. Sood stands as one of the leading authorities in orofacial pain management in Mumbai. Her dedication and extensive knowledge make her adept at handling challenging cases in this field. So I kindly ask ma'am to lead the discussion and provide insights into the intricacies of orofacial pain. Over to you, ma'am.
Thank you so much, Doc, for the elaborate introduction. And thank you so much, Dr. Nurul, for inviting me here at this forum. I've been listening to varied thought processes. I think the whole meeting is about introducing the audience to a lot of different viewpoints. And what is is my screen visible?
Yes, ma'am.
Okay, all right. So we start by invoking the blessings of God Almighty, and may these 25 minutes journey with me be meaningful for all of you listening to me today. And my heartfelt gratitude to my teacher, Dr. Gary Hare. I am his student and living his legacy. He is the student of Dr. Weldon Bell, who is the father of orofacial pain, and my friends, Fernanda and Carol, because it was not an easy journey for me to be in a difficult position in a foreign country and still graduate. So I think we spoke enough about my trainings. Well, why I like to show this slide is because it is not one course, it is not one training which brings the results and prognosis. It's a lifelong process of learning and teaching each patient, each challenging case as a learning opportunity and raising the bar for ourselves. Okay. I'm going to walk through a few cases to establish the premise for orofacial pain management. So this was a patient which came with the chief complaint of pain in the auricular area from zygoma to angle of mandible, headaches, and neck pain. So there are multiple chief complaints. How did this problem start? It started during a festive event where patient had injury and has been progressively getting worse over 12 or 13 years. During this time, he has been to many specialists, but as you can see, there are 6 dentists. And he was referred to my office by an ENT surgeon. Okay, but so we as dentists need to develop orientation and eye for understanding orofacial pain problems. When we examined him, there were trigger points. There were findings with the temporomandibular joint. But we didn't jump for the treatment because these, though there are findings everywhere, doesn't mean we begin the treatment. We have to still go and look for the source of all these problems. We did the CBCT imaging, okay? We did not find the degenerative process, which is consistent with his pain. So though we have the findings, the degenerative changes are not like he has osteomalacia, he has chondrocytes or something to be talking about 8 on 10 intensity pain. So we investigated further. We did his ultrasound and found that there was issue with his thyroid gland. So, this patient has been with us till date. He had thyroiditis and lymphadenopathy because of consistent thyroiditis for I don't know how long. He was managed by the endocrinologist for this problem. And parallelly, we started managing his trigger points. So we did pharmacotherapy, we did the manipulation of the trigger points, and we did not choose to do the low-level laser therapy at this stage. Like the previous speaker very pertinently spoke, diagnosis is the most significant part of management in this field. So we chose to manage him with ultrasound because we know this is a therapy which can cause no harm to him at this stage where we began the treatment. And then we gave him an intraoral splint to stabilize the joint. With all of this patient saw relief after 10 to 12 years of suffering. And this is very, very long time back. I mean to say 6 or 7 years ago. Where it stands today is that once he recovered from pain, he wanted to get into bodybuilding. Okay? And he kept getting, he keeps trying it and he keeps getting into flare-ups. And please remember this point because towards the end, I'm going to elaborate on this. Like, please respect human body. This is a message I say to all the patients. Now, this is a case where patient is going to talk about her story. And
यहाँ पे जो दर्द है हाथ लगा के बताइए कहाँ पे कब से है
अभी 2 साल हो गए
So starting point of
नॉन
pain,
स्टॉप है ये
it
दर्द
started 2 years ago.
रुका बीच में ये दर्द
हाँ बीच में रुकता था 4 दिन रुकता है तो वापस इतना दर्द हो रहा है कि पानी पीने को भी नहीं मिलता है।
इन 2 साल में इस दर्द के लिए आपने क्या क्या किया?
गोली दवा ऊपर से मलम अंदर से सब कुछ लगा है बहुत सारा उसका गोली भी लेकर ताकत नहीं मगर वो सब है दवा सब
This
है
is also demonstrating the history taking process for
कैसे
the
जादू
audience.
एक दर्द दांतों में लगाने लगा था तो एक के ऊपर एक निकाल गई तो दूसरा निकालने लगा दर्द चालू हुआ फिर उसका तो ये दर्द निकाला दांत निकाला तो ये बहुत दर्द करने तो उधर का तो बहुत ही दर्द ही रुका ही नहीं।
जब चालू हुआ था तो ये क्या दूसरी साइड से चालू हुआ था? अभी आपको राइट साइड पे है ना? तो पहले क्या लेफ्ट साइड से चालू हुआ था दर्द?
एक ऐसा दर्द होने का
दांत से चालू हुआ था ना? सबसे पहले दांत दुखा
पहले सबसे दांत दुखा
और फिर उसके बाद वो
पहले सबसे दांत दुखा
उस दांत का कोई इलाज करवाया था?
हाँ किया था।
क्या किया?
मतलब वो क्या ये करके उसमें चांदी बोल के कैप लगाया था तो कैप भी उपटना पड़ा ऊपर में कैप लगाया कैप लगा के फिर उठा दिया फिर दर्द चालू हुआ।
ये जो दर्द है अगर मैं कहूँ 0 का मतलब है कोई दर्द नहीं और 10 का मतलब है असहनीय दर्द, तो आप इस दर्द को क्या नंबर दो? मतलब बर्दाश्त नहीं हो रहा तुम्हाला
This is the most difficult question for all the patients to identify pain objectively.
Zero,
So we have a lot of different types of pain measuring scales. And if somebody just cannot do anything, then we give them a plain line on a Vasco and ask them to mark it.
कायम दुखतं.
So does it hurt all the time? Yeah, here on, she will just shift to Marathi. So she had a complete, that's her mother tongue. So she couldn't talk in Hindi beyond this point. But the important point here is that we have to objectify pain. Her pain started as a toothache. She has been to dentists, couple of dentists. You can see she has total extraction done as it stands today. She's completely edentulous, but the pain has not got resolved and is shifting. So multiple interventions, have they induced neuropathic changes in this patient? Maybe a toothache with root canal treatment, or see, when we see the cases, we do not know where it began. It is the most difficult thing to diagnose an orofacial pain case when it walks in a dental clinic. That's where her patient's first stop is. But at that point in time, if we take a periapical X-ray and we see a lesion, that's when we do the root canal. If there is no periapical lesion, we do not do the root canal and we look for the source of pain otherwise. There are patients who walk in and say that dentist told me that there is no lesion and we should not do the root canal. But आपण try करू बघूया. Means let us try and do the root canal and see. Root canal is a neuropathic procedure. Should we indulge in that procedure to try if we can bring in the relief or not? Because that possibly can set into other types of neuropathic problems, which happened with this case. And it progressed. She had pain on one particular tooth, which was around 6 and 7. By the way, this patient also attempted suicide 3 times for this pain before she had seen me. You know what was her diagnosis? Her diagnosis was facial migraine. All it took was the right dose of beta blockers to get her out of this pain consistently. She rehabilitated, lived happily, kept coming back for the medication for 2 years, more than 2 years, I think. Got tired of taking the medicines, requested us for help to get her out of the meds. And that is, so stay with this thought and we'll talk about it towards the end. Okay. It's very important for us. Sorry, this is something. I am not moving this. This is moving on its own. Okay. It's important for us to know who is suffering from what. The personality type, the phenotypes, the genomic constitution, everything matters when we want to design the treatment plan for a patient. This is another case where patient had, we're going to walk through the entire history of this patient. There is sudden severe sharp shooting pain. Okay? It is aggravated by air and hair. NSAIDs brought relief, but in 2 hours. If this was neuropathic pain, can an NSAID bring relief to neuropathic pain? Yes, the secondary musculoskeletal pain induced by a neuropathic pain entity can be relieved by NSAIDs, but not the neuropathic pain per se. Neuropathic pain is not very difficult to identify because there are only 2 ways nerves stop, either by upregulation or by downregulation. So we just need to be focused on the history of the patient and get it from them. Patient visited the dentist who thought, because we see the wisdom tooth there, they may be the problem, let's remove them. Neurosurgeons did the interventional procedures, rhizolysis with absolute alcohol. Whatever medications were given are walking along, in this case, in the slides, and you can read. This brought relief for 4 years with recurrence thereafter. The pain complaints now were very vague, dull in onset. Okay. Another procedure done, no relief. We are going to walk this patient and see the change in the medications. So Tegretol stays standard, but we add more of amitriptyline, we add more of pregabalin, and we kept adding more and more meds and injections to bring relief to this patient. We can see this in the history. So then there is relief for few days with every intervention, and then the pain fires back. We run the blood panel for this patient, and there is change in the medicines to oxcarbamazepine and newer salts of amitriptyline, and then CT guided V2V3 ablation is done. No relief. This is when I think the patient sees us. Once the patient sees us, got referred to us at this point, and this is also many years ago case. I chose very old cases because I have consistent follow-up on them to talk at this room. These patients, she was extremely disturbed, mother of 2, was living only to raise the kids, was a carpenter's wife. So the survival instincts were fairly strong with her. Okay. There was nothing contributory in the systemic or medical history. There is mild redness that is visible along the teeth. Was it drug induced or was it really the pain problem? I don't know. We ran through the evaluation. There was nothing wrong with the joint per se. So with the provisional diagnosis of neuropathic pain, we started working on this case. We ran through the complete blood panel. Her final diagnosis was peripheral traumatic trigeminal neuropathy. We have guidelines which are laid for managing pain problems. And these are all guidelines. Guidelines are very essential for us to think through the cases. But there are many atypical presentations of cases. Atypical hemicranias, atypical neuralgic pains. We see a lot of them, but we don't see a lot of atypical facial pain. Because most of the pains have a diagnosis. So it took us 1 month to get complete pain relief for this patient. You can see on 29th day, she has reported 000 scores. These patients find it very difficult to think of their pain objectively. They can walk through their day because their survival instincts are very, very strong. And it is very easy as a clinician to be misled that they are not suffering as much. So objective analysis in these cases is extremely significant. The day when the patient says pain is 0, the pain is 0. So whenever in doubt, don't. If you're not sure of the diagnosis, please do nothing which is irreversible. No surgical procedure, no interventions with the bite, no reducing of the enamel, no injections. So what is it that an orofacial pain specialist is supposed to do if there are so many no's? There is a beautiful academy for orofacial pain, American Academy of Orofacial Pain. There are resources for all the professionals there to give us the guidelines. There are guidelines which are set by RTDC for us to read through and understand. There are guidelines by International Headache Association. These are the foremost authorities. The foremost authority for pain is IASP, International Association for Study of Pain. They do have a chapter on orofacial pain, which special interest group, which is on orofacial pain. So these are the avenues where we can go look forward for the resources for better training on orofacial pain. I do get people who want to come, shadow, learn. And you know what is the most common response I get? That is, this is too much. I have a simple answer to that. Orofacial pain is not a simple love affair. Orofacial pain एक जुनून है. वो इश्क है जो हर हद से पार होना चाहिए. It is only then we will develop the vision to integrate a lot of things. When we talk about neocare, we are talking about an integrative pain providing services. Why is it that when the day I started, we started with integrated services? Because one thing standalone cannot provide complete relief to every patient. And every patient deserves to heal. Every human being deserves to grow. You know, Ayurveda is a beautiful system. I think it is like the most complete system of medicine. The reductionist approach that we have with allopathy, where we look at symptoms and we want to have the cubes, we want to put it enzyme and substrate, that this is the symptom, this is the diagnosis. Rarely do we sit down and analyze why this symptom. But what is it that the goal of healthcare has to be? The goal of healthcare has to be preventive, it has to be predictive, it should be participatory, and it has to be personalized. It is only personalized care for every patient which can bring us the desired outcome. So, and Ayurveda calls it as Hetu, Ling, Aushadhi. So, Hetu is the cause. Ling is the signs and symptoms of every disease. Aushadhi is what we are giving as personalized care. For somebody, it may be Tegretol. For other person, it may be Duloxetine. For another person, it may be oxcarbamazepine. Why? Why is it that we are different? So we need to understand the pharmacology of each particular drug, understand each of our patients, and then apply it to them to bring them the required relief. According to Ayurveda, the pain is a shoe. So this is about cell membranes getting unstable. Once cell membranes get unstable, prostaglandins will start getting secreted. So this is like our acute pain. We deal with chronic pain. So that means patient has lived with it for that much duration. And the entire neuroendocrine process of that patient functioning is disturbed at that point in time. In allopathic medicine, we are talking a lot about functional medicine. And there are a lot of trainings available with functional medicine, which are very, very meaningful for any person who wants to pursue pain as a full-time career. These things talk about the same thing. So most of the chronic pain, central pain syndrome, pain problems, they become the, what you would call this, most of this mitochondrial dysfunction. So when we talk about mitochondrial dysfunction, same is the thing which Ayurveda is talking about as the metabolic disturbance. So whenever we are trying to, there is a beautiful shlok, Rogastu dosham vaishyam, dosh samyam arogata. We need to understand that. We need to understand the metabolic process of each patient. We need to bring relief from our understanding and then integrate it with physiotherapy, with counseling, with nutrition, with Ayurveda, with acupuncture, as per the need of that particular patient. Because it is very, very important to, we all heard of Vat Pitta Kapha. What is Vat Pitta Kapha? Vat Pitta Kapha are the functional units of body. Prakriti of every human being is decided at the time of conception. We need to understand it and count it for what it is. If a person is a Vat-dominated person, and you ask that person to exercise for getting optimal health, that person will definitely die because of the exercises. He's a Vata person. He needs more of calming effect. He needs yoga as a therapy. That's what's going to help them better. And how yoga works as I recently had a talk at Neuromodulation Congress at AIMS, and that's where we discussed a lot on these therapies with non-interventional modalities. How is it that they're working as the relief things? But we need to understand that this is the profile of this patient. This patient doesn't need exercises. This patient needs yoga. This patient has too much of sympathetic tone. So this patient needs singing, music as a therapy to get more into the parasympathetic zone. And then we need to keep calibrating. So chronic pain management cannot be done as a cause and effect thing. It is a time-bound process. We need to have relationship with each and every patient. We need to give them time. The first consult will take 45 minutes to 1 hour. And as time progresses and we get to understand more of our patients. Now, I've spoke so much about Ayurveda. This is not my domain. I have 3 Ayurvedic doctors working with me, but I need to understand what is happening in the case, so that as a captain of the ship, I know how to draw that synergistic plan for the relief of every patient. We spoke this much because yesterday I spoke to a lot of my colleagues, dental colleagues from Navi Mumbai, and asked them that I'm talking on enigma of orofacial pain. I chose this title because everybody I meet says what an enigma this field is. So what is this enigma? That's what I asked them. Everybody told me the prognosis, because patients never recover. In allopathic medicine, we say chronic pain is a field of management. But I say, from my experience of last 12 years, chronic pain can also be reversed if we understand the power of integrative approach. Patients of chronic pain live happily without much suffering if they understand their own problems, if they know how to manage their day-to-day life, and if we have integrative approach understood in the right way. Somebody wants to take it up and wants to design studies around it and prove it tomorrow, please, most welcome, reach out to me, and I would be more than happy to collaborate and get all of this published so it becomes evidence-based before I'm gone from planet Earth. Accurate diagnosis is the key. The conditions in orofacial pain are diffuse, non-specific, and there is a lot of referral. In the orofacial territory, referral is by convergence. So it's very confusing. We need to know our guidelines well and know how to connect those dots to be able to treat the patients effectively. As it stands today, most dentists do not treat orofacial pain problems. Either it is too vague, it's too ambiguous, and it stays the enigma. Because we need to understand, as general dentists, the process of differential diagnosis. If it is, pain is the chief complaint for which people come to the dental office, and 95% of it is dental pain. 5% of it, which is non-odontogenic, can easily be referred out to the specialist. But we need to understand that, yes, this is non-odontogenic orofacial pain. And that's about it. Okay? We need more orofacial pain specialists. We need more dentists who understand the appropriate referrals. With this, I don't know why my slides are going back. With this, I would like to thank my teachers once again, and my daughter, and my acknowledgements to my colleagues, my friends, and all the people who partnered with this journey, make me what I am, my students, who made sure that I was challenged enough to explain my thought process at all points in time. That's the challenge of talking online. You don't know Who got what? There are no videos to be seen. So guide me for what next.
Okay, thank you, ma'am, for such an insightful presentation. The cases that you shared were really interesting, and the topic, it was very comprehensive and accessible for all of us. So thank you once again, ma'am. We have a question that kindly share medicinal treatment for last patient of peripheral trigeminal neuralgia as it is recovered from gabapentin 450 mg, not by carbamazepine previously prescribed by neurophysician.
So carbamazepine is not the drug of choice for a neuropathy. For neuropathies, we will use a combination with duloxetine and gabapentin. And the doses have to be titrated. It takes about 3 weeks time for the drug concentrations to develop in any kind of neuropathic pain. And for this patient, we also used Tidal, which is a synthetic opioid.
Okay. Thank you, ma'am.
Excuse me, can I come in? I'm Dr. Mayakar here.
Yes, sir. Yes, sir.
Just for 2 seconds.
Yes.
Let me tell you, friends, most of you are dentists there. Ruchika works with me. What I learned from her is that she knows the insight of everything and she'll not overstep any of her diagnosis planning without talking to me. I've done my master's, but unless you practice your master's subject, you're not expert. So when I found her, I decided that I will do up to my job, which is required to splint and releasing the occlusion, blah, blah, blah. But when it comes to holistic approach of systemic, I just refer to her, I don't indulge, I don't get into it. The point to tell the youngsters is that you form a group of people who will integrate with you, your practice, and then you decide what I will do, what the other person will do, and both have to answer why he is doing so and why she is doing that. The end product is, and most important is patience. We had one patient we have been treating for a year and a half. Today, the patient's father he is big shot. And his patient's father is so good because both of us realize this boy has got a psychological issue and not, he just want to divert and have attention. The point here is, please have a holistic approach, go beyond pink and white, go beyond the pain factor to the brain factor, the psych factor of the patients, and treat them holistically. Thank you very much. I just wanted to share this because I'm experienced with her, and that's what I realize, that if the holistic approach for the betterment of the patient is good enough.
Thank you so much, sir. Thank you so much for your kind words. And friends, this is a fact. Dr. Mayakar is my life coach. And they say, what is the guru kyun dhoondte hain hum zindagi mein? Because we see some trait in somebody and we want to imbibe that. You very rightly said the case study is discussing about, if you check my Insta and Facebook, I have done recently a course in health consciousness, which is an amalgamation of NLP in healthcare, the Gestalt therapy. So counseling also has a lot of therapies. How do I decide which therapy is good for my patient? So I have done CBT, I have done RBT, I did all of this. So I can understand the presenting history of the patient and then decide what is the appropriate therapy, because every person gets trained in one thing. Someone who's good with CBT is not good with Gestalt. So we have to have a team of people. If I have a busy CFO as the patient, he does not have the time to come for a therapy session every alternate day. He needs the injections, which are good for 2 to 3 months, and he will come back for the next injection. So yeah, psycho, endo, neuro, immuno. That's the axis. Everything begins with our thought. So that's who is the prime example of that is the man you just saw. Listen to Joe Dispenza, listen to Bruce Lipton, listen to Deepak Chopra, consciousness, the quantum energy, the quantum field, the quantum healing. What is all of that? You see the 13 days ago bypass surgery, Yeah, how many of you would believe it? So this is the infinite potential of human existence. And this infinite potential keeps him as my guru, and I one day, hopefully, will imbibe it. Any more questions there?
No, ma'am. That's it. Thank you so much, ma'am.
Hello, ma'am.
Next.
I have one question, ma'am.
Yeah, sure.
Sure.
Ma'am, as you mentioned in the previous slides in management, trigger point modification, something. So what exactly, ma'am, can you just elaborate?
So there is a technique which is called as neuromatic. It is a manual manipulation technique where we make a knuckle out of like this, and they explain their quadrants all over the body. So that patient's trigger point manipulation was done using that technique. We did not want to go interventional because the root cause was systemic, right? Thyroiditis was the root cause of trigger point formation.
Right.
And also, when we did run the analysis, this was a Pitta Prakriti person. These people, their genetic wiring is for angiogenesis.
Right.
So they survive very well on high altitude. So we didn't rush for intervention. If it was a Vata person, we would have, there's no harm in doing that intervention.
Yes. Thank you.
Thank you, ma'am. Our next session is on the diagnosis and management of TMJ disorders by Dr. Tawfiq Bohra. Dr. Tawfiq Bohra, a distinguished oral and maxillofacial surgeon with dual fellowships enriching his expertise. His first fellowship, specializing in cleft and craniofacial surgery, was obtained from CCI. Additionally, he holds a fellowship in TMJ arthroscopy and total joint replacement surgery, TMJ mini residency from the University of Maryland. A certified practitioner of pain medicine affiliated with the British Pain Society, Dr. Tawfiq Bohra currently serves as a consultant at SL Raheja Hospital, a Fortis associate in Mumbai. Leading the cleft unit at Raheja Hospital, he undertakes all levels of TMJ arthroscopy in his private practice. Dr. Tawfiq stands among the pioneering maxillofacial surgeons in the country, having completed the prestigious TMJ mini residency program in the USA. He is recognized for his groundbreaking work incorporating lasers via arthroscopy in the management of TMJ internal derangement. We are honored to have you here with us, sir. Please share your expertise on the diagnosis and management of TMJ disorders. Over to you, sir.
Hello. Thank you for inviting me at this particular platform of orofacial pain. I guess most of us are talking on orofacial pain and the management. I will differ a bit and will be talking more on the intra-articular issues of the TM joint. These are my associations. I hope my screen is visible and I am audible as well.
Yes, sir.
Thank you. So I am a practicing consultant at SL Raheja Hospital for odd 10 years now in the field. I have majors in cleft, as ma'am said. This is a day where I was proud of receiving my residency. This is my group that we practice at SL Raheja Hospital. I'll try to be extremely crisp and to the point with my presentation. TMJ disorders, my role today on this platform is to talk about the orthopedic perspective, the surgical and the orthopedic perspective, how we look at this joint. I heard a lot of eminent speakers yesterday, right now, Dr. Sood giving us a lot of insight on orofacial pain management and on the extra-articular issues and myofunctional pain management, neurological pain management, which was actually an eye-opener. Here, I'm here to discuss about the anatomy function. Most of us are knowing the anatomy and function, so I am going to skip through those slides. But what I actually want to discuss is biomechanics, adaptability of the joint, and what are the treatment options we have today. Anatomy, we all know about the disc, condyle, we have an eminence, we have fossa, we have the muscles supporting the joint for opening and closing, set of muscles. Articular disc per se is a very robust structure. Why I say this is because we actually open the joint And even via arthroscopy, if you want to penetrate the disc and come out, it is absolutely not simple. So it is a very robust structure. It does not give up that easily. Even the lining of the joint is extremely robust and also supports a lot of remodeling in the joint. We all know about the set of muscles that help us in opening and closing the mouth. This is particularly a video of anatomy app, and why I included this is it shows exactly the moment, the disc positions, and the trajectory. They were on point with it. The lateral pterygoid muscle attachment. And this is precisely the reason why majority of the disc displacements inside the joint are anteromedial. Moving over to biomechanics and adaptability, the way we look at this joint, biomechanics is when the biological structures are functioning under mechanical laws. When we talk about the temporomandibular joint, what are we looking at is a harmony between the internal joint environment, the muscle activity, and obviously the occlusion. Muscle activity, the patient most of the times will come to the clinic, our office or our practice with excessive muscle activity, which the other group of patients would come with joint issues, and the rest of the patients would come with parafunctional habits, most of them grinding, clenching, etc. That brings me to the next fundamental rule that we follow is Hilton's law. Hilton's law states that the nerves that innervate the joint also innervate the muscles that move that joint as well as the overlying skin. This particular law brings us to the guarding effect. Most of the patients, when they come, since if at all, there is an anatomical difference inside the joint, there is internal dearrangement, which is not reducing. What is reducing, what is non-reducing has already been discussed. I will still touch the point. But if it is a non-reducing disc, it is a buckled or a folded disc. Now that joint is not anatomically normal. It does give a guarding effect to the patient. And most of these patients would complain of stiffness in the face in the morning. They're like, we feel difficult of opening the mouth. This full area feels stiff. We cannot open the mouth. And particularly that brings us to this law. How it happens? How does this small changes, anatomical changes inside the joint affect the entire working of the joint? We are looking at a disc and we are looking at an adaptive capacity of a patient. When there is normal load at the joint, why I say the point, why I do consider occlusion, because occlusion is a place where the force generates. So you cannot debunk occlusion. Yes, I would say that it is not a make or break situation, but yes, at the end of the day, you cannot debunk it because yes, that's the place where the forces are generated, which are further dissipated to the joint. And then comes the adaptive capacity of the patient. So it's simple. We all know about the inflammatory cascade and everything, what happens, hypoxia, dysfunctional remodeling. What matters is load equals to the remodeling capacity or the adaptive capacity of this patient. The more the load, and obviously the adaptive capacity keeps decreasing with age, and the patient lands up into a non-functional joint. This particular slide I would like to mention because I don't see a lot of focus being given to synovial fluid inside the joint. Whereas synovial fluid is the only medium for exchange of metabolites, as well as we all know that it lubricates the joint. But this lubrication is managed by the disc. There are two forms of lubrication which come into play. There's boundary lubrication when the disc is loaded, and there is weeping lubrication. The disc basically absorbs the fluid and then releases the fluid inside the joint. Imagine a disc displaced, a non-functional disc inside the joint. This fluid particularly is less. It is not in a position to generate this fluid. And what ensues is a stuck disc. Eventually, what will happen is there are going to be adhesions inside the joint, and there are going to be a stuck disc. The joint is not able to translate further, and eventually leading to a decreased mouth opening. And again, the guarding effect. Mechanical stress, parafunctional habits, disc displacements, joint overloads, trauma, everything leading to biomechanical instability of the joint, which eventually leads to a condition called as synovitis, adhesive capsulitis, or synovial plicae. Synovial plicae is a initial stage for chondromalacia. Plicae will eventually turn into chondromalacia, which will lead to impaired lubrication, degeneration, osteoarthritis, limited pain movement, and eventually Hilton's law.
This is until
This is a
this
video
is
which
until
probably
it is
everybody
placed,
in the field would have seen.
and it's
This
reduced
is
on
the
opening with a
reducing
click.
disc. Why I wanted to show this is because
One demonstrate with typical clicking, which implies
if that would be the scenario where the disc is constantly clicking, it acts as a speed bump every time. And yes, Dr. John mentioned that this is the highest used joint, which I do agree with him. And yes, if those amount of times this disc is clicking, eventually there is going to be synovitis inside the joint. How do we deal with it? Yes, if it's in the initial stages of the problem, yes, you can deal with it in however manner you deem necessary at that point of time. But at the end of the day, internal rearrangement is all about harmony between the joint, the occlusion, and the muscle activity. Internal rearrangement, everybody has gone through it. We have with reduction, we have without reduction. With reduction is when the disc on opening pops back to its position. Without reduction is when it does not pop back to its position, and that's when the retrodiscal tissue is technically loaded. Now, when this patient is constantly chewing or performing any activity, this retrodiscal tissue gets damaged and it bleeds. It will bleed. So why do I say this? Because it is going to bleed, and that bleeding is going to consolidate into adhesions at that particular point. And those adhesions will not allow the disc to pop back in position. The lateral pterygoid tissue shortens in length, and that is one more reason why the disc remains anterior. Internal rearrangement and biomechanical instability, the clicking and popping, muscles constantly adapting to the biomechanical instability, progression of symptoms, reduced mouth opening, headaches, musculoskeletal MPDS. We are currently into a study where we are studying these 20 sets of patients for around 2 years for the longevity of the treatment we perform. And what we have come statistically to a conclusion is that disc position is not that important as much as the disc function. The disc should be functional. Now, why do I say this? Because there is a lot of confusion, not confusion, but there is no proper set of rules that we follow that, okay, here we do this and there we do that. It is necessary to understand where to draw a line. It is a disservice to the patient to take the patient and operate the patient without knowing what is happening. But yes, it is also a disservice to the patient when he or she requires a procedure that can help them and keep them devoid of that procedure. Burden of diagnosis, idiopathic term meaning one's own, and pathos means suffering. In my humble opinion, information about the root cause is obviously necessary to make long-term changes, but sometimes initiation of the treatment, what do you say? It clears the fog. This is the head and neck region where a patient may come with a lot of overlapping symptoms. And sometimes just initiating one form of treatment just clears the fog. With a lot of other forms of treatment also follow these patterns. And sometimes knowing why it happened in the first place is in our field, considering surgery, why it happened in the first place is very limited help, because we have to deal with the problem at hand. At the clinical level, Mahan's test is something which can be done where you put a spatula at the patient's between and ask the patient to bite at it. On the same side, if the patient points of pain, it's MPD, myofascial pain, and if the patient points on the opposite side, which is actually the loaded side, then it's an interarticular pain. Trigger point injections is something which I regularly use in my practice because yes, it helps you immediately separate out the problem that yes, this is an intra-articular problem. However, one has to be very careful with these injections, because there have been instances where I have seen a little bit of motor block, patient unable to move the eyelid. So you need to be precise with the amount of fluid you inject. At our practice, we also go ahead and perform serology reports, which I feel has come to me from my orofacial understanding of the problem, where yes, systemic evaluation is necessary. We normally perform RA test, HLA-B, for juvenile reactive arthritis. The reason why this is mentioned, because nowadays the number of juvenile cases are increasing. Probably they were already there, but it's just about the awareness that patients are now coming up. ANA, CCP, I personally believe getting a thyroid profile and CRP values is also valuable to give you an insight of what is happening inside. Coming to the diagnosis part of it, MRI being the gold standard for the joints, we do go for CBCTs, but most of the CBCTs are always no patient. To be very practical, no patient comes to us at a stage where there is the joint is absolutely normal. So there are going to be changes. However, MRI points out a lot of points which are important for us to take a call. However, at this, I would like to say that I personally can read an MRI. I am trained to read an MRI, but MRI also is of limited value. There have been a lot of times where the MRI states something, and when we go inside and we see the joint per se, it's a completely different ballgame. There was a particular case where the MRI could not point out a 4 mm perforation inside the joint. That was a different thing that I had gone for an open joint surgery for that patient. However, if I would have gone with an arthroscope inside, I would not be in a position to do anything much about it. What are the treatment options? Treatment options, we have a lot of treatment options. The first things first, we reassure the patient, hot fermentations, pain management, muscle relaxants, anxiolytics. Anxiolytics have to be used with a lot of care, yes. But then they do play a role, at least if not in the pain, they would help in changing the pain perception of the patient. So orthotics, load management is something which we do in our practice. Orthodontics, occlusal interferences, pharmacology, physiotherapy, everything in the conservative realm of it. Most of our patients coming to us have already done this multiple times, and they have been not only to our dental colleagues, they have been to ENTs, neuros, you name it under the sun, and they have done it. Well, out of all the conservative management, I still stand by load management. And when I say load management, I would like to say we have Dr. Saurabh Shah in our team who technically manages the load management part of the patient. Why I say load management? For me, it is as good as managing force. The force that goes at the joint before my procedure or after my procedure. It is absolutely important. Like if somebody had to go for a knee procedure, not every patient is allowed to use the joint as they were before. They have to use a walker or they have to take rest. How would you manage that in the jaw? There were practices earlier of doing an IMF, which is no more followed. And it was even not rational at that point of time. So load management is key for longevity, is what I have seen in my own study. If you leave load management, the patient will relapse. However, coming to the surgical part, which is my domain, arthrosynthesis. Now, I get a lot of questions that why would you not do an arthrosynthesis procedure? Well, I have performed dozens of arthrosynthesis procedures. The point is that arthrosynthesis works well only in capable and experienced hands. Why I say this? I'll say that arthrosynthesis predominantly is dependent on encephалation of the joint. You push fluid inside, the joint encephalates. Encephalation means it's filled with fluid to an extent that it's completely bloated. That bloating of the joint is responsible for breaking off the superficial adhesions inside the joint. However, yes, you are flushing the joint at the same point of time, but flushing the joint is just a quick fix. Adhesiolysis, what is mentioned via arthrosynthesis, why now I'll tell you why most of us cannot achieve that kind of encephalation is because we multiple pricks. We do not get the outflow needle at the first go, so we prick it multiple times. What happens is, what we don't realize is that you have already made multiple ports, and now you're not generating that kind of pressure inside the joint, and hence arthrosynthesis is something. It is a blind procedure, but it does not even lead to an appropriate adhesivolysis. We have arthroscopy, prolotherapy with dextrose, bupivacaine for subluxation cases. Even we inject Botox under vision. Then comes to a traditional long-aged open joint surgeries with screw anchorage, open joint discectomies. Now we have laser discectomy, which is done via an arthroscope, and total joint replacements. When coming to the open joint procedures, I myself have performed open joint procedures, but I was even reluctant at that given point of time. Why? Because yes, in the initial stages of surgical development and the field, it was way aggressive to maintain a disc condyle relationship. Opening the joint used to sound very aggressive. Yes, even I used to agree with it at that given point of time, and we used to wait and continue the conservative management till the time the patient used to learn to live with the problem. But now, with the advent of arthroscopy and the technological advancements, as we are seeing in all fields, even the surgical fields are going ahead with their procedures. Now, using a minimally invasive technique, we can reposition the disc. We can get the disc back in position. We can deal with the synovitis objectively, definitely using lasers. This is the form of stabilization splint. These images are from my colleague, Dr. Saurabh Shah. He makes a simple splint which just manages the load, causes disocclusion whenever the patient moves from right to left. Forward, this is something which it does. Sorry. I'm sorry, not work. So when coming to conservative approach according to me works best for symptomatic relief in cases which are less than 6 to 8 months and are not anatomically compromised. The cases where the disc is still reducing and the patient still has a functional disc and there is no change in disc morphology. Now, when I say disc morphology, whenever there is a non-functional disc, you would expect changes in disc morphology. With that will ensue changes in the condylar segment. Now, when this patient comes to us and we go and we perform a procedure, it is very difficult to stabilize this joint because there is a lot of changes in morphology. So now stabilizing this joint becomes very difficult. And this particularly happens when the problem goes undiagnosed or unnoticed for a long period of time. Post-procedural arthroscopy management of the condition and masticatory muscle activity. The cases where everything is okay and it is purely an extra-articular problem. Obviously, in extra-articular problems, conservative approach works absolutely best. TMJ arthroscopy, we use a 1.9 mm scope, which is a 30-degree scope. This is what we do to technically perform the procedure. There is one port which enters the joint. It is a very technique-sensitive procedure. Why? Because we are working in a very small and a very constricted space. It's a small joint, and hence the steep learning curve. But yes, you have to go through that learning curve with a number of cases to understand this. However, I'll try to explain in short. There is a 2 mm scope that enters the joint from the post-glenoidal space. We go in, we perform a diagnostic sweep, and then we enter one more port in the anterior part of the joint, which serves as a port for us to introduce our lasers, introduce our working instruments. We are capable of introducing one more port. So in total, we introduce 3 ports, and we can also pass a stitch through the disc. So on the right-hand side, what the image you see, there is a there's a black dotted line, and that's the lateral pterygoid muscle. In cases which are long-standing, disc is folded, the disc is absolutely anteriorly placed, it's not coming behind. But we can go ahead and we can cut the lateral pterygoid muscle so that it reduces the pull at the disc, go posteriorly, pass a stitch, and then pull the disc behind. And then tie the knot, obviously. This is one case where I would like to show you. Sorry. That's my scope. I cannot see the. Yeah. So if you see this part of the scopes, this thing, what you see over here, the red RBCs inside the synovial joint, that's the joint. That's a reduced disc. This is the synovitis that we're talking about. This particularly is called as the creeping synovitis. That's a retrodiscal band of tissue, which is when the mouth is completely open. When we go ahead, that's the disc. And that's the movement happening on a reduced disc. That's the form of damage that synovitis does. This is a very good joint, I would say. We have seen worse joints than this, but that is a very good image of creeping synovitis. This is one more case. We've used again the same arthroscope. You can see the amount of inflammation inside the joint. This is typically a villonodular plica which had developed. This patient had a history of trauma. This is a villonodular plica which is there inside the joint, and you can see it has developed its own blood supply, and it is a painful condition for the patient. What it does above that is it does not allow the condyle to seat back in the glenoid fossa. It takes up that space. This is before lasers. We used to use graspers to hold the plica and to burst them open and then pull them out. And we've sent them for biopsies as well. This patient typically was managed by Dr. Saurabh Shah. We did load management. This patient developed a deviated jaw post-procedure. And Dr. Saurabh managed it with a deprogrammer for a brief period of time and then again put him on load management. That's how we pull the disc behind. There's post removal, and under vision, we have injected steroids. If you see the medial side of the joint, the medial rib, that is inflamed as well. This is one more case where I would like to show you a clicking joint. That's how it clicks under vision. You see the red portion of this is now a video with Holmim-Yag laser. Holmim-Yag laser is the only laser which works under constant RL flush, and that's how we go and we we ablate the synovial lining, which is causing pain to the patient. You can see the creeping synovitis going up the disc. The laser actually acts as an eraser. You can directly go and just erase it off. I would like to mention one more point over here. Scarring of the retrodiscal tissue to pull the disc back. What I have noticed in my cases is that we believe in superficial scarring, but superficial scarring does not work. It does not pull the disc back. You have to at least ablate half of the retrodiscal tissue, and then in turn it scars and it pulls the disc back. This is the lateral capsulitis. You can see the capsule bending up, and there is inflammation there as well. Now, when we touch these points and we ablate them, this patient is typically pain-free and does not have any problems. Again, a video showing how we ablate using the lasers. This is chondromalacia. The joint is severely damaged. There's a lot of synovial hypertrophy over there. And we can just point and shoot. and get rid of all the hypertrophied synovium over there. This is particularly a very good case. This patient itself is a laparoscopic surgeon from Delhi. He was referred to me by a doctor in Delhi, and this is severe chondromalacia inside the joint. His joint is stuffed with hypertrophied synovium. Everything is inflamed inside the joint. Since he was a doctor, he dragged the problem a little bit with a little more research and everything. Eventually, we scoped him, and now he's completely pain-free. And we have a follow-up with him for more than 3 months now. You see this? It's completely full. It's completely full. See the medial drape of the joint.
So actually we're running a little short of the time, so can you please conclude the presentation?
Just this one video. This is a huge adhesion going all above the disc. Why I show this? These adhesions cannot be removed with arthrosynthesis. They typically need to be cut under vision. And this is a full wall of adhesions which is going across the joint. I would like to just show in, this is a lateral pterygoid muscle myotomy. We've been cutting the muscles and going beyond. What does arthroscopy do? Arthroscopy not only just flushes the joint, but it will also allow to view the disc under vision. It enables the surgeon to perform all the pinpoint injections, perform adhesiolysis, and it also allows us to pass a stitch through the disc by involving a third portal, and also will allow in future, once we have the condylar shaver, to shave off the excess bone involved and deal with the joint. When we consider an open joint surgery, this is how we perform. That's again a clicking disc on an open joint procedure. And what we do is we go ahead and we put a Mytech screw at the condylar length of the joint, and we take a stitch through the disc, and that's how the disc functions post correction. We reserve our total joint replacements for ankylosis cases, tumors, resection, severe arthritis, avascular necrosis being the highest cause of joint replacements. Need not be said that TMJ, internal dearrangement, is not the only thing that we are dealing with. Joint replacements are something which is also done nowadays in India and is picking up. This is one of the cases where we have planned. This is a Pierre-Robin syndrome case where we are performing a concomitant orthognathic surgery, and we are also going to replace the joint. That's how we are going to achieve mouth opening for this patient, as well as with dental implants. A case of orofacial dystonia, which we had treated with Botox, kind of reaching this patient height. We went ahead, we injected 25 cc of Botox both sides, and again followed him with load management. A case of oromandibular dystonia, open mouth lingual dystonia, where the patient, when he opened the mouth, he lost control over his tongue. Neurologically, everything was normal. We went ahead, we under USG guidance, we injected Botox per side in the deep muscles of the tongue. Patient was sent for speech therapy and was doing well. However, entire speech was not recovered. Intercuspal pulse of the presentation. Intercuspal position may not always be the most musculoskeletally stable position for the condyle. Canine guidance is always better over group guidance. This is what we feel, because it loads only the temporalis muscle. Biomechanical stability of the joint is compromised when the relationship between the soft tissue bones is not maintained. Disc function, obviously, and morphology is more important than the disc position, and early intervention is best. In contrast to traditional concepts mandating the exhaustion of conservative treatment options, minimally invasive procedures deserve to be implemented as an efficient first-line treatment, provided you see some changes anatomically over the MRI or a CBCT. Thank you. In the end, this is what I particularly follow: anticipate, seldom improvise, stick to the plan, slow is smooth, and smooth is fast. Thank you. Thank you for allowing me to present at your forum. And I'm very grateful to Dr. Nurul and the entire orofacial pain community and the organizing team for inviting me. Thank you for your patience. Thanks a lot. I'm sorry if I've crossed the mark.
Thank you for such an enlightening presentation, sir. There's one question that which is the best imaging modality for TMJ, bony and fibrous ankylosis?
I guess CBCT. CT in all scales, and CBCT for ankylosis will give you a clear-cut idea of how much has to be excised and what has to be released. Fibrous ankylosis, I have scoped fibrous ankylosis joint and tried to release them. But yes, even after performing an arthroscopy in those joints, I would still say that an open procedure will supersede an arthroscopy. With arthroscopy, case selection is tremendously crucial.
Thank you, sir. Next, we have Dr. Varun Kunte. Dr. Varun Kunte, an MDS graduate in oral medicine and maxillofacial radiology, is the founder and CEO of Arthros, a leading center in Mumbai specializing in craniofacial pain, TMJ, and sleep disorders. Serving as a consultant specialist in orofacial pain and TMD across multiple hospitals in Maharashtra, he holds the distinction of being the only Indian doctor with a prestigious fellowship from the American Academy of Craniofacial Pain. Dr. Kunte is the first doctor from Mumbai to achieve the esteemed DTR certification, fellowship, and mastership in DTR under Dr. Benstock. He received intensive training in DTR from Dr. Robert Kirsten, the inventor of DTR. Additionally, he is the inaugural Indian doctor to complete the mini residency in TMJ and sleep therapy under Dr. Stephen Olmo's mentorship. A diplomate of the Orthodontic World Institute in Barcelona, Spain, Dr. Kunte is equipped with advanced biometric tools for treating craniofacial pain, TMJ disorders, sleep apnea, including T-scan, bioelectromyography, joint vibration analysis, 3D jaw tracker, quadratens, and many more. Established as a speaker and key opinion leader in the TMD and craniofacial pain field, Dr. Varun Kunte has conducted numerous lectures, courses, and hands-on workshops. I request Sir to share his expertise on dissolution time reduction, a novel method of treating myofascial pain. Over to you, sir.
Thank you so much. Thank you so much for inviting me to this August gathering. Good afternoon, one and all. So as Mrinalini has already introduced me, so let me take this opportunity to tell you all that I practice temporomandibular joint disorders, which are a part of orofacial pain disorders. They are not fully orofacial pain disorders. So temporomandibular disorders are a part of what I do, and orofacial pain, chronic orofacial pain, is what I try to help a lot of patients in my practice. But essentially, the focus of my practice is TMD, which is a part of orofacial pain. So today, let me take this opportunity to tell you that, a lot of my eminent colleagues have spoken about how complex the orofacial pain is and what should be done and what should not be attempted. As a dentist, I will tell you what simple procedures you can do to help patients. And disclusion time reduction is one of that procedure, which you can do for your patients to help them with their symptoms. So a quick disclaimer, is it the cure? Probably not. It's a management strategy. Is it like a Ramban Upai that you do a DTR for every pain case or every TMD or every chronic orofacial pain case? Absolutely not. You have to pick and choose. You have to select cases for DTR, and DTR can only help reduce the load on the masticatory muscles, and that's it. If the patients continue to clench and grind their teeth, if patients continue to have elevated sympathetic tone, if they suffer from stress and anxiety and chronic neuropathic and neuroplastic pains, then DTR is not the management for them. So DTR is for management of simple myofascial pain, and often it is combined with other treatment modalities to help the patient, like flat plane occlusal appliances, like sleep apnea appliances, or maybe a daytime appliances like Dr. Tawfiq spoke about, or disclusion appliances or a simple stabilization splints. So DTR as a standalone treatment modality may work in selected cases only, and you need to know which cases are to be treated with disclusion time reduction. So we are going to see this DTR in 3 parts now. I'll be keeping my presentation short and sweet. DTR is basically disclusion time reduction. So these 3 parts will be, first of all, what is DTR? Second, how do you do it? And third, what are the do's and don'ts of DTR, right? So before we proceed, it's very, very vital for you to understand what is disclusion time. So disclusion time is that time which one requires to cause separation of posterior teeth when one is achieving canine guidance. So it is separation of posterior teeth while you achieve canine guidance. That is DTR. So all of you know that one is usually recommended to have canine guidance. So canine is being separated here and canine is engaging and the posteriors are separating very quickly. So according to Robert Kirstein and his studies, he observed many cases with myofascial pain and not myofascial pain related to systemic disorders or not TM joint disorders, but simple myofascial pain cases. He noticed that these patients have lost their canine guidance. There is a group function, and due to that group function, the disclusion time, amount of time you require to separate your posterior teeth, is increased. And in some subsection of these cases, the muscle activity was excessive. That means in order to perform these basic movements, patients were utilizing excessive amount of muscle activity. So that is what Dr. Kirstein suggested, and he called it mechanism of muscular hypercontraction. That means if you are chewing your food or if you're moving the mandible to the right lateral excursion or left lateral excursion, and if there is significant friction of the posterior teeth, your muscles require more activity, and that activity is generated through anaerobic respiration. Byproduct of anaerobic respiration is lactic acid built up. Lactic acid is directly related to pain. So all the posterior teeth have mechanoceptors in them. You can definitely check it yourself. You can keep all your hands on the masseter and temporalis and try and clench. And as you clench, you would see that the muscles are getting recruited. So what recruits your muscles is the way your teeth come in contact. That is where the muscles are recruited. So if you control the way your teeth come in contact, the muscle load is also reduced. Now, we must understand that how do you do DTR? So first of all, whenever the disclusion time is increased and it is causing excessive muscle hyperactivity, then you can go ahead and build the canine. Yes, you can build a canine guidance using composite, and you can cause smooth disclusion of posteriors. So DTR is nothing but immediate, complete anterior or canine guidance development. Smooth disclusion of posteriors without any grinding is also okay. So as opposed to a common criticism for anything related to occlusal calibration is that irreversible or you have to grind your teeth. So it's actually not. You can actually do a lot of cases of DTR with just addition on the canines or building an anterior guidance using composites. Patients not okay with it, you can grind it off. Absolutely. Right. So how do you do DTR? So I often get these questions. Are equipment absolutely necessary? No, they are not. They're not absolutely necessary. You can do a DTR even with your regular methods like waxing up and the building the composite using those wax ups and building the canine guidances or anterior guidances. So these are all the traditional methods in which you can do it. You can treat majority of cases that way, but if you want to get it, if you want to do it accurately, and if you want to pick and choose your cases, and you want to be very, very sure of what you're doing, then equipment are your eyes. Okay, equipment will tell you which are the cases which will actually get benefited with DTR and which are the cases will not. And the equipment will help you throughout when you're carrying out these cases. Okay, so there's one equipment called as TechScan, T-scan, which studies the occlusion. A lot of doctors think that this is meant for TMD. No, it's not. It's meant for dentistry. It's meant for general dentistry. Some of us have used it for treating cases of TMD for calibration of the appliances, for calibration of occlusion, etc. EMG is basically electromyography, which will study the muscle activity. I will show you one case. Due to the paucity of time, I'll show you just one case of a dentist, and there you will see EMG readings. So all of us are familiar with Dawson's point occlusal contact. So Pete Dawson also says that you need to have point occlusal contacts and not too much of surface contact in the occlusion. So DTR essentially says that you need to have good occlusal contact, point occlusal contact, and anywhere there is there is excessive friction in the occlusion, then you can think about calibrating it. Okay. Now, where would you typically calibrate it? Is not on the cusp tips, not on the cusp tips. Do not change patient's vertical. Only on the inclines where there is excessive contact, and the calibrations are actually in microns. They are about 30 to 50 microns, as low as minimally possible. And often these calibrations are not required, because if patients have lost the canine guidance, there's no need for grind somebody's teeth. You can actually go in, build the canine, and a lot of times these adjustments are not required. Right? So we need to understand that when we talk about irreversible methods, we are talking about microns here. Nobody in their right minds with the right training about DTR would grind teeth unnecessarily and flatten the occlusion. Absolutely not. Nobody will change the shape of the teeth. You have to respect the natural anatomy of the teeth. So during my training, when I learned DTR as a first treatment modality, and I thought, oh, that's great. This is great. And I would try and help every patient by doing DTR. And yes, I've done my fair share of treatments that way. And as soon as I realized that it's not the right way. DTR applies to a very minor subset of population, but it's an effective method in the effective hands. So as I've said, DTR is occlusal calibrations in microns and not millimeter. And if you want to do any adjustments, I recommend that you do it under the able guidance of equipment. The equipment are not needed for diagnosis. They are only required for evaluation. So you may have it or you may not have it, but it is recommended for anybody who wants the certification or a mastership or fellowship of DTR is they should have the equipment, so that a lot of wrong treatments are prevented. And more importantly, DTR can be addition and not just grinding. So very important that all of us know that we need to reduce the disclusion time, which is very high in these cases. We need to get it back to normal level being about less than 0.4 or 0.3 seconds. And we need to ensure that the muscles are not recruited excessively. So we also have to get the occlusion time within 0.2 seconds. Occlusal time is basically that time that is required to get all of your teeth together into occlusion. So there's no occlusal prematurities or no high force points when you get your teeth in occlusion. And an even force distribution is maintained and good muscle activity is generated. Very importantly, we need to understand that the point of occlusion is to not have good teeth and good contacts. The point of occlusion is to have good function. So when somebody clenches, they need to activate their muscles strongly and possibly, and they need to reduce excessive hyperactivity of this muscle when the occlusion is performing its usual role, that is swallowing and chewing and etc. So this is one of the case. Let's say this would be before doing the DTR. Patient has some canine guidance, okay, and apart from working cusp tips or working cusp tips here, there are a lot of these smudge marks on the cuspal inclines, on these inclines, non-working cuspal inclines, etc. And when some occlusal minor correction is done, you would see that a lot of these marks have significantly reduced, and you would see the canine guidance is automatically increased. Now, I want you to have a look between this, okay, look at the cuspal anatomy and look at this. There's not much change in the cuspal anatomy. So it's very, very minimal procedure, and it has to be done with a pinch of salt, because if your patient is having sympathetic tone problems, stress, anxiety, and clenching related pain, neurological dysfunctions, and then this is not the right procedure. So this is where we need to understand that the diagnosis is the key, and we need to evaluate thoroughly before we make any decision regarding treatment. So DTR is not just, you go in and use your biometrics, and on every case, need to really pick and choose, and only few percentage, maybe 10 to 20% of cases may require these biometric tests, but it does not eliminate all other routine evaluation like clinical checklists, detailed history, serological investigations, radiological investigations like CT and MRI, sleep apnea, psychological counseling, psychological evaluation, systemic evaluation. And only after you have ascertained that all other factors are corrected, only then you would go in with your biometrics, check if there is any muscle related problem, and then attempt a correction initially with reversible methods. And if you have to, very precise, ultra precise minor calibrations of teeth, which are like a painter who paints on a canvas. So these corrections have to be that small, and you have to be very, very careful when you do that. So let me tell you about this particular case. And this particular case is the dentist herself. And now she's a clencher and she has a lot of wear facets in the teeth. However, she has a gag reflex, so no appliance. I mean, when we tried putting in the appliance, there was the gag. She couldn't get used to the appliance. There was no question of making a sleep apnea appliance. She said, "I'm not going to wear it. I'll bear the pain. I'll take the medicines. But is there anything that you can help me with?" So I said, "Okay, let's try and see if we can, help you." And we did a T scan and EMG, and we found that she has a lot of interferences, posterior interferences on the working side. This is right lateral, and some balancing side interferences here. And the disclusion time, instead of 0.3 or 0.4 seconds, it is 1.3 seconds. That means it is increased by 4 times. Also, what we noticed is she has a good clench in the center. These are temporalis and these two are the masseters. So she has good clench in the center, but when she's moving her mandible to the side for the right lateral excursion, there is a hell lot of activity of the right temporalis. The right temporalis is too hyperactive. Even the left temporalis, right masseter, left masseter, there's just too much of muscle activity. So you know what we did in this case? In fact, we built a canine a little bit because she had a very flat contact in the canine. So we built the canine by composites, okay? And just by building the canine with composites, look at the result that we had significant reduction in the muscle activity in the given window. And the disclusion time was brought back to 0.3 seconds. And same thing with the left side, disclusion time 0.82 seconds, canine guidance not that great. We built the canines, did extremely small adjustments, and immediately the muscles calmed down, disclusion time was brought in control. And guess what? Now this patient does not have significant pain. Pain symptoms reduced by 75 to 80% within first 2 weeks. That's great, right? No medications, no physiotherapy, no orofacial pain management, but pain symptoms reduce significantly. A simple thing that a dentist can do, not very complex. And even if suppose that does not help later on, okay, you could just grind away the canine filling and go back to where it was. So these are simple things what dentists can do. But again, she's a clencher and bruxer, and there is an airway compression. So we have told her that she requires an appliance. She needs to have a consultation with sleep specialist. She has a deviated septum, so an ENT consult is also warranted. So all these things are informed to the patient. However, being a doctor, not ready to do the treatments till the time it's a significant problem. So, but at least we could help her significantly with simple one filling and practically no occlusal changes. She already had a lot of wear, so there was no question of occlusal changes. So this is what we did for a patient, and patient is really, really happy. So what are the do's and don'ts of DTR? Naturally, if there are anterior open bite, skeletal abnormalities, severe degenerative changes, lot of occlusal wear, like due to bruxism, lot of occlusal wear, you definitely cannot grind anybody's teeth. And probably with clenching, you will require an appliance. And if patient is having neuropathic and neuroplastic pain, then we would require a management of orofacial pain or management of craniofacial pain done primarily, and DTR is not for such cases. There is a enigma about orofacial pain that Dr. Sood spoke about, and she's quite right in that regard, that often those who have equipment tend to think that everything they can do everything with the equipment, and those who don't have equipment, they they can't do much about it. And that's absolutely wrong. And people on the other side of thing also say that, okay, these equipment are not needed, and you can do a lot of things without equipment. So I think the truth is in the middle. We can try and help as many patients as we can with our respective schools of thought and be respectful about one another. So DTR is a scientific treatment modality. There's a whole book published about DTR, 2 edition. There are about 100 articles written about DTR, and a lot of now DTR is not what it used to be. Now it has evolved to a lot of restorative methods, so you can always use reversible methods for treating DTR. Now, Dr. Tawfiq also spoke about avascular necrosis and severe degenerative changes. So this is one of the avascular necrosis, and one of my colleagues had suggested some occlusal equilibrium for this. But if you don't, do your due diligence and diagnose these cases, the treatment methods can be a disaster. So we have to use these diagnostic methods like CT, MRI, serological investigations, and only then, go to treatment methods. So diagnosis would be the key. Also, I would very much like to draw your attention to this slide. Here we see the disclusion time is increased. It is beyond 0.3 or 0.4 seconds, okay? But there is no significant muscle hyperactivity beyond this dotted line C, which is the excursion timeline. So there is no muscle activity. So I need to tell you that there are so many of us who have groove function. Does that mean that we just go ahead and build canine guidance for everyone? Absolutely not. So only in cases when there is group function, posterior friction, and that friction is causing muscle hyperactivity, only in such cases you would consider building the canine guidance or doing some very minor occlusal calibration, but not in every case. So one treatment solution does not treat all patients. It will only help a certain subcategory of patient. So that is where the T-scan and EMG will help you in identifying such cases. Also, this would be the joint vibration analysis. And it tells me that there are these very high clicking sounds. Now, you don't require a JVF to palpate the clicking sounds, okay? But I wanted to quantify how much are the vibrations. So these vibrations are sky high, and there's a very active damage going on in the TMJ confirmed on the CBCT. So such cases are not for DTR. We would try and stabilize these cases with appliances. And if not, if they don't respond to the appliances, we would consider doing an arthroscopy guided disc repositioning and following up with a decompression or a simple distraction appliances. So DTR is not a magic bullet. It reduces intensity, frequency, and duration of the symptoms. It is done in about 3 to 5 sessions, and pain may move or symptoms may differ between various settings, and it's not a Ramban Upai for everything. It has its own place. So all other factors also have to be considered, where the diagnosis would be the key in the management. So I would like to conclude by saying that DTR is one of the treatment modalities for treating myofascial pain without very significant joint clicking. It is only for treatment of myofascial pain and headaches where the systemic problems are kept under control. So it is only for myofascial pain management. DTR can alternatively used for management of occlusion, using for in post-orthodontic cases, management of occlusion in full mouth occlusal rehabilitations, and even in implant occlusion. Not DTR, but in general, a TEC scan can be used for management of occlusion. So occlusion being one of the parameters when we regard temporomandibular disorders, it needs its due diligence, and newer methods are there to evaluate whether occlusion really plays a role in the TMD or not. At least out from my own practice, I have seen that it plays around 10 to 20% role in causing certain symptomology of temporomandibular joint disorders. And even if you read Dr. Okason's book, even Dr. Okason even says that we require more and more data-driven treatments rather than concepts, because concepts tend to change with time. So data-driven treatment, evaluation and diagnosis-driven treatments, and treatments which are relatively reversible are the key here. So that is what I wanted to say. And thank you so much for listening to me today. I hope I have not exceeded my time. And I've tried my best to deliver a very complex topic of disclusion time reduction, which took me about 5 years to understand. I've tried my best to summarize it in 15 minutes for you. Thank you so much.
Thank you so much, sir, for such an excellent presentation. There are a few questions, sir. First one is, if DTR needs to be performed, which teeth to modify, maxillary or mandibular?
Okay, the corrections are normally balanced between the two. And if there is a crown on the mandibular and a natural teeth on the maxillary, then I would prefer doing it on the mandibular teeth. And the corrections have to be actually extremely minimal.
That's it, sir. Next, we have Dr. Sonal Yerpade. Dr. Sonal, who is a seasoned private practitioner from Thane, Maharashtra, has been in practice since 2003. Specializing in orofacial pain, she serves as a TMD mentor and a speaker. Dr. Sonal is a fellow in orofacial pain and dental sleep medicine and holds certification in aesthetic dentistry from NYU College of Dentistry. An alumni of DY Patil University, Mumbai, Dr. Sonal remains committed to staying abreast of the latest development and research in dentistry, ranging from implant dentistry and microdentistry to digital dentistry. As the owner of Smiles Unlimited Dental Academy, she facilitates continuous education across various dental specialties. Notably, Dr. Sonal is the organizing secretary for Nopcon 2023. Today, she'll be unraveling the role of appliance therapy in the management of temporomandibular function. Over to you, ma'am.
Ronali, can you hear me now?
Yes, ma'am.
Yeah, sorry about that. I had a connection issue here. So, yeah, can you see my screen now?
Yes, ma'am, we can see.
Yeah, just a second. I'll just start with the shared screen option. Is my screen visible, doctor?
Yes, ma'am, it's visible.
Yeah, hello everyone. I'm Dr. Sonal Yerpude and warm regards from the team Nopcon 2023. My topic for today is something that I have always strived upon. That is, everybody deserves a beautiful smile, and every smile has a story. So when I talk about every smile having a story, we as clinicians or a orofacial pain practitioner or a dentist, we are bound to deliver the best what we have, or whatever equipments or whatever knowledge we have, we are supposed to deliver the best possible result for our patients. And I thank God for making me a medium by which I'm able to help some of my patients. And I'm a healer. I'm privileged for giving this opportunity. God has given me this opportunity. So when I talk about my topic for the today's presentation is occlusal appliance therapy and adjunction to management of temporomandibular joint disorders. We have heard lot many procedures and lot many therapeutical uses and eminent speakers talking about management of orofacial pain, and the most clinically significant pain what we as clinicians have seen our patients having temporomandibular joint disorder cases. And when we talk about management of temporomandibular joint disorder cases, the first thing that comes to our mind is that it should be a reversible form of treatment. Emphasis has been always been upon reversible and non-invasive kind of treatment. So when we talk about such condition and such clinical criteria as the criteria for management of conditions, the most important thing that comes to our mind, or what we have been following for up till now, is something that is called as an oral appliance or a splint that was always delivered to the patient. Now, when we talk about scientific and professional societies that recommend oral appliances as treatment of temporomandibular joint disorders, all the societies, what even if you talk about AOP or AOMS or ACP, NIH, all of them recommend oral appliance therapy as treatment management protocol. But there are certain things which we are not aware about oral appliances. So let's just understand what these oral appliances are. So Delian et al. Defined occlusal splint therapy as the art and science of establishing neuromuscular harmony in masticatory system and creating a mechanical disadvantage for parafunctional forces with removable appliances. As complicated as it sounds, let's just decode it. An oral appliance is a removable device, usually made out of hard acrylic, as we all know. It is basically placed in one arch. At times nowadays, it is placed in both the arches simultaneously. That creates a precise desired occlusal contact with the teeth on the opposing arch, commonly known as night guard, bite guard, intraocclusal plate, orthopedic appliances, or the orthotonic appliances, so on and so forth. So what are the oral appliance indications that we know of? Patients with masticatory myalgia or TMJ arthralgia, myospasm or myositis patients, patient having history of inflammatory or joint condition existing caused by parafunctional activity such as bruxism. Bruxism in itself is a symptom, as we all know now. Researchers have proved it to us. And unstable occlusion, stress-related pain symptoms such as tension, headaches, and neck pain or muscular origin. What we all don't know about oral appliances is that the mechanism by which exactly how they are working in some cases, and it might not work in some TMD cases, and what are the long-term impacts of oral appliances on our patients. There are so many physical designs that are available, and it is not very clear because they are not very well documented. Most of the time, the management for through oral appliances, it is mentor driven or system driven, and that has created a fallacies, or that has created a gray area when we are administrating these oral appliances. And the multifactorial, as we have seen since yesterday and today, the multifactorial representation of these patients, both in Access 1 and Access 2, has shown it to us that it is very difficult to diagnose and treat such conditions. So let's now understand what is the role of these oral appliances. We all are giving oral appliances, come what may. We are administrating these oral appliances. So what generally happens when a patient walks into your practice and you decide upon giving an oral appliance to a patient? What happens? First thing that we do is we alter the occlusal condition. Obviously, when we are putting even a cotton roll put into a patient's mouth between upper and the lower arch will act as some interference in the occlusal condition. So, but then these oral appliances are designed in a way that they place the occlusion in a balanced way. So that will reduce the muscle hyperactivity. So all these appliances are basically concentrating on the muscle activity of the patient, so that the reduction in the muscle activity could be one of the reason why the patient seems to have relief in the symptoms of pain or conditions of temporomandibular joint disorders. Then we have, as we place the oral appliance in a patient, most appliances alter condylar position to either a more musculoskeletally stable or a more structurally compatible and functional position. This effect on joint stability could explain that. That's why the patient feel reduction in pain symptoms. Now, obviously, when we are placing an appliance in between the teeth, we are altering the vertical dimension. So all intraocclusal appliance temporarily increase the patient's vertical dimension, and this is universal with regards to all the appliance therapies. It could explain that that can reduce the muscle hyperactivity, and that's how the symptoms of temporomandibular joint disorders are reduced. When we deliver appliance, there is something that is called as cognitive awareness in patient. Patients who wear appliance become more aware of their functional and parafunctional behavior. The appliance acts as a constant reminder to alter activities that may affect the disorders. Mostly, I have seen this happening mostly in patients who have clenching habit or more often bruxism habit. They will be more aware of these situations. This is my favorite, I would say, a change in peripheral input to the central nervous system. Occlusal appliance, when placed between the teeth, provide a change in peripheral sensory input, often resulting in decrease in central nervous system bruxism symptoms or central nervous system induced bruxism symptoms, or it can reduce the signs of parafunction when worn at night. So when we administer a oral appliance, it can bring about neuromuscular recovery, muscular recovery, natural muscular recovery. As we all know, during a normal movement or during an exaggerated movement, muscles tend to go into a delayed onset local muscle soreness. And when most often than not, when we tell a patient, when anybody is not feeling well or they have any muscle soreness anywhere in the body, forget about temporomandibular joint or the oral cavity, we say rest for a while, you'll feel better. So rest is the best way to combat muscle soreness, we all know. So along with it, if we administer something that is called an oral appliance, this most likely will reduce the symptoms or resolve the symptoms completely. Then most important aspect when we deliver oral appliances, it acts as a placebo effect. So favorable doctor-patient relationship accompanied by explanation of the problem and reassurance that the appliance will be effective will definitely reduce the stressful symptoms. So this placebo effect, I would say, will work in every patient of ours, be it a orofacial pain patient or any other patient. We need to reassure the patient that this treatment that we are providing to the patient, first we need to be assured that this will help the patient, and subsequently we can assure the patient that this treatment protocol will help the patient. Now, this symptom, that is a regression of the mean, like when we at a given point in time, temporomandibular joint disorder patients will show varying degrees of pain throughout the day or throughout the week. So it could happen that a patient has walked in with to your clinic with a pain in the range of 8 to 10 out of 8 to 9 out of 10, but has a regressive mode, and he will land up in the morning he has a pain in the range of 8 to 10, but in the daytime the pain reduces to 6 or 7. So when we administer the appliance to a patient, this can increase the regression period, and that definitely help the patient with reducing in the symptoms. Now let's classify oral appliances, having understood what oral appliances work upon. Okeson has classified oral appliances as stabilizing appliances or anterior repositioning appliances, and other appliances also are there like anterior or posterior bite bend pivoting appliance, soft resilient appliance, or silicone appliances. And Dawson's classification Dawson has classified oral appliances as permissive splint or muscle reprogrammer, non-permissive splint or directive splints, pseudo-permissive appliances. Now let's in brief, I will now, since the time duration is very short for this lecture and this is a fellowship topic in itself, so let's just discuss a few points about stabilization appliance, which is very commonly used in our dental practice. The treatment goal for stabilization appliance is eliminating any orthopedic instability between the occlusal position and the joint position, thereby removing instability as an etiological factor. Teeth are contacting evenly and simultaneously, so the condyles are in the most musculoskeletally stable position. Patients with local myalgia or chronic centrally mediated myalgia are the best suited patients, along with patients experiencing retrodiscitis secondary to trauma. This appliance can help minimize forces to damage tissue, thus permitting more effective healing. So how do we construct this appliance? The most accurate fit if you are constructing in a maxillary appliance, it has to fit the maxillary arch completely in most stable, and the retention has to be perfect. In the musculoskeletally stable position, all mandibular, buccal, cusp tips, and incisal edges must contact on the appliance flat surface with even force. This is very important when we are constructing or fabricating this appliance. It should provide total disclusion of posteriors during protrusive and lateral exclusive movements or in canine guidance. If there might be situations where we need to give a mandibular appliance, and that is that is effective as maxillary appliance. The only issue is that creating a even stop due to the placement of maxillary teeth, labial placement of maxillary teeth, it becomes a little difficult to get a perpendicular long axis of maxillary incisors, but still it is given more often than not. We might need to give patients a mandibular appliance as well. Now let's talk about anterior positioning appliance. An anterior positioning appliance encourages the mandible to assume a position more anterior to the intercuspal position, bringing it forward. So when when we are constructing or when we are making this appliance is made in a way that the lower jaw, the mandible, is moved ahead, and the bite is taken in a way that the lower incisor fit in a position that is more forward. indicated for treatment of disc displacement with reduction or disc displacement with intermittent locking, joint sounds, or jaw catching. If the disc is permanently displaced without reduction, and anterior positioning appliance is contraindicated. There are other ways and means of managing, which we have already seen by other eminent speakers. They have already discussed about it. So how do these appliances work? What happens actually? The goal of treatment is not to place the mandible in temporary forward. Goal of the treatment is to place the mandible in forward position. During the forward position, the retrodiscal tissue undergoes adaptive and reparative changes. These tissues are can become fibrotic, vascular, and as the condyle returns to the fossa, it moves posterior to articulate on the adapted retrodiscal tissue, which acts as pseudodisc, eliminating the pain. So, as we all know that the retrodiscal tissue is the most innervated tissue present in the joint condylar complex. So, we allow the joint tissues to heal in a way that the retrodiscal tissue becomes the pseudodisc and it eliminates the pain. Now, anterior bite plane. This appliance is also very commonly used. It's a hard acrylic appliance worn over the maxillary teeth, providing contact with only the mandibular anterior teeth. It disengages the posterior teeth, eliminating their influence on the function of the masticatory system, and best used for treatment of muscular disorder related to orthopedic instability or an acute change in occlusal condition or parafunctional activity, most commonly known as anti-eye appliance. Again, this also has some drawbacks of its own, because it allows potential supra-eruption of unopposed teeth or intrusion of occluding teeth. You should not be prescribing this appliance for a long duration of time. But at times, we consider the patient's pain relieving factor as most important, and still these appliances are given, or these appliances can be used for short-term deprogramming, as they call it, deprogrammers. So this is very good for this kind of activities, but avoid a long-term use for this appliance. There are other appliances also, but due to the time constraint, I'll be discussing only these three or four appliances. Now, there is something that is DASA appliance. This is also dual arch anterior scribe appliance. This is the newest in the commodity of occlusal appliances. When we have, as the name suggests, we have two appliances on the upper and the lower arch. Upper arch generally has a flat plane appliance, and lower arch will have an occlusal nub. Works similar to the anterior and any other appliances. So this is also newest. I have not worked on these appliances, so maybe in current due course of time, if I work on such appliances, I will let you all know. So instructions that are given to the patients when we administer oral appliances. The patient is instructed to wear the appliance only at night. Appliance should not be worn in the daytime unless and until you want to bring about a cognitive awareness in the patient. First follow-up is done between 2 to 7 days for evaluation, and maximum after 6 to 8 weeks, the appliance therapy should be ceased. And if at all in that period of time you have achieved symptomatic relief in patient, or you have been able to manage the patient's pain, then you can consider yourself successful in the protocol. But more often than not, I'm a person who I believe, what if there is no pain relief? If symptoms are not relieved or improved, the appliance should be reevaluated for proper fit or occlusal contacts. More often than not, we are humans, and there could be a chance that we made the appliance incorrectly or ill-fitting. If all these factors are correct and the patient is wearing the appliance as instructed, the etiology of disorder has probably not been affected, or we were wrong in our earlier diagnosis. So having said all this, what I now would like to conclude is, what is the role of these appliance therapy? First and foremost, it can be palliative. Yes, it will help you to relieve the pain. Secondly, it could be a diagnostic appliance which will help you to tell you all more about the orofacial pain or the temporomandibular joint disorder condition. Or it could be a protective against the parafunctional habits, or it could be something which will help the patient get rid of the parafunctional habit for a short duration of time, or the time for which the patient is wearing the appliance. So points to remember: thorough history taking, examination, and diagnosis is critical, and no amount of emphasis on these 3 points is enough. Actually, all the speakers have been emphasizing this. Each appliance aimed at affecting a specific etiology. To select a proper appliance for patient, one must find and first identify the major contributing etiological factor causing the disorder. No single appliance is useful with all TMD cases. Some TMD cases may not even respond to an appliance therapy at all. So to sum it all up, the success or failure of appliance therapy depends on patient's history taking, accurate diagnosis, case selection, appliance fabrication, adjustment, and most importantly, patient's cooperation. You make the best fitting appliance and the most stable appliance, and if the patient is not wearing it and keeping it as a jewelry, it's of no point. So path ahead. Now, why this area is considered as gray area in dentistry? Because you may have heard some speaker speaking very good about oral appliances. Some speakers are in dual mind about it. The reason being the precise mechanism by which appliance may reduce TMD symptoms is still a question of debate, and there are inconclusive theories at present. We should focus on providing enhanced evidence-based data for better understanding the role of appliance therapy. What is evident that they are generally reversible and non-invasive modality that can help manage the symptoms of in many TMD cases, mostly in the muscle-related TMD cases. Therefore, they are often indicated in initial diagnostic phase and in some situations long-term treatment plan for TMD cases. Controlling pain while allowing joint structure to adapt appears to be the most important role of appliance therapist. So this is what I would like to conclude upon. It is in gray area. Lot needs to be learned about it. But yes, we are delivering appliance therapies, and what we need to understand it is a interim procedure. It is a something which is non-invasive, and it can be the first line of treatment for patients after medicinal or any other physical modalities or any other procedures. And if at all you find no help in symptoms with these appliance therapy, then you need to reevaluate your patients for diagnosis, and you may need to change the treatment plan altogether. So here is a case which I would like to say.
Mr. Sane, आज कसं वाटतंय तुम्हाला आता वर्टिगो आणि पेन्स बद्दल कसं आहे?
Vertigo is almost gone.
ओके, म्हणजे आता बेंडिंग वरती वाटतं चक्कर किंवा
काहीच नाही.
पोस्चरल काही
मला
वाटतं?
मी मान वळवतो, उठतो, बसतो, मला काही होत नाही.
अच्छा.
आता या प्रत्येक ऍक्टिव्हिटीला होत होतं.
हा. आणि व्हॉट अबाउट युअर पेन? आता जॉच्या पुढचं पेन कसं आहे आणि थोडं पुढे तुम्हाला पेन होतं?
मला थोडंसं इथे, थोडं इथे आहे. आणि
इंटेन्सिटी किती कमी झाली? समजा पहिले 1 ते 10च्या मध्ये तुमचं इंटेन्सिटी किती होती आधी?
इंटेन्सिटी आता म्हणजे तशी 4-5 झाली असं म्हणतो.
4-5 झाली. आधी किती होती?
10 समजा आधी 9 होती, तर आता 4 झाली.
4 झालेली आहे. ओके, ठीक आहे. ओके, मुंह खोल के दिखाइए अपना अभी पूरा. वेरी गुड. तो क्या तकलीफ थी प्रिया आपको जब आप आए थे?
पहले जब मेरा मुंह ही नहीं खुल रहा था, अभी इतना सारा खुल गया मुंह.
अच्छा, वेरी गुड. अप्लायंस कब से पहन रहे हो आप अभी? चौथा रात है ना?
हाँ, 3 नाइट है.
3 नाइट पूरा पहना?
हाँ.
कोई तकलीफ पहनते समय?
So what you all heard about from this patient is the first patient saying that his vertigo issue has been resolved. Earlier he had postural vertigo as well as some amount of TMD pain, preauricular pain, and appliance therapy helped him. And the second case said that her mouth opening in 2 or 3 days of appliance wear was improved subsequently. So these are the books which I would always recommend everybody to whoever wants to practice orofacial pain practice or temporomandibular joint disorders and who want to know what these conditions are. So these books needs to be there in each and everybody's library. They are available online also. If you all don't have it, you all can connect with me. I can provide an ebook copy for all of them, and you should read these books. So thank you. These are my coordinates. And one thing I would always recommend everybody to have is creative mind. That's contagious, and you should pass on your creativity. Be teachable, or be somebody whom you can teach, or be somebody who can pass on their information, and be creative enough to accept the new changes or new fallacies, or accept whatever is happening around you. So with this, I would like to conclude, and I hope I am in time with my presentation.
Hello, ma'am. I have an.
Yeah, just a second. Yeah. Let me just end the slideshow. Yeah. Yes, sir.
Ma'am, actually in stabilizing appliance, you have shown the occlusal orthotic appliance. In that, I have seen the small perforations on the occlusal and the lingual flange aspect. So why it is made and how it is helpful?
No, I don't think so. There were any perforations.
Dots like on the occlusal aspect.
No, those dots meant the occlusal contact points of mandibular teeth. So buccal contact points and the canine, how they are supposed to contact. This is how the appliance is fabricated. This is how you fabricate the appliance. That is that. How do you judge? See, I'll tell you what. If you give a flat plain appliance, totally flat plain appliance, okay, how do you judge that your appliance is the proper way? So you need to take in these markings with a simple 40 micron articulating paper, and you need to check that only the buccal cusp tips of the posterior teeth and the anterior teeth, the incisor edges are touching the maxillary arch, maxillary flat plane of the appliance. So these were the markings. So these they were not perforations; they were the markings. I'm sorry if you took them as perforations.
I think I got confused.
No, those were the occlusal markings. Yeah.
Whether that appliances are fabricated with the use of articulator or only just by the.
Yes. See, I always do that. See, that's what I said. This is a fellowship topic in itself, and fabricating an appliance takes a lot of. There are steps in it. You need to take a proper impression, digital or manual, whatever way you want to do it. And I always mount, like even if it's a single crown preparation that I'm doing, I always like to start. I'm an old school person, so I always mount my cases, even if it's an FMR or I start a single tooth. I mount my cases from the day one. How the patient has walked into my practice, it's very easy for me to visualize that way. Or now the scanner, it gets easier. But yes, mounting is mandatory. How will you know otherwise where to place the appliance contacts? Mounting is mandatory, sir.
Right. Thank you, ma'am. Thank you very much.
Ma'am, if I may ask something.
Yes.
Ma'am, if there is a case of a flat occlusal surface of all the teeth, so we may not get point contacts on the flat plane appliances. So in such cases, how do we evaluate whether the appliance is fitting properly or not?
No, then you can consider only a single point contact, the first point in contact. Definitely they are going to have, even if it's a flat plane person who has all the teeth that are flat, there will be some point which are contacting first. And that person is definitely having some of the issue with the parafunction also. That is the reason he's having such kind of flat appearance of the arch. So definitely you need to mount it, check for the occlusal point of contacts, check in lateral excursion where the tooth is contacting first. So yes, we will give a single point in contact for a particular teeth, but generally it is 1 or 2 point in contact. It is good enough for you to start with the appliance therapy. Over a period of time, you can titrate it, grind the appliance. It is acrylic, with a small burr, straight handpiece burrs. You can adjust it in a way that the teeth start contacting. So over a period of time, it is all titrated. Like, you need to adjust the appliance accordingly. The first is at least 2 or 3 posterior contacts, and anterior contact is mandatory.
Oh, thank you so much.
Yeah.
Ma'am, there's one more question that what is the thickness of this splint that you fabricate?
So initially, see, I'll tell you what, there are various theories. That's why I said that there are so many fallacies, how thick the appliance should be. How far can you go? So if you increase the vertical dimension by a certain, there are particular theories which say that increase the vertical dimension by 8 millimeters, 1 centimeters, nothing happens, and over a period of time titrate it. They act as a muscular splints and all that. So depending on the case, so case selection is very important. What has the patient walked into your practice with? What percentage of pain, or where the patient is complaining of pain? Initially, I'm a very conservative person, so 2 or 3 millimeters max I would go about doing it. Increasing the height by height of the appliance by many millimeters will be decided only and only if the patient is showing some severity symptoms which are associated with the any other part of the body, since we all know the convergence factor, the neck pains and the body aches and the myalgias and all that. So if I'm going into that line of treatment planning, then only I will increase the vertical dimension more than 2 or 3 millimeter initially, because this is all patient acceptance. Imagine you are giving imagine if the patient is not comfortable with the increase in vertical height too much. So I would start with a smaller appliance, and then eventually, if I need to, I will titrate it to a bigger one.
Okay, thank you so much, ma'am, for your incredible insight. Now I request Dr. Narul to take over the platform.
Thanks, Dr. Mrinalini, and thanks, Dr. Sonal, for giving a wonderful presentation on appliances dealing in orofacial pain. I'm thankful to Dr. Mrinalini. She is, sparing her precious time and join early in the morning today. I'm just giving you, since she has chaired and moderated our session, it is worth mentioning his introduction. Dr. Milani is an endodontist, and she is a senior lecturer at Manav Rachna Dental College, Faridabad. And she is a topper in his MDS in A.B. Shetty Institute of Dental Sciences 4-5 years back, I think. And in 2017, I think, and she has contributed in a textbook, and she is a recipient of Early Career Award by ACE Karnataka. So thanks, Dr. Milani, giving your time and chairing our session in the first session in the morning. You have taken this moderation very well and all. So if you have a time, you stay with us. Our program is go till 5 o'clock. So stay with us. If you have some work, then you can leave and all. So Dr. Sonal, we require you because you are the judge of a paper presentation. We have 5-6 PGs who have submitted an abstract, but somehow they couldn't turn up. 1 or 2 PGs have presented yesterday only. So there is a one postgraduate student, Dr. Tejaswini. I think she is there. Dr. Tejaswini, are you there? Could you please share your slide?
Yes, sir.
Yeah, we have, say, 7 to 8 minutes, and after that, we'll go to the next presenter.
Yes.
Yeah, your slide is visible. Carry
Yes,
on.
sir. Yes. Thank you, sir. So my topic for the presentation, if paper marks could talk, T-scan, a digital articulating paper, its role in the diagnosis and the treatment of the temporomandibular joint disorders. So I will be discussing about what is T-scan, where it is useful, and how it exactly works. So according to the researchers, there is a strong correlation exists between occlusal interferences and TMDs. So overload of the masticatory system will lead to the muscle hyperactivity, orthopedic instability, and that will lead to the temporomandibular joint disorders. General prevalence for the TMD is 2 to 8% for the males and 4 to 15% for the females. So the TMD with the pain, they're having the impact on the daily activities like mastication, speech, then psychosocial functioning, and generally the quality of the life. So it is necessary to diagnose and treat the TMDs. T-scan help to detect such interferences, premature contacts to achieve the proper occlusion to prevent the further problems, as prevention is always better than cure. So we use conventional methods to check the occlusion, the articulating paper, impression wax with silicones mapping occlusion with occlusion sketch and the photographs. But it has some limitations, like they do not quantify the occlusal forces, and they do not record the timings like occlusion time, disocclusion time, etc. So marks on the paper is subjective and therefore inaccurate because identical occlusal loads correspond to markings of the different intensity. So the Manes et al. In the year 1987 reported the development of the T-scan, which is a reliable and easy to use clinical diagnostic device which senses and analyzes occlusal contact force using the paper-thin disposable sensors. So the components of T-scan are the sensor, which is a key component, then handle assembly and the computer software. So the sensor consists of sensile, that is the elements which are arranged in vertical and horizontal rows, and the sensor is inserted intraorally between the central incisors, as shown in the figure. So when patients bite on the sensor, the resultant change in the electric resistance is converted into the images on the screen. There are two modes, the time analysis and the force analysis. The time analysis provides information on the location and the timing of contacts in different colors, while force analysis shows the location of contacts and their relative forces in different five shades of colors, that is ranging from blue to pink. Here we can see the pink color is shows the heavy forces, while the blue is the minimum forces. The On the right side there is the dental arch, which shows the anterior and the posterior compartment, and the left side is indicated with the green color and right is with the red color. And there is on the left side there is a table which shows the occlusion and the disocclusion time, which is given by the T scan. Then below that there is a graph which shows the 4 points, that is A, B, C, and D. The A is the first point of contact. Then B is the teeth which are when in maximum intercuspation. Then C is the when they are come in proper occlusion, and then C to D is the disocclusion time. So the applications of T-scan we can use in orthodontics if improper occlusal contacts due to the severe malocclusion. We use the T-scan before diagnosis and after orthodontic treatment for the patient to attain the goal of correcting malocclusion and maintaining the proper bite force. In case of prosthodontics, as in the day-to-day dentistry, we perform different procedures for the replacement of missing teeth with bridges, crowns, complete or the partial dentures. The improper occlusion is the major challenge. The T-scan is helpful to achieve the occlusal stability of intercuspal position. So in case of restorative dentistry, like improper restored tooth can lead to the early fracture of the tooth or restoration, TMD related problem in unbalanced bilateral application of force during the mastication, and that will lead to the headache. So it can be checked with the T-scan and we can reduce that high points. In case of implants, biocompatible implants, they do not have the shock absorption and they cannot adapt according to the need of the occlusal forces. So replacing missing teeth by embedding the biocompatible material with no periodontal ligaments is really a challenging task. The T-scan occlusal analysis system is helpful to meet the needs of the patients for a reliable measurement of occlusal biting forces. So the advantages of T-scan, it can measure location, timing of the tooth contact and occlusion in three-dimensional view. The premature contacts interferences can be identified in the dynamic occlusion, easy for the patient understanding and patient education. Disadvantages of T-scan, some studies says that the electronic sensors were relatively thick sensors that may inhibit the dental proprioception. It is expensive and it is relatively a newer technique. So conclusion, the number of TMD patients are increasing nowadays and it shows impact on the lifestyle of the patient. So balanced occlusion is most important factor in our day-to-day practice. D-scan allows fast and accurate registration and analysis of occlusion. So is a useful clinical method that eliminates a biased subjective evaluation of the occlusion and articulating relations on the part of the operator. Thank you.
Yeah, very good presentation, Dr. Tejaswini. And it's, of course, it's a newest technique. Have you done any cases with this T-scan?
Actually, my thesis topic is with the T-scan. So
Okay.
I will be checking the occlusion time, disocclusion time in TMD patients and in non-TMD patients and comparing their data. I will be
Wonderful.
comparing.
All the best, doctor. Nicely
Thank you
presented.
so much, ma'am. Thank you, ma'am.
Thanks, Dr. Sonal. Now, since we are a bit, half an hour lagging in our sessions and all, so we are moving forward to one of our special guest speaker today. He is joining from Pink City, Jaipur. We have privilege that Dr. Sanjeev Kumar Sharma is with us. He is a visiting consultant at and pain medicine and rehabilitation at CK Birla Hospital, Jaipur. He is MD and FIPM fellowship in pain medicine from All India Institute of Medical Sciences, New Delhi. And she has a certificate course in Essentials of Palliative Care, IAPC, and Rehabilitation Medicine. He is a part of drafting team of Indian guidelines for psychiatrists for approach to cerebral palsy. And currently, he is running a clinic at Dr. Sanjeev's Pain Clinic, Mahesh Nagar, Jaipur. Over to you, Dr. Sanjeev. Please share your slide and continue.
Hello all, good afternoon. Am I audible to all of you?
Yeah, Dr. Sanjeev, you are audible and your slides are visible.
Okay. So, thank you, Dr. Mrul, for inviting me to the Nopcon 2023. So, I will be discussing a small part of my practice, which I am doing as a pain medicine consultant. So, we are dealing with multiple type of pain syndromes. In that syndromes, we are dealing with facial pain also. We get a lot of references from dentists and other specialties, neurologists, neurosurgeons regarding the management of pain. So, first of all, if we see the orofacial pain could be due to multiple causes. So if we that it could be due to some dental pathology or some oral mucosal, salivary gland or jaw bone pain. It could be due to some myofascial pathology, which could be primary or secondary to some problems. TMJ pain, it could be due to some lesions or disease of the peripheral nerves or cranial nerve, that is the trigeminal nerve or glossopharyngeal nerve. Or orofacial pain could be a presentation of part of presentation of some headaches like orofacial migraine or tension type orofacial pain, trigeminal autonomic orofacial pain, neurovascular orofacial pain, or some idiopathic causes like burning mouth syndrome, persistent idiopathic facial pain, or persistent idiopathic dentoalveolar pain, which we call as atypical odontalgia, or constant cumulative facial pain with additional attacks. This classification has been given by International Classification of Orofacial Pain, which was published in Fibromyalgia Journal by International Headache Society 2020. So we'll be primarily dealing with the nerve interventions for the disease, for the neuropathic orofacial pain, that is due to trigeminal nerve and glossopharyngeal nerve. So neuropathic orofacial pain, it is caused by some lesion or disease of the peripheral nervous system or central nervous system. So it could be either continuous or episodic. In this continuous neuropathic pain, the pain will be present, constantly present, which could be with the fluctuating intensity of the pain, but usually there is no remission in between. In episodic, it is usually presented in the form of neuralgias. It presents like sudden episodes of hectic-like severe shooting pain, which could last for few seconds to few minutes. So if we see cases of chronic orofacial pain, so in this we can see if the patient is presenting with the unilateral continuous orofacial pain, then it could be due to post-herpetic neuralgia, post-traumatic trigeminal pain, anesthesia dolorosa, or atypical odontalgia. These are the neurological causes of this orofacial pain, unilateral continuous orofacial pain. But in cases of post-stroke pain or thalamic pain syndrome, giant cell arthritis, these are vascular causes of some pain in that area. If we see if the patient is having bilateral continuous orofacial pain, then it could be due to TMJ disorders or persistent orofacial muscle pain, burning mouth syndrome, or persistent idiopathic facial pain. If the patient is having episodic orofacial pain, and if it is unilateral, then it could be due to trigeminal neuralgia, which could be classical or type 1 or type 2, or glossopharyngeal neuralgia. It could be sometimes trigeminal autonomic cephalgia type of headaches. Okay. If the patient is having bilateral episodic orofacial pain, or it could be due to some tension type headache or medication for reduced headache. This has been given by the this has been published by the British Journal of Anesthesia in 2013. So, in cases of management of neuropathic orofacial pain, there is a multidisciplinary approach in which the role of dentist, immunologist, pain medicine specialist, clinical psychologist, and neurosurgeon, all of them have a role. There is a multidisciplinary approach for the treatment of this neuropathic orofacial pain. So coming to our first topic, that is trigeminal neuralgia. In this, classical trigeminal neuralgia is the involvement in which the patient is having, it is usually idiopathic. There is a associated chronic vascular compression of trigeminal nerve at the root entry zone of the brainstem region. And the second type is secondary painful trigeminal neuropathy, which is usually mostly iatrogenic or due to some structural lesion like multiple sclerosis or some neoplastic or intracranial space occupying lesion or tumors which are compressing the trigeminal nerve at the Meckel's cave or sometime in the brainstem level. So the classical symptoms in this, the patient has unilateral sharp electric shock-like sensation in the distribution of one or more branches of trigeminal nerve. 68 to 98% of the patient have spontaneous pain, but some triggers factors are like chewing or talking, brushing teeth are present. But in 14 to 15% patient, they have continuous pain also. Now, if we see the extracranial branches of trigeminal nerve, that is the fifth cranial nerve, it arises from the brainstem and crosses through the Nepal's cave and divides into three parts. That is the V1, V2, and V3. The V1 is the ophthalmic branch, ophthalmic nerve, which divides into the frontal nerve, and this frontal nerve then later out divides into the supraorbital and supratrochlear nerve. The second branch of V1 is the lacrimal nerve, and third is the mesociliary nerve. Now, if we come to maxillary nerve, it comes out through the foramen rotundum and it enters to the pterygopalatine fossa, and it divides into zygomatic nerve, infraorbital nerve, and superior nerves. The third branch, that is the mandibular nerve, it comes out through the foramen ovale and it divides into buccal nerve, lingual nerve, and inferior alveolar nerve, which terminates as mental nerve. And one of its branch is known as auriculotemporal nerve that supplies the temporal area. So if we see in this picture, we can see the area supplied by the multiple nerves. This is the area just above the nose area and little bit just lateral to the midline of the face. It's area supplied by the supratrochlear nerve. And the area supplied above the brow area, it is a forehead and the scalp area, it is supplied by the supraorbital nerve. If we see just immediately below that infratrochlear nerve is the area supplying this area. The area supplied by the below the eye or the cheek or the lateral part of the nose is supplied by the infraorbital nerve. If we see the lower jaw or the chin or the lower lip, it is supplied by the mental nerve. Some part of the area is supplied by zygomatico-facial nerve and zygomatico-temporal nerve. And the area just in front of the ear, the pinna tragus area and the temporal area, it is supplied by the auriculotemporal nerves. So if we see the management of trigeminal neuralgia, usually we start with a single drug, that is a carbamazepine or oscarbazepine. My choice in this case is usually oscarbazepine because it literally has less side effects as compared to carbamazepine, and those can be escalated very well. The one point which I want to emphasize is that usually some of the patients, they come with a very low dose of these medicines and they complain that they don't have adequate pain relief. So first thing which you should do in your OPD is that first of all optimize the dose of these medicines. So dosage of carbamazepine and oscarbazepine, whichever medicine you want to prefer, you have to optimize the dose first and till this adverse reaction occurs. Second choice of medicine is my choice is baclofen. Sometimes I prefer lamotrigine also. Third choice is the gabapentin, pregabalin, botulinum toxin can also be used in these cases. So we have to increase progressively the therapeutic anticonvulsant level. If there is no response to single therapy or single medicine, then only we have to add the second one. If we have given three medicines, 2 to 3 medicines we have given, but still the treatment effect is inadequate, or the patient is having severe adverse reactions, or the patient has a relapse of the pain, then we have to consider the pain interventions. So Dr. A.K. Saxena, P. Jain, Dr. G.P. Dureja, they have multiple other pain physicians. They published a consensus treatment from Indian experts in Indian Journal of Pain in 2018. That is the pharmacological management of neuropathy pain in India. In this guidelines, the Indian specific guidelines for the management of trigeminal neuralgia. So medical management is the first line of treatment. If the carbamazepine patient is unresponsive to carbamazepine, then try baclofen and pregabalin. Tricyclic antidepressant like nortriptyline, amitriptyline can be added. Tramadol alone is not useful because opioids have benefit to side effect ratio we have to see. Usually in cases of increased doses of these opioids, the side effect occur more frequently as compared to effect, and there is a risk of opioid addiction also. If the patient is refractory to 3 medications in optimal doses, then we have to think of some pain intervention or some surgical treatment. So peripheral nerve block is in the second line of treatment, and glycerin, ganglion blocks, RFAs, and all those things, they are can be used if the patient is if the technique is available with the treating doctor or the patient is affording for those techniques. So decision making in trigeminalgia treatment is that when should the intervention be considered? So whenever the conservative management or medical management has failed or has significant adverse gas reactions, you have optimally changed the doses of the medication, but still the patient is having pain. If there is a acute exacerbations or relapses of the pain are there, frequent relapses are there, or the patient have in pain from very long duration, so some intervention has to be considered. Now, which intervention should be done? It depends upon the age and health of the patient. For example, if the patient is an old age patient with multiple comorbidities, he's already on bedside and can't tolerate a big surgery or big interventions, then peripheral nerve blocks are of choice in that patient. If the patient willingness to accept facial sensory loss in cases of radiofrequency ablation and in PVC cases, that is percutaneous balloon compression cases also, there's a little bit sensory loss or numbness over the face. So that has to be decided and talked to the patient before doing the procedure. If the patient had already got the procedures done for trigeminalgia, then we have to consider that which procedures have been done and how precisely they have been done. Because whatever I see in many cases that sometimes the procedure has been done, but that has not been optimally done, that the drug or the has not reached to the appropriate nerve that has to be seen properly. That patient had experienced paresthesia during the procedure or not. If that is not, then you can again try that procedure. Otherwise, you have to go for advanced procedure like RFA or PVC. Then consider the invasiveness of procedure. That is the minimally invasive, EPC, or less invasive. That is the peripheral nerve intervention that I am going to talk about. But RFA and percutaneous balloon compression, they are cryo, they are more invasive, and extremely invasive are the microvascular decompression surgery for the trigeminalgia patients. Desires of the patient and cost effectiveness we also have to take in account, and experience of surgeon or experience of the doctor who is doing the procedure, that has to be taken in account. So coming to peripheral nerve blocks, so for peripheral branches reasoning for the V1, V2 supraorbital or supratropium nerve block. For V2 or the pain over the cheek area, then upper jaw infraorbital block. Mental nerve block for lower jaw or the lower lip pain area. Auriculotemporal nerve, if the patient is having pain in front of the ear or just over the temporal area, then we can go for this nerve blocks. If the patient is having pain in the whole of the maxillary area supplied by maxillary nerve, then we can get for this V2 maxillary nerve block or RFA through the neurolytic block through the coronoid notch. V3 mandibular can be also approached by the coronoid notch in cases of pain involving the whole of the lower jaw and up to the temporalis area. Now, the advantages of this peripheral nerve block that they have a good diagnostic as well as prognostic value. Diagnostic because they can exactly, if you are in cases of dilemma that that pain is due to some nerve or some or any other pathology, then we can go for diagnostic block with the local aesthetics. Prognostic, that how much effect will we can do this procedure before RFA, that how much effect will the patient will have after these RFAs. So these procedures can be done under landmark guidance, or they can be done under ultrasound guidance also. Right now, I'm doing most of my procedures under ultrasound guidance. These procedures can be followed by cryoablation or RFA. These are usually OPD based procedure, so no need for some expensive setup, and these are also cost effective. Disadvantages, they have short-lived or medium-term effect. If I see if the patient has got the local anesthetic plus steroid nerve block, then the effect may be from 15 days, 1 month to 3 months approximately. If we are going for neurolytic blocks, then the range of the effect is from 3 months to 1 year also. So I have seen multiple cases up to 1 year also. If we are doing RF and cryoablation, then the effect can last for long. So these in this another disadvantage is that a high rate of recurrence is there, and late differentiation pain can occur after multiple serial blocks. So indications, the pain persisting in spite of pharmacological treatment, if there is a no response or tolerance or adverse drug reactions to pharmacological therapy. They have also diagnostic significance to relieve acute pain. Before starting medication, the patient is having severe acute pain, then we can use these nerve blocks to relieve the pain. To improve oral intake and nutrition, I have seen 2 or 3 cases in which due to severe pain and unavailability of the services, they are not taking solid diet. They were on liquid diet from, I think I can say 1 to 2 to 3 months. So to improve oral intake and nutrition, we can go for these blocks till the patient get ready for some other higher procedure like RFA or PVC. Secondary causes like refusal to surgery or recurrence to pain after interventions are poor medical. Now, if we see the anatomy in this, we can see that this is the area where the supraorbital notch is there in just above the orbit area. This supraorbital notch contains the supraorbital nerves and vessels, and the muscle which is overlies it is the corrugator supraciliary muscle, which lies superficial to the supraorbital notch. This is the supraorbital nerve area, and the supratrochlear nerve is just along the middle border of the this orbital notch. Okay. Now coming to infraorbital nerve lies in the infraorbital foramen, which lies just 1 centimeter below the inferior rim of the orbit. Okay, so it harbors the infraorbital nerve and the vessels. The levator labii superioris muscle, it overlies this area. Okay. Now coming to the mental nerve is a terminal branch of inferior alveolar nerve, which lies just around 1 centimeter above the lower border of the mandible. Okay, and the depressor labii inferior muscle is overlies this area. Now coming to auriculotemporal nerve, which is also one of the terminal branches of mandibular nerve, it just lies along with the it just lies just anterior to the tragus and supplies the temporalis. Now, what we see that these 3 positions, that is supraorbital, infraorbital, mental, they just lie in the same line if we see. So if you are doing multiple nerve blocks, then you can just see in that they are all lie in the same plane. So pre-procedure, for all the interventions, we have to get the written informed consent. We have to explain the procedure to the patient and expected benefits and expected side effects of the procedure. Constant vital signs monitoring is required. If we are doing ultrasound guided procedures, then we need a linear probe for nearly all the nerve blocks. But in cases of mandibular maxillary nerve block, we can use a curvilinear probe. In cases of a patient having thick, I can say, thick skin or larger head size. In local aesthetics, we use lidocaine 1% or bupivacaine 0.25%. In cases of drugs, that we use is the triamcinolone 20 to 40 mg. Phenol, if we going for neurolytic block, then we are using phenol 6 to 8%. Needles, if we see in cases of superficial, these small blocks, we use 25 gauge 1.5 inch long needle, so that it has a long trajectory we can for the ultrasound procedure. And in case of deep procedure like maxillary and mandibular nerve block, we are using 22 gauge 3.5 inch, that is a spinal needle, that is a black in color. So RFA, in RFA cases, we are using 22 gauge 5 centimeter or 10 centimeter long, that is having 5 mm active tip, cannula and probe. In cryoablation, I use 17 to 20 G gauge cryoprobe. Now coming over to supraorbital nerve. In cases of supraorbital nerve, the supraorbital nerve lies over here. It supplies the upper eyelid, forehead area, and anterior half of the scalp area. It supraorbital artery and vein accompany it, and the corrugator superciliary muscle usually lies over it. Okay, so if we are going for the landmark guided nerve block, then in that case, what we have to do, we have to start palpating the eyebrow from medial to lateral, and just immediately around 2 to 3 centimeters from the lateral to the midline, we are able to palpate a notch, and this is the area for supraorbital notch. In landmark guided technique, we just have to insert the needle over here, little bit superiorly, and then we have to just target nerve, and a little bit paresthesia or reproduction of the same pain symptoms will be there, and we can deposit the medication. Usually 1 ml is sufficient over this area. Okay, but if you are going for the ultrasound guided nerve block, which I am preferring from last few years, so in that case, we are going to place our linear probe transversely over the eyebrow, and what we will be seeing? We will be seeing the subcutaneous tissue and the collicular superciliary muscle over this here, and we will be seeing the hyperechoic shadow of the bone over there, and the little bit rift, or we can say breakage in the shadow. This is the area of supraorbital notch. And if we put the color Doppler on, then we can see the supraorbital vessels also, and that we have to go for lateral to middle approach, and we can insert our needle over here and just target the nerve over here. Okay. Now, in cases of infraorbital nerve supplies the lower eyelid part, half lateral half of the nose, and the upper lip area and cheek area. So in that case, if you want to go for the landmark guided injection technique, then we have to palpate the inferior orbit, and just 1 centimeter below inferior orbit, we have to palpate that area, and thus we have to insert our needle and look for the paresthesias or reproduction of the pain symptoms. But if we are going for the ultrasound guided technique, then we have to place our probe in the transverse view, and then what we have to do, we have from the lateral to middle approach, we will be visualizing the this muscle over this area, and the accompanying vessels over this area. So our nerve is infraorbital nerve is over here, and we can target from lateral to middle approach. We can see that there is a rift or there is a breakage in the shadow of the bone, and this is the infraorbital image. Now coming to mental nerve, in this mental nerve, it supplies the skin over the chin area, the lower lip area, and the mucus of the lower lip area. So if you are targeting for the bony landmark, then what we have to do, 3 centimeter from the midline, approximately 2 finger breadth from the midline, and 1 centimeter above the lower border of the mandible. Here lies the mental foramen, which is in same line to the supraorbital, infraorbital, and the mental foramen. So in the landmark guided technique, we just have to identify this foramen, and just we have to insert the needle just near to it, and then after eliciting the paresthesia or the reproduction of the pain symptoms, we can go for that block. In cases of ultrasound guided technique, then we have to place the our transducer or the probe in the little bit oblique orientation, and then we have to visualize this area. And now what we can see, that we can see this is the mandible area, and this is the rift, or which can be shift, which is seen in the bony shadow, and this is the area where we can see the accompanying vessels, and our target is over here from the lateral to middle approach. Now coming to auriculotemporal nerve, it supplies the anterior ear area and the posterior part of the skin over the temporalis muscle area, that is the temporal area. Superficial temporal artery, it usually accompanies it, and it is very, very superficial. I can say 0.5 centimeter depth only. It is in the subcutaneous tissue. So if you want to go for landmark guided technique, you have to place your single finger or the index fingertip over the just anterior to the tragus of the ear, and you can feel the pulsations of the superficial temporal artery. You just have to target the area near the superficial temporal artery, and you will feel a little bit paresthesia, and then you can give the medication. But in cases of ultrasound guided technique, we'll place our probe like this, and we will be visualizing that this is the superficial temporal artery pulsation, which is visible on the carotid, Doppler color Doppler presentation, and the nerve is just immediately beside it. So we have to target this area. Okay. So now coming to maxillary nerve. So if we want to target the whole maxillary nerve, the maxillary nerve supplies the lower eyelid, cheek, nose, upper lip, upper teeth, gum. If the patient and the roof of the pharynx, sphenoid, ethmoid sinuses, and meninges. So in cases of cancer pain, also if the cancer infiltrates these areas and the patient is having pain over these pharynx areas, roof of the pharynx, sphenoid, ethmoid sinuses area, so then we can go for maxillary nerve block or neurolytic block also. So the maxillary nerve, as we have seen, that it comes out through the foramen rotundum and goes through the sphenopalatine fissure and the sphenopalatine fossa. So its landmark is that we have to identify first this is the condylar process of this is the condylar process, this is the coronoid process, and we have this is the area or the fossa area that we have to insert the needle through this, and we have to target the lateral pterygoid plate. So the pterygopalatine fossa or the fissure lies anterior medial to the lateral pterygoid plate. So if we go for first of all the landmark guided technique, so 22 gauge spinal needle after local anesthesia into this area, the 22 gauge needle is placed perpendicular through the mandibular notch, that is through the condylar process and the coronoid process. We have to place the 22 gauge needle through the this mandibular notch, and after progressing it around 4 centimeter approximately, then we will be our needle will be contacting the lateral condyle lateral pterygoid plate, and after that we have to redirect our needle little bit anteriorly and superiorly. Okay, so then we will be the patient will be feeling the paresthesia or the reproduction of the similar pain symptoms, and there we can deposit our drug. So there is one problem, practical problem, when we try to withdraw our needle and try to make it a little bit superiorly anteriorly, it doesn't go. So the needle bending technique, the tip of the needle has to bend a little bit around 10 to 15 degree. That will help in maneuvering of our needle into that notch. So if we want to go for ultrasound guided this maxillary nerve block, then what we have to do, we have to place our probe just over the one end of the probe over the coronoid process, and one end of the process over the condylar process, and we have to look in this notch, that's the mandibular notch. So if we see in this mandibular notch, what we are going to see, we are going to just see the superficial part of masseter muscle, deep part of masseter muscle. This is the shadow of the condylar process on the lateral aspect, and deep to it, around 4 to 5 centimeters deep, we are able to see a bony shadow. This is the lateral pterygoid plate. If we put the color Doppler on, then we could see the pulsation of sphenopalatine artery also. Okay, so the needle of that needle direction would be from the lateral part of this mandibular notch and goes directly inside it, and we have to hit the lateral pterygoid plate a little bit anterior to it, and we can visualize we can hit the maxillary nerve, and then we can deposit our drug over there. So coming over to the mandibular nerve. So mandibular nerve it gives sensory innervation to the anterior 2/3 of the tongue, teeth, mucosa, periosteum of the mandible, skin over the chip and lower lip, and skin over the mandible. So this is the area which comes out from the foramen ovale and goes down, and it supplies this area. So the bony landmark is that it traverses little bit posterior to the lateral pterygoid plate. Okay, so if we go for the ultrasound guided technique, then what we have to do, we have to place the probe as we have done before. Now we have to insert our needle from the anterior to posterior approach. This is the red line marks the direction for the anterior to posterior approach. We have to give it for piercing the superficial masseter, deep masseter, and lateral pterygoid muscle, and then we will be passing little bit posterior to the lateral pterygoid plate. Here we will be feeling the paresthesia. Even we can use the electrostimulation, that is we can use the electrical stimulation to see whether there is a contraction of the motor part of mandibular nerve with the masseter muscles, and all those muscles can be seen, and then we can deposit our drug over there. But if you are going for the landmark guided technique, this technique is same. The needle is inserted directly into the mandibular notch, and then we have to hit the lateral pterygoid plate, and needle has to be directed little bit posteriorly and downwards till we get the paresthesia. Usually we get paresthesia around 0.5 centimeter or 0.5 centimeter to maximum 1 centimeter depth after hitting the lateral pterygoid plate. We don't have to go beyond that, otherwise we will end into the pharynx area. Now coming over to complications, nerve injury could be there. It could result into paresthesia and dysesthesia. Numbness over the face, skin slowing or fat necrosis could be there. Swelling or localized hematoma, intravascular injection or hypotension. In cases of maxillary nerve block, the needle may enter into the orbit and could cause multiple problems. In mandibular nerve block, the needle could enter into the pharynx and could cause multiple issues. Now coming to glossopharyngeal neuralgia. the patient has paroxysm of pain in the sensory divisions of ninth cranial nerve. So it could be it present at the shooting, stabbing, or needle-like pain in the ear, that because it supplies the eustachian tube area. No? So base of tongue area, tonsillar fossa, and beneath the angle of jaw. Sometimes the patient presents as a foreign body sensation in their throat. So that these are cases of the glossopharyngeal neuralgia. So the cause could be multiple, but one of the common causes is Stilge or Eagle syndrome due to long stellate process or calcified stylohyoid ligament. So coming over to the both the ultrasound guided technique and the landmark guided technique, we have to mark in that patient, we have to mark the stellate process. Okay, this is marking for the stellate process. This is the angle of mandible which I have marked. This is the mastoid area. So we have to draw a line from mastoid area to the angle of mandible, and just in between to it, just in the middle, just middle of that line, we can identify this point, and then we have to insert our needle anteriorly and superiorly till we hit the styloid process. Usually the distance is around 2 to 3 centimeters, not beyond that. 2 centimeters are sufficient. So as we hit that styloid process, okay, after we hit the styloid process, then we have to slide our needle just immediately posterior to it, aspirate the needle so that we are not going to inject into this carotid artery and the veins around there, and not inject the vagus nerve and other structure. So we have to just aspirate and then deposit our drug in small amounts. If we are going for the ultrasound guided technique, then we have to place our probe like this, in this plane, and then we can go from the anterior to posteriorly plane. So what it looks like when you do ultrasound guided block, this is the normal anatomy which we see when we place our probe over that area. On the posterior part, we can see this is the styloid process which is casting the shadow over here. And this is the angle of mandible. In between and superficial to it, it is a submandibular gland area. Now as we go little bit downwards, then the styloid process shadow little bit goes out of the picture, and we can see the external carotid artery and IJV pulsations visible on carotid color doppler. So after visualizing this thing, we can go from anterior to posterior approach and target immediately just below this styloid area. Okay, so we have to target this area. This is the area where the glossopharyngeal nerve lies. Coming to last topic, superior laryngeal neuralgia. Superior laryngeal nerve is the sensory terminal branch of vagus nerve. So usually it presents as a severe pain paroxysm which lasts for seconds to minutes in the lateral aspect of the throat and submandibular region underneath the ear. It is usually precipitated by swallowing, shouting, or turning of the head. And what is the examination feature? A trigger point is usually identified along the lateral part of the hyoid bone or the hypothyroid membrane. So when you identify this trigger point is there, and the patient having typical severe pain paroxysm over the lateral part of the hyoid bone area, then you can consider it as superior laryngeal neuralgia. And the diagnostic as well as the therapeutic is the superior laryngeal nerve block, which we can do easily by the ultrasound. In this, a linear probe is placed with the upper part of the probe over the lateral part of the hyoid bone, and the inferior part could be little bit oblique, and it could be placed over the thyroid cartilage. Okay, so what we are able to see? We are able to see this is the thyroid superior border of the thyroid cartilage, which is marked as 1. This 2 is the lateral part of the hyoid bone or the greater horn of the hyoid bone. In between, we can see a thyroid muscle and thyroid membrane. So we have to, the superior laryngeal nerve lies in between this plane. So we have to come from either from below to up. So we have to deposit our medicine over here. So this will result in diagnostic as well as therapeutic superior laryngeal nerve block. Now coming to articles regarding the clinical effectiveness of peripheral nerve blocks in trigeminal neuralgia, it is said that they provide a short and mid-term clinical relief.
Dr. Sanjeev, sorry to interrupt you. We are running a bit time, and
I'm completing. There are only 2 slides.
There is, please.
So it provides immediate relief. They are simple. There are no serious side effects, and they can be easily done. So these are references, and thank you. The next topic will be covered by Dr. Dhruv Vibra regarding advanced interventions.
we'll take the questions after Dr. Bibira's presentation. Thanks, Dr. Sanjeev, for giving all interventions or peripheral nerve interventions for managing the orofacial pain. So we have a privilege. We have a senior anesthetist with us. If we talk about the pain medicine in India, everyone knows Dr. Bibra is a known name among the anesthetists across India. And he is usually everywhere if you see any big conference happening on pain. So he must be there, one of the speakers. He is currently working as a senior consultant in pain medicine at Delhi Pain Management Center, New Delhi. Delhi Pain Management Center is a chain of standalone pain management center, one of its kind in India. And there are 3 locations they are working at. And he is also, running and setting up the, pain medicine departments at various medical colleges and hospitals. 4-5 hospitals and medical colleges where he has established pain medicine departments. A few of them are Suvarti Medical College, LYF Hospital, Manas Hospital, Kanag Hospital, and Aryan Hospital. These all hospitals are Delhi and NCR, as well as he also mentioned the pain medicine department in Rajasthan, Assam, Bangladesh. These are the Jaipur Pain Management Center, Pain Clinic Narayana Hospital, Dhaka Pain Management Center, Bangladesh. And since he is very busy anesthetist, he is visiting consultant at Bilwara Pain Clinic, Rajasthan, Jaipur Pain Management Center, Rajasthan, Dhaka Pain Management Center, Bangladesh. He did his European diploma in pain medicine, I think from Belgium. And he did fellowship for interventional pain from USA and Germany. So he will be talking on advanced facial pain intervention. And, Dr. Sanjeev has already thrown light on how to intervene and do the management. And he's talking about the advanced pain intervention. Over to you, Dr. Dhruv. Thanks for joining us. Yeah.
Sure, sir. Okay, fine. First and foremost, thank you so much for giving a very warm welcome and a warm introduction, sir. The most important thing you forgot in my introduction was that I like to introduce myself as a student of pain medicine. So that is there, my biggest thing. Rest, everything is secondary. So first and foremost, I would like to thank Dr. Anwar and Dr. Sonal for giving me this opportunity. Giving it in these multidisciplinary approaches is always an honor and a privilege. Unfortunately, because I might have some technical issues because I'm doing my talk from Kochi. So apologies in advance. Because it's a mixed thing, and I think most of us in the audience are orofacial surgeons. So there might be these interventions might be very new to them. So just sit back, relax, and just get an idea. And hopeful with more such interactions, we will have more sort of workshops or trainings where even you can start doing these interventions. Okay, fine. Few points regarding intervention, few principles, how I call them, that they are common for any intervention, basic or advanced. Now, for people who play video games or who are into guns, they will realize that there are, broadly speaking, there are 2 kinds of guns. One is the world famous Kalashnikov, which is the AK-47, where you don't target, you just deposit multiple rounds. But my dear friends, interventional pain medicine is all about firing a sniper, which I call is a sniper theory. Dr. Sanjeev beautifully talked about blind techniques, about ultrasound guided techniques, but pain medicine eventually is all about taking that sniper shot. We take all the time in history, we take all the time in examination, we take all the technology available and then deposit the highest concentration of the drug at the desired site. Whether it is fluoroscopic, whether it is ultrasound, whether we reconfirm the position where we are doing dye, we are using hybrid techniques, whatever, with the sole target and the sole aim of being snipers. Now, the second thing which I often come across is when doctor talks about intervention is, my intervention failed. My dear friends, if you want to follow or what should I say, if you really want your interventions to work, just follow these three principles, which are the RRR principle, which means right candidate, right intervention, and right timing. If you follow these three R's, trust me, you're not going to fail. So it is never the intervention fails. It is we as treating physicians are unable to find the right R in all these aspects, which led to the failure of these interventions. So today we will be talking about ablative techniques. See, most of us practicing pain come from anesthesia background, and we have a long standing committed relationship towards pain, towards nerves. So whenever we find a nerve, whenever a particular structure is troubling us for a very long time, we try to find the nerve supply of that particular area. We become extremely happy if it is a pure sensory, if we find out a pure sensory nerve. There, what we do basically is we go ahead and do an ablative procedure. We block the transmission by that nerve. Now that can be done by a chemical thing, alcohol, phenol, and glycerol, where there is a lot of volume spread. We are covering a lot of area, but that is not under our control. So that is a disadvantage when we do any ablative thing. Second is radio frequency ablation and cryoablation. Radio frequency, we are heating up the tissue beyond 42 degrees Celsius and blocking the transmission. Cryo, we are dropping the temperature and again bringing about a denervation so that the transmission is stopped. Because I will be talking about radio frequency ablation today, so I will be briefly giving you what radio frequency is all about. So in basically what is happening in radio frequency, as I told you, see, the target is that beyond 42 degrees Celsius, there is going to be coagulation of proteins. So if there is coagulation of proteins, the transmission will stop. Therefore, what we are giving in radio frequency is we are giving high frequency radio waves, which will lead to thermal energy. So if fast current causes radio waves, this is met with resistance, increases the surrounding temperature. If the surrounding temperature goes beyond 42 degrees Celsius, we can go ahead and block the nerve. And then the transmission is stopped. How do we do it? So there is a generator, there is an active electrode through which current is passed, there is an active tip. Then there is a thermistor which measures the temperature, which is the most important thing. And then we have a passive electrode which completes the circuit. So this is, you can appreciate that you have the probe, you have the generator, you have the current flow, and then it is earthed by a dispersal plate. Now this, you can appreciate the needle which has got an electrode. The stillet has been removed. Now something which Dr. Sanjeev also talked about, the active tip. So if you clearly see this needle is entirely black, which is insulated. So there is no dissipation of energy in the tissue where we don't want it to be dissipated. And there is an active tip of 5 millimeter. Now this is very variable, 2 millimeter, 5 millimeter, up to 10 millimeter we have. Now this 5 millimeter is the one which is going to dissipate heat. Now this also brings us to the very important point, is that your ablative procedure is going to be successful only and only if this active tip is at the desired area. So if this active tip is in the desired area, then only your any ablative procedure would be successful. What are the factors affecting? Now, I won't be going into the detail, but just give you a brief idea. Larger the needle size, larger is the lesion. Larger the active tip, larger is the lesion. Higher is the temperature, bigger is the lesion. More the time, bigger is the lesion. But what happens is that if we keep on increasing, or if we have a larger size needle, so or high temperature or high time for the ablation, then what generally happens is we have a tissue charring, which causes burning, which causes increased resistance. Therefore, for optimal ablative procedures, we have found out that temperature of close to 90 degrees Celsius and a time duration of 60 to 90 seconds is apt for this ablation. Now, here also, I would like to just pinpoint, this is the area where you need the active tip. As we talked about, that we need to get the temperature beyond 45 degrees. So this is the temperature, this is the area where we are able to get that temperature. Therefore, my dear friends, any ablative procedure you are planning, the active tip has to be close to the nerve. That is one. Second thing, it has to be in direction of the active nerve. So somewhere here you would like to place them. Fine. Okay. So for identification of the nerve, you need a good knowledge of anatomy, appropriate size of the needle, and confirmation with sensory and motor. As I told you, so these are good stimulators also, where just like to rub it. Yeah. Okay. So for the identification of the nerve, obviously we need a good knowledge of the anatomy. We have to be appropriately placed the needle. Thirdly, we have to confirm the needle position by sensory and motor stimulus. So now let us start with the Gazerian ganglion RF. Now Gazerian ganglion, as we all know, it is present in the Meckel's cave, which is present in the midbrain, petrous part of the bone. It is lying very coolly and comfortably there. Now this is the anatomy of the Gazerian ganglion, where we see the sensory and the motor. It's a mixed nerve. The mandibular is a mixed nerve, so that is there, but predominantly it is a sensory. So there are 3 sensory root and 1 motor root. Now let's talk about RF ablation. Now the route or the area through which we can enter the Gazerian ganglion is through the foramen ovale. Now foramen ovale, you can see in the diagrams, it is a small oval shaped foramen through which we enter. Now this is present here. So how do we enter it? This procedure is done under fluoroscopic guidance. I tell everybody that whenever you are doing any fluoroscopic guided intervention, you have to imagine the fluoroscope like your eye. So basically what you are doing is you are putting your fluoroscope in a direction where it becomes aligned to the foramen ovale. So you have a condition where in this condition, you will put your foramen. So patient is lying down supine. Your CM is moved in a caudal direction on the ipsilateral sides. I'll have the images to show you. Now, you can appreciate that the patient is lying supine. It has been turned obliquely around 10-15 degrees. Second, we have identified the foramen ovale by making it tilted in the caudal direction. The caudal direction is just to make sure that the foramen ovale is in the position of the needle. Once we have done that, we introduce the needle in the foramen ovale. Now, as I always tell, fluoroscopy, what we are trying to do in fluoroscopy is we are trying to convert a 3-dimensional structure into a 2-dimensional structure. Therefore, you need to confirm the needle position both in the AP as well as the lateral position. That is one. Second thing is, before doing this intervention, you have to be very sure which nerve you generally tend to block. Though this is given very simply, like lateral most is the mandibular, then maxillary in ophthalmic, but you have to realize that it is oversimplification. It is not like 1, 2, and 3. It is like 1, 2, and 3. So they are arranged in a 3-dimensional structure: mandibular, maxillary, and ophthalmic. Generally, when we are doing an ablative procedure, we try to avoid ophthalmic because it can cause corneal dryness and paresthesia, which might lead to ulcerations in the longer run. So once we have introduced it, we confirm it in the lateral position. Once we have put it, we do a sensory, as I told you, we do sensory and motor stimulation. Mandibular being a motor nerve, we will be getting a motor stimulation, but otherwise it's a sensory stimulation. Sensory stimulation is simple. The patient tells us that he or she is having paresthesia in the area of distribution of that nerve. So for example, if it is the V2 nerve we are trying to block, it will be restricted to the upper limb. If we are trying to block the mandibular nerve, it will be restricted to the lower mandible. So this is the setting of it. You can see the impedance, the resistance, the temperature is around 90 degrees Celsius. Duration is around 60 to 90 seconds. Patient selection, that I have already told you that it is not the first line treatment. This is reserved for patients who are not responding to pharmacological treatment or who are responding to pharmacological treatment, but at the doses that they are doing, which is giving them a lot of side effects. That is one. How do we do it? This has to be done in an OT setup. There has to be monitoring. There has to be an anesthetist in the OT or in the OR when you are doing this procedure. Normally, you can do some Xylocard. Once you have identified, you can give some Xylocard, or you might have to sedate the patient. Therefore, securing the airway, resuscitation, OT setup, anesthetist in the room is the must. Ophthalmic branch, we generally, for ophthalmic branch, we do not go for radio frequency ablation. We try to manage by peripheral blocks, or there is something like as balloon decompression that can be tried. RF needle active tip 5 millimeter or 2 millimeter. Generally, we go for 5 millimeter. You have to create a lesion which is big enough to damage the Gazerian ganglion so that the patient has good relief for an appreciable period of time. Temperature, already we have discussed. Temperature is around 80 to 90 degrees Celsius. The temperature schedule that I follow is 70 degrees for 1 minute, 80 for 1, 90 for 1. Sometimes I just try to repeat by moving the little here or there. What if we get CSF and aspiration? Nothing to worry. You can go ahead and do it. Complication, only thing is post-procedural pain might be there, but anesthesia dolorosa or paresthesia of that area is something which the patient is quite worried about. CSF aspiration we have talked about. So dysthesia, anesthesia dolorosa, masseter weakness if we are doing, and then corneal sensory impairment. Now, the other block that I thought of discussing was a sphenopalatine ganglion block. Now, what are the indications? Now, interestingly, it is there for cluster headache, atypical headache, sphenopalatine neuralgia, CRPS, neuralgias of the face, orofacial cancer pain. See, you have to understand this is a part of the autonomic system. So therefore, any pain condition which has got autonomic symptoms associated with it. So what are the autonomic symptoms? Where there is hyperalgesia or allodynia. So if those kind of features are there on your face, or what I have seen is in long-standing patients of trigeminal neuralgia, which has been there for years and years together, they have some sympathetic, they have some autonomic dysregulation, which might lead to conditions where the patient, along with pain, has these symptoms. So in those subset of patients, just giving Gazerian ganglion may not work. Therefore, you have to find, you have to give this, sphenopalatine ganglion block. Grade 1 indication for cluster headaches, but what I've seen with cluster headaches is generally extraoral approach towards blockage is good enough. Radio frequency is generally not needed for that. CRPS is again a very interesting indications. I have few patients, rare indications of CRPS of the face, but yes, it is there. So what we do is it is a space between the pterygoid process and the maxillary sinus. How do we enter? We enter through the fissure. So we enter through the fissure. Medially, it has the palatine nerve. Opening is this sphenopalatine foramen. Now, what I always tell all my doctors who try to discuss and how do we do it, whether it is a sphenopalatine ganglion block or whether it is Gazerian ganglion block, these are technician's block. If you get good fluoroscopic images, you can easily go ahead and do it. So there it was foramen ovale. Here we need to get this typical flask-shaped appearance. So if we are able to get this typical flask-shaped appearance, it is just about putting in the needle through and through. Okay. So as I told you, the patient is again lying supine. Here, what we are doing is we are putting the CM in the lateral position. I like to show you. Yeah. So this is the patient. In this patient, what we are doing is we are putting the CM in the lateral position. So the C is in the lateral position, and the skill is to get a perfect lateral image. So once you get that perfect lateral image, this fissure, this canal will superimpose, and what you will get is the perfect tunnel. Till you do not get a single image of both the tunnels where the tunnels are overlapping, please do not go ahead and do this intervention. How do we do it? Now, this is something which one of the tricks which one of my seniors told me was that though there are a lot of technical things of getting a perfect lateral image, the other or the simpler way is you just need to ask the patient to wear a stethoscope. So once the patient puts a stethoscope, you just need to ask them to keep hearing the noises. So we need to get the fluoroscopic image perfect lateral. Then it will be easy for them to identify. I hope it is making sense. So you just put in the stethoscope, you get the lateral image, and you just need the single image for the stethoscope, which so that the job becomes easy. Lateral, as I told you, it is there on the upper part, cephalad part, upper 1/3 part. You have introduced it. So once you introduced it, as I told you, that whenever we are doing any fluoroscopic guided intervention, we need to move it in the AP, confirm in 2 dimensions. So what we do is we make it in an AP direction. We introduce a needle till we hit the lateral palatine bone. So laterally, we lateral aspect of the palatine bone we need to touch. Supine C-arm, 2 lateral image. Once we have done that, you enter it, redirected K-flat. So we tried the active tip to be on the K-flat part. We go ahead and introduce up till that we get the palatine. Now this is the AP image where we are hitting the lateral part of the palatine bone. Perfect lateral holds the key. Use a curved needle. Now this is again something which I would request my friends who are starting off, that whenever you are doing any fluoroscopic guided intervention, try to bend the needle, bend the tip of the needle. It is one of the tricks which will help you get your orientation right when you are doing fluoroscopy, because what happens is over a period of time, you tend to get confused with the orientation where you put and the needling becomes difficult. So in that subset of patients, it is easier if there is a bend tip that will help you guide it in a better way. So these are few things that if you get the tingling numbness in the upper teeth, you need to direct it posteriorly. If you are if the tingling sensation so close to the palatine nerves, so you need to redirect it cranially. But generally, it is a simple, easy procedure. The third block which I would be talking about, which can be ablated in the orofacial space, is the greater occipital nerve block. Now, where do we do it? So basically, patient having occipital neuralgia. Now, how do we diagnose occipital neuralgia? Patient having pain in the occipital region. See, this is a kind of an entrapment neuropathy, and for entrapment neuropathy, the gold standard is a diagnostic block. So you go ahead and do a diagnostic block if the patient has, and what you say, with full honesty, do not try to give too much of local. Just 1 or 2 ml of local anesthesia is good enough. So if you give 1 or 2 ml of local anesthesia, patient has good relief, your job is sorted. There are studies where this has been used in patients of recurrent or chronic headache which have not responded, where they have gone ahead and done a pulse radio frequency. In pulse radio frequency, it is more about what should I say, neuromodulatory effect rather than ablation. So it is does not cause what you say, paresthesia, but yes, it improves its functioning. So what is about greater occipital nerve? Branch of C2 innervates the occipital parietal region. Now there are 2 ways of blocking it. Okay, so one is a classical approach where we just go for the external occipital protuberance, the mastoid, draw a line, palpate the artery, and just go slightly medial to it. So this is the standard technique which we have been using for a very long time, but it is blind technique. And especially if you are planning an ablative, this is not the way. So this is the proximal. And this is the distal end of the occipital nerve. So what we do is we can go for a proximal approach. So proximal, as I told you, it is a branch of the C2. So what we do is we put the C-arm. We put the C-arm in the external occipital protuberance. Once we start scanning it down with ultrasound, so this is where we put it. We start scanning it down. Once we start scanning it down, we get the bifid spinous process. So C1, C2 has a bifid spinous process. We appreciate that spinous process. And then, okay, so this was the standard thing. So once we have, this is the bifid spinous process, we just make it slightly laterally to touch the transverse process of the C1. There we have got 2 muscles, splenius capitis and semispinalis, obliquus and semispinalis capitis. In between the 2, you will be coming across the nerve. So as I told you, the obliquus capitis and the semispinalis capitis, you will get the occipital nerve. Sometimes you are not able to appreciate the occipital nerve But you will be able to appreciate the occipital artery. You put in the needle, do certain stimulation, and once you do that stimulation, you will be able to go ahead and block it. So take home message would be, yes, it might sound challenging whether anybody will be able to do it or not, but trust me, my friends, you can do it. Start with peripheral blocks, then move on to these things. Greater occipital nerve definitely can be done. You can go for diagnostic blocks. Phenopalatine, just try to comfort yourself with fluoroscopy, and trust me, it is not difficult. And if we have more kind of these interactions, workshops, where probably you can get an idea. Static sepsis, definite monitoring. Do not try it whatsoever, how much confident you have to become. Proper positioning is required. These are image guided. The 80% of the job is getting the perfect images. And these are ablative procedures. Post procedure pain is common. Try to cover it with the good NSAIDs. When we are going intracranial, probably you need antibiotic cover. Otherwise, it is not. The success of any intervention is not decided in the OT. The success of any intervention is decided in your OPD. So before you talk to the patient, counsel the patient, tell the pros and cons, make sure you spend adequate time with the patient. That will really help you. Thank you so much. Any questions, anything, please feel free to get in touch with me. Thank you so much.
Thanks, Dr. Dhruv, for making your presentation and very compact and very informative. Anyone from audience and attendees would like to ask question to Sanjeev and Dr. Dhruv, can unmute and ask the question. Unmute your microphone, ask the question. Or you can ask on a through chat as well.
Thank you.
Yes. I think there is no any questions from the
It would be a new topic for them. I can
Yes,
accept.
of course,
I can
new
expect.
topic. Most of them are the dental surgeons, but slowly and gradually they will understand with these programs, the fellowship and hands-on
Sure, sir.
training.
Sure, sir. Always a pleasure. Thank you so much, sir.
Thank you all.
Yes. Dr.
Thank you all.
Sanjay, if you there, be with us, or Dr.
Yes.
Dhruv, if you have any prior occupancy, then you can leave. Otherwise, it would be great if you can stay with us.
Yeah, definitely.
I'll try to join, sir. Thank you so much.
Yes.
Thank you so much.
Thank you. Thank you. Thank you.
Yes, thanks, Dr. Dhruv again and Dr. Sanjeev. So we have privilege. We have the next speaker, Dr. Vijay B. Vandikatla. He is from Hyderabad, but he is, I think, out of station, and he is joining from some other place, and he's supposed to catch his flight in another, say, because he has to leave the place, and I think 6 o'clock is his flight. So maybe he's coming back. He worked as a consultant anesthesia and pain medicine at Bradford University Teaching Hospital and Yorkshire Clinic Hospital, Bradford, UK. After completing MBBS and DA in India, he traveled to UK to train and practice for nearly 15 years. During this time, he completed FRCA, MBA Hospital Management, FFP, MRA, Pain Fellowship, and specializing sleep medicine. He achieved his CCT in anesthesiology with a special interest in pain management from the Cambridge. Pursued to, I'm just.
నాది ఎక్కడ పోయింది అనపట్లేదు ఒక్క నిమిషం ఒకసారి మా ఫైల్ కాపే
Please unmute. Let me complete the introduction. Yes.
Sir, 1 second.
He achieved his CCT in anesthesiology with a special interest in pain management from the Cambridge. In pursuit of academics and to achieve clinical excellence, he undertook a fellowship in neuromodulation and advanced pain research fellowship from the Guy's and St. Thomas Hospital, London.
Desktop. Yeah. 1 second, sir. I'm just trying to get on.
Yes.
Hey, sir,
you settle them, then.
Yeah, I'm just trying to get that file open for myself. Hey, ఒకసారి తొందర.
on the bottom of the screen, you are getting one green icon, share screen. Yes. Yes, Dr. Vijay, your slides are visible. Continue. Could you please unmute?
Yes,
Yes,
unmuting.
yes.
Yeah.
Yeah, yeah.
Am I seen now?
Yeah, yeah. You are visible. Your slides are visible.
Okay. So thanks, Dr. Nurul. At the outset, I thank the NOP to give me this opportunity to talk on this topic on orofacial pain. Thank you very much. As you said, the topic is going to be on neuromodulation. So for facial pain. So just coming to the neuromodulation, it's one of these fastest growing fields in medicine itself, to be honest. So essentially what we do in neuromodulation is going to be a therapeutic alteration of the nerve activity through the delivery of some electrical or maybe a chemical stimulus to the patient. So you can give a stimulus to the patient and you perceive pain, and that's what we normally do. But here what can happen is you can actually targeted stimulation of a particular nerve, you can alter the perception. For example, you would have all heard about the gate control theory, where a little massage on your head can actually make you feel better, your pain is improved, and that happens all the time. And sometimes there is a sensitization of the nerves where there is more pain than you normally would expect to perceive. So there is this neural plasticity which happens within the body, and that is actually utilized as a therapeutic device. And if you can deliver these stimulus to the patient, either chemically, as we discussed, like Botox, local anesthetic, or maybe you can change it by various other things like electrical, magnetic, light, or even sound. With these kind of things, you can actually change the pain perception, and that's exactly what neuromodulation. So you modulate the nervous inputs and thereby the pain perception. So going into this neuromodulation, it started about 40 years ago, the neuromodulation as a technique. But then the initial waves of neuromodulation in the 90s, when it was happening, it was more of failed back surgery, and to a certain degree, some kind of complex regional pain syndromes or the initial indications. Someone who had a spine surgery and it failed and they have got residual nerve pain, people were doing these spinal cord stimulators to control that pain. But slowly, as we started getting more understanding and the equipment is getting better, we started doing this peripheral nerves. So this is the second wave where some of the post-herpetic neuralgias, diabetic neuropathies, or maybe some of these pelvic pains, we started treating those things where a peripheral nerve is stimulated to get a control rather than the spinal target. Then the third wave happened, which is happening right now, where we have more understanding of the devices, newer technologies which are coming, and we are experimenting with the newer waveforms. Earlier, it used to be an electrical pulse, like what you see in a TENS machine. There is a little electrical pulse, and that's all. And whatever it is stimulating, we're getting a relief, and we are happy with that. Right now, we are using high frequency, almost like 10,000 hertz of electrical pulses are delivered per minute. And at the same time, the patient doesn't feel the sensation. By that, you're getting pain relief as well. The second thing which is happening is the burst stimulation, where like a normal electrical neural impulse, you are delivering a train of about 5 impulses all at the same time to get that pain relief. So that's the burst stimulation right now. So there are multiple waveforms which are being experimented, and they are going to be helpful to us. So lots of these things, along with newer targets into the cranium, like the deep brain stimulation, motor cortex stimulation, we will talk about it now. So first, for us to understand the peripheral nerve targets, so that is where the pain sensations are being transferred. Let us start from there. So now, if you're talking about the peripheral sensations which are happening, you've got the trigeminal, which is the biggest sensory part. And then you've got the the glossopharyngeal, and the spinopalatine ganglion, as Dhruv was talking just now, so which has got the autonomic things. So these are the three major nerves that we are talking about. So in the trigeminal, we've got the three branches. We've gone through it just now, the ophthalmic, maxillary, and mandibular. And there are minor branches which come from these nerves, which are the supraorbital, supratrochlear, and all the other infraorbital, auricular, temporal, all these nerves which are coming. You can actually target these peripheral nerves, both non-invasively as well as an invasive implant devices. So there are lots of techniques which we can utilize to modulate the nerves. So once the nerve is getting transferred, the pain signal transferred from the V1, V2, or V3, they start to go into the what is called the trigeminal.
Sorry to interrupt you. Your slides are not moving actually. So.
Oh really?
So
what? It got stuck there.
Yeah,
it happened before I could. Is it stuck there? I'm sorry. There is one.
Excuse me, sir, we are unable to hear you.
Yeah. Are we on the first slide?
Yeah, we are on the first slide, yes. Can you go to the second slide so that we'll see whether it is moving or not?
We are on the second slide now.
No, it's not visible on Zoom slide share.
I'm sorry.
Platform, yeah. You are on the second slide.
Right now I'm on the second slide. I move to.
You come out of slideshow and just show through that only, because sometimes slideshow is not working. Function 4 F4 is have you pressed?
Oh, you mean to say, yeah. Let me. Can you see now?
Yeah, it's visible.
Just a second then.
Yes. Okay.
So,
it's appropriate, yeah.
It's okay now?
Okay.
You're able to see? Okay.
Yeah,
so,
neuromodulation in facial pain, yeah.
Yeah. So, let me be there. Let me be there. Okay. So, what I was trying to say is, so far, there is this neuromodulation, which is altering the neural activity I was talking about. And you can have various things like various physical modalities such as electricity, magnetism, light, acoustic, sound energy. All these things can be utilized to change the perception of pain, as well as stabilizing the system in due course of time. And I was talking about the waves of neuromodulation. The first wave, pure dorsal column stimulation. Second wave, experimenting on the peripheral nerves like post-herpetic neuralgia, diabetic neuropathies, and so far. Third one, we're talking about the newer waveforms that we are talking, like the closed loop systems. We have burst stimulation, high frequency spinal cord stimulators. All these kind of newer waveforms have been experimented. That indeed has opened up so many newer opportunities to treat very complex pains like orofacial pain, unlike the old devices. Now, for treating the orofacial pains, first of all, we need to know the targets that we have for doing a neuromodulation. So this neuromodulation, most of these are coming from the trigeminal, as you've already discussed. And there are other things like glossopharyngeal, spinopalatine ganglion, which is more of an autonomic ganglion. Now, from the peripheral nerves, the impulses are traveling. As you can see in the picture, slowly they get traveled down into the what is called the trigeminocervical complex. It is a combination of two things. So there is a trigeminal component where the trigeminal is coming out, and also the cervical component. So there are multiple nuclei in the cervical complex, which will take inputs not only from the neck, but which is the myofascial structures from the neck, but it will also take the inputs from the vessels and the dura mater. With this convergence is why you will get majority of the cervical symptoms when you have a migraine attack or maybe a tension type headache. So with these kind of things, the confluence of these systems are because of the convergence. So there is this up and down signal movement for this one. So as you are looking at the trigeminal cervical complex, the pain slowly starts to go into the brain, from the midbrain into the cortex. So now we will look at some of the cranial targets that we can utilize to do neuromodulation. So basically, there are a set of things like the activating things, such as the periaqueductal gray, which is the most commonly activated complex, which will relieve the endorphins. And you also have got the ventrolateral medulla, which is present a little below. These are the two activating things, but the rest of the things like the somatosensory cortex, the prefrontal cortex, and few of the other cortices, they are more for inhibitory activities. So there is a balance which is there, and that you will utilize, and we will see that as we go along. And now, when you are talking about the neuromodulation with the advanced technology, not just implantable devices that we were using earlier, like the spinal cord stimulators, as I told you, we also have got non-invasive devices. Lots of these non-invasive devices are coming into the market. Quite a few of them got FDA approval. For example, we all know the humble TENS machine, which itself has got a good evidence, and it is efficacious in quite a lot of conditions. Similarly, you've got external pulsed RF, the transcranial magnetic or direct current stimulation. There are lots of these, vagal stimulation, lasers, Botox, which is a chemical neuromodulation. There are lots of these things. Along with the implantable ones, we will go a little into each of these. I'm just trying to give you a flavor of neuromodulation, what can be done for this orofacial pain. It is not possible to go into quite a fine detail into each of these things because there are so many of them, which I myself realized as I'm trying to present it to you. So when we are talking about TENS is full form as in transcutaneous electrical nerve stimulation, where you deliver minimal low voltage currents to the skin through an electrode, and slowly it travels through the skin and into the nerve fiber, and it basically works on the gate control theory. For the people who are not very well versed with the gate control theory, what happens is in the pain nerve fiber, in the sensory nerve fibers, you have certain pain fibers which are very fine ones, and you have certain fibers which are thicker ones, such as the pressure ones, the touch ones. These are bigger myelinated nerve fibers. So basically, when you are applying a pressure, for example, when someone has got a headache, you apply a band around the head, correct? So exactly in the same way, when you apply a band, how the patient is getting some amount of relief. When you apply an electrical current, this opens the gate for the pressure while it is closing the gate for the pain. So that's how the gate control theory works. You may not be able to explain all the pain symptoms that a patient gets, but this will help for most of our neuromodulation purposes. So this TENS, which works on this principle, can help in quite a lot of conditions which are mentioned there, including the facial nerve pain, also trigeminal neuralgia, some of the TMJ symptoms and things like that. So recently, there is there's the only meta-analysis that I could find for TENS, which is indeed effective, at least in the short term. So there is a reduced number of monthly headache days as well as painkiller intake. Similarly, the response rate is not that bad from the patient point of view, and they are reasonably satisfied. So there is a role for TENS. Now, another one similar to TENS is the external pulsed radio frequency. You use it quite regularly. So basically, with an external pulsed RF, what you get is there is a tense-like waveform, as you can see on the left, top left, but there is also an electrical, the radio frequency waveform, which is superimposed onto the electrical waveform. Together, they form the pulsed radio frequency, the external pulsed radio frequency, which is called as a machine called stim pod. This electromagnetic waveform, it basically alters your metabolic activity of the affected nerve. So it will have specific crosstalk somewhere. So there is a specific thing which is happening here. All the parameters that we'll have to set on the system, you choose the lowest current that is possible, and then gradually increase it to the highest tolerable level, and then you do about 10 minutes per session. You do about 9 to 10 sittings per patient, and what you can see in this trial, they managed to reduce the pain by about half. At the same time, the facial pain activities and the general patient activities, they're also improved by more than 50%. So there is a role for pulsed RF too. Now, another one which is talked about very much these days and being extensively studied is the repetitive transcranial magnetic stimulation, this RTMS, which is there, where, as you can see in the picture, where the current is coming, goes through this induction coil, and as it is going through the coil, as the current travels here, you are developing some magnetic field around that. And this magnetic field, when you are directing it onto the brain, you will start to develop certain induced current inside the brain itself. And when you develop this current, you can alter the conduction. So basically, you can change the excitability of the area that you are stimulating. The commonly stimulated areas would be a motor cortex M1 and the prefrontal cortex, as we discussed earlier, as well as the secondary somatosensory cortexes. So these are the common things that we utilize. So essentially, within these, depending on the frequency, you can either excite the nerves or inhibit the nerves, so thereby producing some pain relief to the patient. So that is the functioning of a transcranial magnetic system. The next one, if you look at the transcranial magnetic system, it has been utilized for a variety of medical problems, starting from psychiatric problems like anxiety, depression, dysphagias, and various other cognitive dysfunctions in neurology, generalized fatigue, and all sorts of things. But then coming into pain, it has got a role both in acute and chronic pain. Not just that, for our topic, which is the headaches, where you are looking at on the right hand side in the top red box, what you have is migraines, cluster headaches, various trigeminal neuralgias, and very refractory pains. You could use transcranial magnetic stimulation. And how does that work? So you basically, it works on the NMDA receptors. So when you have these kind of pains in the cortices, somatosensory cortex and other places, you have activation of your NMDA receptor. So what the RTMS is doing is, it is trying to counteractivate the LTP, the long-term potentiation of these things. So that's what it is doing. Similarly, the inflammatory mediators, interleukin 10 and TNF alpha, which are elevated, and this is trying to reduce. Similarly, the neural sensory cells which are there, it helps in proliferation of those cells. So, and then there is increased dopamine, which is the happy chemical. When these things happen, patient will start to get a decent pain relief. Similar to RTMS, we also have direct current stimulation, where again, like TENS, we use low-level currents externally. There could be either a direct current or an alternating current, AC or DC. You can use both of them. And then you activate the similar kind of nerves like the magnetic stimulation. Again, apart from having some unpleasant sensations, this also has got a role both with TM joint dysfunction as well as orofacial pains. Another light-based modality is the lasers. Lasers have been extensively used during surgeries. They've used for plastic dermatological conditions. So a lot of work has been done on lasers, but laser also has got a role with our healing as well as pain relief. So that's what the laser is. When you use a low level laser, here use a single wavelength for producing the light. Usually it is in the range of 800 nanometers, 900 nanometers. These are two wavelengths that are commonly used. And then you start to deliver this monochromatic light onto the affected tissue. You direct it to the distance. Depending on the distance from the tissue, the machine will give you a guidance. So you deliver this, and then that will help to heal the affected tissue. Lasers have been proven to be effective for trigeminal pain, post-herpetic neuralgia, and most of these other TM joint dysfunctions and mucositis, toothache, etc. So let's see how a laser works. Generally, when you are delivering this current, the laser goes through the skin, reaches the cell, it affects the mitochondria, and there it actually causes three different things. Basically, it will help to release the ATP. As the ATP is released, it will help for regeneration as well as fighting infections. So that is where the laser has got a role. Similarly, the reactive oxygen species which is produced, it is going to positively impacting the cellular repair and healing like ATP. So there are a myriad of things from the mechanism. Lots of things have been postulated which are supposed to be the actions for lasers, and there is a lot of evidence which is going around that. Now, another chemical neuromodulator that we talked about is Botox. Botox specifically for orofacial pain, like trigeminal neuralgia we're talking about, when you give it into specific areas, like 5 units in each of these areas, you can have a decent analgesic effect. How does Botox work in neuromodulation? It is generally taken up by the nerves. Unlike the mechanism that they describe for the plastic surgery or dermatological things where the wrinkles are removed, there is a slight difference here. It is taken up by the pain nerves. It travels both the retrograde as well as anterograde along the nerves through the microtubules, jump through the synapses, and it will end up in the cranial areas. Similarly, in the DRGs and the spinal centers. So it works both peripherally in the lower limbs for neuropathic pains, and it has been investigated for migraines. And more importantly, now there is evidence mounting for trigeminal neuralgia, where you could do both into the nerve near the trigeminal ganglion. You can also do into the periphery and the mucous tissues. So that will help. So generally, you give about 75 units of this, about 5 units per place per spot, and it is given both into the intradermal as well as submucosal injection. It's very simple to do, provided you understand. You don't go too deep into the skin, where you can block the muscle, and you can have either a ptosis if it is in the supraorbital, and you can have a flaccid patient on the face. They don't like it. So you have to be a little careful in giving it. Otherwise, Botox is very helpful. And just for you to understand, these are the pictures for migraine. So these are some of the locations for Botox injections, which is Procerus, corrugator, and all these these are more of muscular injections. This is not what we are targeting right now. Now, coming back to the electrical neuromodulation again, for migraine, you have another device called Kefli. This is FDA approved right now. It actually activates the frontal, the nerve pathways, and you can do an acute treatment, but also you can do a preventive treatment with the Kefli. You can have an acute session, having a 60-minute session for acute migraine, but then you can prevent it like giving it every day for about 20 minutes, and there is a good response. Almost like, as you can see, close to 80% of users feel a pain relief 1 hour after an acute treatment. So that's a a decent response. Similarly, there is another thing which is called as a vagal nerve stimulation. And this vagal nerve stimulation can be done, historically it was done as an implantable device. But these days, because it is so close to the skin, we can also do it as a non-invasive. The device is called as Gamma Core. And once you are doing it, it has got FDA approvals for cluster headache and then migraines. So for cluster headache, it is both for acute and chronic. You really have to refill the device every month. There is a cost associated with the refilling of the device, but it will help to modulate the pain signals. And in the non-invasive vagal stimulation, there are newer devices, not just on the neck, but you can also do transauricular, and there is also a percutaneous auricular device that can be used where two small tiny needles will be puncturing the skin and not very painful, but that can give a lot of good pain relief. That's called as a PA1s. So moving on to the
Dr. Vijay, we have the other speakers on queue, and
that's
we are
fine.
already delayed, so we take a time, not a problem, but try to finish as soon.
Yes, we'll just go quickly then. Okay, so that's absolutely fine. So this is the most important thing anyway. The other things, they may not have much interest anyway, because most of them are dentists. So the next thing is the peripheral nerve stimulation that we use. These are done by the pain doctors regularly. In this, you have pulsed radio frequency. Usually you will have a 42-degree pulsed radio frequency. You can give it onto the trigeminals and various other nerves. Due to the pulsed RF, as you can see in the picture, it is reaching up to the trigeminal ganglion, and the pain scores, they will reduce from about 7, 7.5 down to about 5, which is going from a severe down to the moderate level. And then you have various implantable neuromodulation devices. In the implantable neuromodulation devices, what you have, the occipital nerve stimulation, as Dhruv was talking about, the greater occipital, and similarly you have lesser occipital, least occipital, or third occipital. So all these kind of nerves which are present on the back of the brain, they can be stimulated with these 8 contact electrodes, and you can deliver this electricity like a TENS machine, but internally with a very low voltage you can give it, which is more comfortable to the patient, and you can use continuously. Similarly, we've talked about it earlier. Dr. Sharma was talking about the supraorbital, infraorbital nerve blocks, but you can do a continuous stimulation of these supra, infraorbital, and a combination of supra, occipital, all these things, they can be done. Similarly, there is auriculotemporal nerve stimulation. Along the auriculotemporal nerve, starting from the tragus into the temporal area, you can stimulate it, and there is good evidence for the TM joint syndromes with this. And now we were discussing about the spinopalatine ganglion block. Now you have a spinopalatine ganglion stimulator, where you will implant this electrode into the spinopalatine ganglion, and you have a remote to operate it, and you can continuously stimulate for your comfort. So this is a very small device. As you can see, the whole electrode is only 1 centimeter. It's a micro electrodes that we have. And you have these vagal nerve stimulators, and they are also pretty helpful for cluster headaches and migraines and various other things. Vagal nerve stimulator has very many indications, not just for pain, for various other reasons it has been used. And these days we have trigeminal nerve stimulator for refractory pains which are not getting better with your usual medications or the ablations. Then you can implant an electrode directly into the Gasserian ganglion and get a good stimulation with pain relief. So this is another one, which is a high cervical spinal cord, where an electrode is placed in the epidural space, reaching up to the close to the C2. And I talked about the trigeminal TCC, the trigeminal cervical complex I talked earlier. You can stimulate the same thing on a continuous basis using a high spinal cord stimulator. Now, these are the 2 things which the neurosurgeons would be doing. What we have is a deep brain stimulator, very specific areas. The periaqueductal gray and the thalamus regions, they're stimulated using the deep brain, and you can get good pain relief. And that is also proved to be effective for facial pain recently. And that is how you actually get it down into the thalamus through the skin, and it is an implantable device. So there is always a problem with damaging the surrounding nerve tissue, both due to stimulation as well as placement of the device. So that's the DBS, and this is motor cortex. So you have the motor cortex on your brain. You can stimulate using certain electrodes which are implanted on top of the brain, and with that you can actually use that. But then there is an issue with the response rate for facial pains with this. So it can be used, but there is minimal response. So I think I'll stop there. And thank you for your patient listening. And if you have any doubts, let me know. It's a huge topic on itself. So we try to put few things in perspective. Thanks, Dr. Nirvi.
Thanks, Dr. Vijay, for throwing light, though it is this different topic for our audience. Those most of them are oral health procedures, dental surgeons, oral surgeons, but still they know how neuromodulation is helpful in managing facial pains and all. So we are very thankful for sparing your time and joining in our National Orofacial Pain Congress 2023. In audience, if anybody want to ask any question, they can unmute their microphone and ask the question right away, live, or they can put it on the chat.
So quite a lot of these things can also be utilized on an OPD basis. So which is what I tried to cover. Keep the invasive things and the implantable devices to the minimum. I just mentioned those things, but the other things, they can be used in an OPD setting or maybe even by physiotherapists.
Yes, of course, of course.
So, yeah.
Okay, thanks, Dr. Vijay, for joining us, and we'll keep on inviting you in our next edition for these Nopcon. Maybe we'll do in the next time. Thanks for joining.
Thank you. Thank you very much, sir.
Yeah. So we have a privilege. We are moving to the next session. We are privileged that we have a young dynamic lady, Dr. Minal Chandra. She is with us. She is co-founder and consultant pain specialist in Apayon Center for Pain Relief and beyond that. So she is joining from the city of Biryani, city of Charminar. Dr. Minal has worked as a pain specialist in some of the prestigious medical organizations of India. In her stint of 8 years as a pain specialist, she has treated over more than 25,000 patients in her clinic with chronic pain and headache successfully. Her dedication and compassion towards the treating patients are held a high regard by her fellow pain specialists, and she adds a huge value to Apayon Center for Pain Relief and beyond that. She has been awarded for India 100 International Pain Management. During her fellowship under the Dr. Sudeep Pioneer in Pain, Dr. Minal gained valuable experience in treating complex cases of chronic pain conditions. And her major area of interest include regenerative therapy like PRP and stem cell therapy for chronic pain, and a multiple of headaches, including migraines, cluster headache, etc. She is here to talk about PRP, plasma-rich platelet, which is being used in treating temporomandibular disease. So, thanks, Dr. Minal, for joining us in our second edition of National Orofacial Pain Congress 2023. Over to you, Dr.
Thank you, Dr.
Thank
you, Dr. Anwar, for the beautiful introduction and for the invitation of this talk. And regenerative therapy is something that I practice a lot, and so it is very close to my heart, and I love talking about it and sharing my experience. So I would like to start and share my screen now.
Yes, you are.
So is it visible, and
It's
can I go
visible.
ahead?
Yeah, it's visible. You are audible. Continue, please.
Yeah. So PRP therapy for TM joint dysfunction, we have seen different modalities. We have understood the TM joint pathology, and we have understood that what are the different modulation and what different techniques for treating. So this is PRP therapy, regenerative therapy. We have come from an era of nerve block to era of ablations to era of neuromodulation. We saw the last three talk where Dr. Sanjay was talking about the nerve block. Then we have Dr. Dhruv talking about the ablations, and then Dr. Vijay Bhaskar talking about neuromodulation. So it's a long journey, and over decades of years we have come, and now we are into an era of regeneration. So this regenerative therapy is basically a branch of medicine that we deals with the process of replacing, repairing, and restoring the normal tissue and function. So in this, when we practice this regenerative medicine, we are not only treating the pain, we are also treating the cause of the pain. So we are restoring the normal function, normal tissue function. Now, why I say that there is work in progress, because it's a new branch. There are lots of work which is happening, but still we have a long way to go. We have a lot of researches to happen. We since yesterday we have been seeing that what are the TM joint pathology. So TM joint disorder, the orofacial pain in TMJ, it involves the pain in TMJ, the mastication muscles, the head and the neck, and the other musculoskeletal structures. Around 5 to 12% of the population will have this TM joint disease, and among this, the majority of the cases are of osteoarthritis. Just after chronic low back pain, TM joint dysfunction is the second musculoskeletal pathology that causes impairment. So this is the basic. Keeping this into mind, we'll go ahead. Just coming to the pathology, the TM joint dysfunction can occur because of the hypo parafunction of the muscles around, because of the traumatic injuries or any hormonal changes or joint changes happening, leading to a disc displacement, disc degeneration. And if just like any other structures, just like any other joint, the TM joint osteoarthritis is also common, and there will be degenerative changes like destruction and loss of articular cartilage. There will be subchondral osteosclerosis, osteophyte formation, subosseous microcapsule formation, and synovial inflammation. The patient will present to us with muscle pain or joint pain. There will be a clicking sound from the joint. There will be a limited range of motion of the TM joint. There may be deviation and deflection of the mouth opening. Most of the time, there will be the patient will have psychosocial factors like stress, depression, anxiety associated with it, and patients may complain of headaches, earache, toothache, nerve pain. So all those things a patient of TM joint dysfunction can present with us. Now, why is it important for us to understand this? Is because we always prefer, we should know that what we are treating, what is our aim to be achieved, and how we are going to achieve this. So as a pain physician, the aim to be achieved is a reduction in the pain, to normalize the range of motion, to prevent the progression of the joint damage, and strengthening of the muscles which are supporting the joint. So our aim is to decrease the pain and bring the normal function of the joint, and also that we prevent the further progression of the disease. This can only be done in a holistic approach. Could be achieved with when we apply our interventional therapy, then we have a lifestyle modification, physical therapy, sometimes a pharmacotherapy. So unless and until we combine all of this, we are not going to achieve our desired result. So that is why it is very, very important that what patients complain of, symptoms, what are the symptoms the patient complains of, and what are the other associated symptoms. So once we understand the symptoms, signs of what patient is going through, then we have to define what is our aim, and then we have to prepare a holistic approach towards management. The most important thing is counseling of the patient. Like Dr. Dhruv was talking, how counseling is very, very important, because we are now opting for something which is a very new treatment modality. So we need to understand what patient is expecting out of us and how much we can give to the patient. So explain the condition to the patient. What is the present condition? How much is the damage? Explain the procedure, how we are going to do it, what could be the success rate, and the requirement of doing it into multiple sittings. how much time is it going to for the patient to get the desired result, the need to follow the rehab and the do's and don'ts, which will be explained by the clinicians after the sittings. So these things should be very clear in the mind of the treating clinician and also into the mind of the patient. Give a clear picture of the condition and a clear picture of the treatment that you are going to offer to the patient, and do not give any false hopes to the patient, because again this is going to lead to disastrous result. So when we come to platelet-rich plasma, platelet-rich plasma is just an autologous product of our own blood cells. When the concentration of the platelet is 2 to 8 times from the normal baseline, then we called it as platelet-rich plasma. Platelets will have more than 30, actually more than 300 bioactive proteins that will help in healing and homeostasis, angiogenesis, and other mechanisms that will happen at the cellular level. The active secretion of these growth factors by the platelet will begin within 10 minutes of activation, and within an hour, the 95% of the growth factors will be secreted into the site. So what is the mechanism and what is the science that PRP is going to do? So the bioactive proteins and the growth factors which are being released from this platelet will have antimicrobial action. It has anti-inflammatory action. It is going to provide angiogenesis. It promotes the healing fast. It regenerates the damaged tissue, restores the function, and is also chondroprotective. So we have other interventional therapies also where we try to take care of the pain. But the PRP is, why PRP is different is because it is going to restore the function and also prevent the further degeneration and degradation of the tissue. Now, this is a flow chart to show how PRP is prepared. There are lots of commercially available kits available in the market. So, depending upon which kit you are using, the preparation of the PRP differs. So, this is a very almost like minimally invasive technique. With the help of a small venipuncture, we take some quantity of blood. Then we, under all aseptic condition, we transfer it into the commercially available kit, and then according to the guidelines, we do the separation. So few kits allow for 2 separation, few kits will allow for a single spin preparation of PRP. So this flowchart shows how easily this procedure of PRP can be done, and without any hassle, without any complications to the patient. Like I was mentioning, we have different kinds of kit available in the market with different techniques, and different volume of PRP can be extracted. Now, TM joint is a small joint with a capacity of around 1 to 2 ml. So minimal amount of PRP, 1 or 2 ml can be extracted from these commercially available kits. So very important when we do PRP is when we expect the success of PRP is how what is the technique of injecting the PRP, and how important is how you're preparing the PRP. So the concentration of the platelet that you need should be well analyzed, and so whenever you're using your kit has to be, make sure that you're using if not FDA approved, at least use the FDA cleared products. And when you inject, the technique should be very clear. You should be able to identify the TM joint, and as a pain physician, we always prefer to do it under image guidance. So whether it can be a CM guided or it can be an ultrasound guided. So the technique of doing it has to be very sharp and clean, so that we are not harming the patient and we get the desired result. So consent from the patient is important. Monitoring the patient, how small or how minimally invasive it may look and sound like, but it is very important to monitor the patient while doing the procedure. And we prefer to do the procedure in operation theater under all aseptic condition, under the use of CM or ultrasound. Because it's a joint, I prefer to do it under CM guidance. The advantage of CM guidance is that you can do a dynamic movement. You can ask the patient to open and close the mouth, so that you can identify the joint. And ultrasound guidance also is very helpful. Using a very small 26 gauge needle, we can inject under fluoroscopy. We can first give local anesthesia and then inject 1 to 2 ml of PRP. We need to monitor the patient for at least half an hour in the recovery room. So this is the injection technique where where I prefer to do it under image guidance. So you see in this image where we have asked the patient to open the mouth so that we identify the joint space. So you see this is in the open mouth, and here I have with the closed mouth the needle trying to inject into the joint. Then again in fluoroscopy, we have that advantage of confirmation that the needle tip is in the joint or not by giving a dye spread. So this is the dye which has been injected and the dye has spread all around the joint. And then we can inject 1 to 2 ml of PRP. Again, the success of the PRP also lies on the post-procedure care that you're offering to the patient. So you need to tell to the patient that whichever side is affected, you need to stop chewing from that side for a while. Activation of all the muscles around. So we know that the pterygoids, the lateral and the medial pterygoid, and the hyoid muscles, the geniohyoid muscles, and all other muscles surrounding it needs to be activated because all those muscles are also into the spasm. So activation of all these muscles through a good rehab has to be very, very carefully done by the patient, and the clinicians need to tell the importance of these rehab techniques. We usually ask the patient to apply ice for 2 days post procedure because we expect some kind of inflammation and the pain may increase. So, and because we cannot prescribe any kind of anti-inflammatory or NSAIDs post procedure for like 5 to 6 days, so we ask the patient to apply ice so that we combat any kind of inflammatory pain post procedure. Rehab to increase the range of motion. Most of the time, the range of the motion will be restricted. So once we have given the PRP with the anti-inflammatory property of PRP, the pain may come down within a couple of weeks. And then we have to start the rehab to increase the range of motion, because that is one of the aim that we opt for, that the range of motion of the joint has to be improved. And taking care of the other associated symptoms like the headache, earache, patient may have tooth pain. So all those things, associated symptoms, what the patient has complained has to be taken care of by other modalities. By and large, this PRP therapy or regenerative therapy for TM joint is a very simple procedure, and usually we do not need any technically high skills or any other high skillful things. But in very few conditions, the contraindications apply for. So in case of patient refusal, in case of thrombocytopenia, if the patient is on anticoagulant therapy, any active infection at the site, an active tumor or metastatic disease, and in pregnancy. So these are only the conditions where we don't offer PRP therapy to the patient. Now coming the most important thing is what the literature says. So we have quite few of literature which have favorable effect, which have favorable result when PRP is concerned. So in this one of the review literature, they have concluded that when they have compared arthrocentesis alone or with the use of hyaluronic acid, the biological products have given better and encouraging results. Again, this was a 3-month follow-up pilot study for TM joint osteoarthritis, where they said that majority of the PRP patients, they showed decrease in pain, and the pain score has come down from an average of 7 to an average of 3.5. And another study which shows that intraarticular PRP has not only was effective in treating the pain and also in the functional improvement. So even the literature, there are few positive literature which says that we can always give this regenerative medicine, regenerative therapy, PRP therapy for patients with TM joint dysfunction, and especially beneficial for patients with TM joint osteoarthritis. So why we would prefer for PRP is because of its scientific underpinning. We know that the growth factors which are present inside the platelets have its own mechanism by which these growth factors will be released and will lead to healing of the tissue. So there is a scientific underpinning. The ease and relative non-invasive nature in which it can be obtained. So we saw how easy it was to take a few ml of blood of the patient, process it in machine, and inject it with the help of a 26 gauge needle in operation theater, which can be done over a period of like in 40 minutes to 1 hour, and the patient within 2 hours the patient can go back home, and it's well established safety record. So PRP is one of those medical treatment modality where the safety records is very, very high, because we know it's an autologous product, so there is no side effects. Though we have seen patients coming with mild inflammation or swelling, and so we need to explain this to the patient, and for this reason we always ask patient to apply ice for 3 to 4 days post procedure. So the take-home message would be that refractory cases, chronic refractory TM joint patient, which is actually very debilitating, can be treated with platelet-rich plasma therapy. But we need a multidisciplinary approach because it is not always the joint. The associated muscles around it, the ligaments and other structures needs to be taken care of. So it has to be in a multidisciplinary approach where we use pharmacotherapy, where we use physical therapy, rehab, and interventional therapy. The result of the platelet rich plasma depends upon how you're preparing and how you're injecting. So preparation technique of plasma is very, very important. What is the concentration of the platelet that we require? So we have a lot of commercially available kits, which and the literature, they also provide us with literature and the technique. So if we properly apply those techniques, the yield what we get is will be rich in growth factors. And the injection technique. So like I said, doing a blind procedure wouldn't be a very good choice now. So image guided injections like under fluoroscopy or under ultrasound is the best to do. So we know that we are exactly into the joint, and wherever we are injecting, the PRP is well absorbed into the joint. Explain the do's and don'ts to the patient. So like I said, when you're talking to the patient, when you counsel the patient, you need to explain what are the do's, what are the don'ts, and you need to explain the efficacy of the result. You need to explain the success of the result. And the literature, there are literature which also supports that PRP in biological products have results better than steroids, hyaluronic acid, and other treatment modality. So these are my center which we are now having. We have 2 centers in Hyderabad. This is our sports center. This is our center where we practice a lot of regenerative therapy. This is our Chennai center, and this one which we have started in Bangalore. And now we are expanding, and we are trying to bring revolution with regenerative medicine. So we are collaborating with anesthesiologists, orthopedics, radiologists, neurosurgeons to come together and bring this medicine up, because it is non-invasive, it is minimally invasive, and the results are really, really, really good. So if anyone is interested, they can contact us. Thank you so much.
Excuse me, ma'am.
Yeah.
Question. For PRP injection, where exactly we have to inject into the upper joint space or lower joint space?
See, getting into the lower joint space will be really difficult. So what we do is, with the help of fluoroscopy, we can only approach to the upper joint space. So there is what we try to inject. And because the communication lies between the upper and the lower, we can the PRP will definitely spread there as well.
Okay. So what is the maximum amount of PRP injection, ma'am?
See, the joint capacity would be somewhere around 1 to 2 ml, and in that around 0.5 ml would be dye. So the best is to give around 1 to 2 ml, depending upon how smoothly you are, able to inject the PRP.
So how many settings we can inject, ma'am?
That's what we have seen, that usually with TM joint, single sitting will suffice, but for the need for the further sitting should always be counseled to the patient beforehand. So if we get a patient who is getting good relief, maybe 50-60% pain relief with one sitting, then we can again offer the patient to do, because these are very simple, and these are also counterprotective. So we can address to have multiple sittings as well, because it's a small joint, maybe 1 or 2 sittings will suffice. When we do bigger joints, like in our protocol, when we talk about regenerative therapy, we don't have a standardized protocol, so it is always institutional. So we do a lot of large joints, like in knee joint, shoulder joint, so we use multiple sittings, like 3 or 4. But I think in small joint like TM joint, with a good rehab, 1 or 2 will definitely suffice.
How much should be the gap duration between the 2 settings?
The minimum gap should be at least 15 days, because see, the platelet, the entire process of platelet will be at least for 7 days. So the inflammatory process remains for at least 7 days. So you can do it after at a gap of 15 days. There are also literature which says that you can do it after a gap of 3 weeks or 4 weeks. So like I said, there are a lot of literature with different intervals in between. So you can opt it for doing it after 14 days or 21 days or 1 month, but definitely not within 1 week, because that is the time when the platelet growth factors are being released. So we need to give that time till the platelet turnover is, one cycle of platelet turnover is over.
Okay. Thank you, ma'am.
Thanks, Dr. Minal, for joining us and throwing light on how to use PRP for treating TMJ disorders and all. And I think the audience who are here definitely get advantage out of it, because they are mostly dealing with TMJ problems. Thanks for joining us, and if you have a time, stay with us. We are still continuing. So we are moving to the next.
Thank you, Dr. Anwar.
Yeah. So we have a privilege. We have a special academician who is joining Southern India, deep Southern India. We have Dr. Pratibha Mashe. She is associate professor and she is head of pain and palliative care unit, Department of Anesthesiology, JSS Medical College, JSS Academy of Higher Education, Mysore, Karnataka. She did his MBBS from BJ Medical College, Pune, and PG from TN Medical College, Mumbai. She is fellow of Indian Academy of Pain Medicine, and she is Best Low Cost Pain Treatment Award she got at the National Pain Conference. She is past acting registrar of Indian Academy of Pain Medicine. She is also president of ISSP Karnataka chapter, and she is associate editor of Indian Journal of Pain. And she is program head of IAPM affiliated and JSS University Fellowship in Pain at JSS and MC Mysore. She presented several papers and invited faculty of state and national pain conferences. Thanks, Dr. Pratibha, for joining in Nopcon 2023. Over to you. We have made you a co-host, so please share your slide and continue. Could you please unmute your microphone?
Yeah,
Yes.
can you hear me?
Yeah, you are audible. Yes.
Yes. So good evening, and thank you so much, Dr. Narul, for that introduction. And I think we have had wonderful lectures so far. I don't know how much it was of use or for the dentist, but I'm sure that they are able to get that scope of orofacial pain, how far it can go. I always love these interdisciplinary meets because there is always so much of knowledge exchange that happens. I have also been listening to a few of the lectures from yesterday and come to know the perspective from the dental point of view. The same way, I'm sure that for all the crowd here, the perspective from the pain physician's point of view also would be really valuable because ultimately all of us are working for the aim of giving the best treatment for the patient. So today I'm going to just go ahead with my talk, that is diagnosis and management of trigeminal neuralgia. And I bring greetings from the royal city of palaces, that is Mysuru, and that's my hospital I'm very proud of in Mysuru, Karnataka. And you all know that who doesn't know Salman Khan? So he is the one who suffered from trigeminal neuralgia. I don't know how many of you know that. So coming to the definition, it is a neuropathic disorder which is characterized by the paroxysmal episodes of sudden severe unilateral pain, which is most of the times described as an electric. Yeah.
Ma'am, you are sharing slide or you are without that, because we are not able to see your slide here. Yeah.
No, Dr. Noor, the slides are visible, doctor. Very much visible.
Yeah. Okay.
You're able to, all of you are able to see my slides?
Yes.
Okay.
Please continue.
So, yeah, so it is the trigeminal neuralgia is usually defined as a neuropathic disorder which is characterized by the paroxysms of sudden severe unilateral pain, which is described as an electric shock kind of a sensation in the distribution of one or more branches of the trigeminal nerve. It is very common in the old patients and young.
Doctor, I am sorry to say I am able to see them, but most of the participants are not able to correlate with the slides. So if you could go back and share the screen again. Thank you, ma'am.
Okay, I'll do that.
And you can press F3
So
also. That is also.
no, I'll do stop share now. Can you see now? Can you see my screen?
Not yet.
Oh, ma'am, it's not visible.
Can you press F4?
F5.
F5 rather, no.
Function 5.
Okay, now?
We can see the screen, but you can just share the screen now. That would be great. Like that will be a full screen mode.
I have already done that.
Yeah, I can see, but I'm not sure about others. Like,
No, then how is that only one person is able to
Uh,
see?
it is actually there are two screens shared right now. So
And
on the top left corner, you can just choose Dr.
Dr.
Meenal.
Dr. Minal, could you,
She has
unshare
to
that,
stop
please?
sharing.
Yeah,
Yes.
please.
yeah.
Is it done?
No. So both the slides are, could you please stop sharing slide, Dr. Minal?
You'll have to call her.
Just wait. I'm doing that. Yes, ma'am.
Shall
Your
I go
slide.
ahead?
Yeah. You can go ahead. Yes.
So is it visible now?
Yeah, it's visible.
Okay, so as I said that it is more common in old people than young, and females are affected more than males. Right side is affected more than the left side, and the distribution is mandibular nerve is affected more than the maxillary and then the ophthalmic nerve. But also we see the combination of V2, V3 is also very popular. Now coming to the classification, trigeminal neuralgia is classified into primary and secondary. Primary is again divided into classical and the idiopathic. Classical is the one which is there is an evidence of vascular compression, like there is a neurovascular conflict with the superior cerebellar artery and the anterior inferior cerebellar artery compressing at the root entry zone of the trigeminal complex. And the idiopathic, there is no cause. And the secondary ones are secondary to multiple sclerosis or the posterior fossa tumors, CP angle tumors. Now, in the classical trigeminal neuralgia, because there is a compression of the nerve root by the vascular loop, there is a constant irritation of the trigeminal root that is happening at the root entry zone. And this causes the focal demyelination of the afferent fibers, causing the aberrant discharge. And this results in a trigeminal neuralgia. So now coming to the clinical presentation that I'm sure that all of you would have seen cases of trigeminal neuralgia. They usually come with the paroxysms, or they say that I get the attacks of pain. And most of the time it is on the one side of the face. If it is bilateral, you should always have a strong suspicion of multiple sclerosis. So the pain is always spontaneous. It is sudden onset. Like they say that I don't know when it will start. It will be like severe in intensity. It's described mostly as a shock kind of a sensation, which will come, last for a few seconds, and then it will go. And then there is a complete symptom-free interval between the two attacks. Most of the times, this is stimulated by some triggers. And I'll just talk about those triggers later. And in some atypical cases, mostly it is the paroxysms of attacks and in between symptom-free interval. But some cases, they also have a continuous background pain, and then they will get attacks in between. So this is very important for you to know the trigger zones. So the trigger zones are most commonly located around the cheek and lip, nose, and the buccal mucosa. So pain will be triggered by touching of the face, washing of the face, brushing their teeth, when they're chewing, eating, talking, laughing, when they're going on a bike, or they're sitting in the bus and the car, and when the wind is coming. So it is very difficult to lead a normal life for them. Mostly people you will see, if it is an ophthalmic division, then the eyes will be all dirt will be there. If it is V2, V3, then the moment they come near you, it will start smelling so bad because they wouldn't have brushed for a long time. They wouldn't have shaved. Mostly their beard will have grown. So it's very classical and it's quite painful. So they will avoid doing these things, or some of them will have also covered their face because any trigger kind of exposure to wind will cause the attack to come. So these are some of the cases that I wanted you to show. This is one of the case on the table before the RFA ablation, which we had planned. The patient had an attack and he just was not able to control. And then you can see that the attack is over and he is comfortable. This is another patient recently we saw. She had, the moment she came, she had an attack of V1 division of trigeminal nerve. And this is another lady. So they are very, very, it's also called as a suicidal disease. It's one of the most painful condition wherein people will want to just end their life because they don't know how to deal with this, because their daily activity, their daily routine, imagine not able to talk, laugh, eat, brush their teeth. These are the basic things that anybody will want to. This is the minimum basic what everybody want to do in their life. So some of the patients, like I think Vijay also spoke about something called as a trigeminocervical complex. So some patients also have atypical presentation of not the classical pain, but the pain getting referred to the non-head and neck structure. And this is because of the convergence of the cervical spinal nerves onto the trigeminal nucleus. So now not always what I showed in the picture, the patients will come like this only. So since I work in a medical college, I tend to see all kinds of cases because tertiary care center, and I feel very proud that our dental college and hospital is one of the best. There is lot of awareness about all these things, and we get lot of references also from dental college for the trigeminal neuralgia. So many patients who are in the early disease course, they may not have this severe complaint. So in the initial phases, only problem is diagnosis. In the initial phases, it will be like a very, very mild attack that they will get. It may not be that severe intensity. So they will just get a mild pain, which will come for a second and then go. It may come to start with in a weekly once, then it will become 2-3 days once, then it will become every day, then it will become daily 2-3 times, then it will be daily 6-7 times, and up to I have seen kind of 50 to 100 times also. Like it becomes every now and then, off and on, off and on. So over a period of time, it will progress. It is very important that they go to the right person, they get the right diagnosis done, they get started on treatment, or if it is required, they undergo surgery or the interventional pain management. So that is what happens over the progression. And here why I have put this slide is when they come in the initial phases, what I have also faced is that most of the times when these patients are coming, they are coming to the dentist when it is a very mild pain and it is in the territory of dental part. They feel that it is some dental issue and they go to the dentist. So it's very, very, very important that the dentist know how to diagnose trigeminal neuralgia. I would say that most of the times patients who have come to us, they will have undergone some or the other dental treatment. And I feel at times really sad that the dental treatment that has given, that has aggravated their pain. I have also seen one person whose all teeth were removed. He was completely edentulous over a period of 2 years. Every time he used to have pain, he went to the doctors all over the city and small places, everywhere, whomsoever he knew. And everybody had done extraction for him. And at the end of it, he was completely edentulous. And then he was, I think, referred to the neurologist, wherein he got diagnosed because there was a vascular loop which was there. And then he was referred to us for the interventional pain management. So what I would like to tell is, it is very essential for a dentist to diagnose this condition. You can always give a trial of tegretol instead of directly going in for the procedure, because that might aggravate. Or you could always take in, refer it to the neurologist, get an MRI done, see whether it is there is an evidence of vascular loop. So that is one of my aim for this talk also, that it is very important for dentists to diagnose the trigeminal neuralgia so that they don't land up into the further problems. So another thing, that once trigeminal neuralgia is mostly a clinical diagnosis. It's a very classical symptoms of paroxysms of unilateral facial pain in symptom-free interval in between, and then it progresses over a period of time, and excellent response to carbamazepine. But what physical examination, that is another classical thing, is you will always have normal neurological findings. You will not have any sensory motor deficit. The patient will be completely normal when it comes to the neurological examination. If you find anything abnormal, then you should always think of some other pathology like multiple sclerosis, posterior fossa lesion, or the CP angle tumor. Ophthalmic examination is required to rule out the multiple sclerosis, because you will see the ophthalmoplegia and the nystagmus. And the dental examination is definitely a thorough dental examination. Whenever we get any patients of orofacial pain, we make it a point to rule out the odontogenic cause of orofacial pain. So this is an ICHD classification of for the trigeminal neuralgia, where it says that at least 3 attacks of unilateral facial pain, which is occurring in 1 or more divisions of trigeminal nerve with no radiation beyond the trigeminal distribution, should be there. And pain has at least 3 of the following 4 characteristics, like paroxysmal attacks, which are lasting for a fraction of seconds, severe in intensity and described as an electric shock kind of a sensation participated, and it is precipitated by the stimuli, trigger factors. And there should be no neurological examination, should be normal, and there should be no other cause which is found that there is another diagnosis should be ruled out. So investigations hardly have any role in this diagnosis, because it's more of a clinical diagnosis on the basis of history. But investigations are done to rule out, it is CT, MRI, or MR angiography is done to rule out the CP angle tumors, multiple sclerosis, and also in cases of trigeminal neuralgia, especially the classical trigeminal neuralgia, to rule out the neurovascular conflict if it is there. So why you have to know the neurovascular conflict, we will go about that later. And coming to the differential diagnosis. So lot of cases, it's sometimes it can be really confusing. Though the trigeminal neuralgia is a very classical picture, still sometimes patients will not describe the way it is described in the books, They will have their own symptoms, and that sometimes can be very confusing. So cluster headache and migraine can mimic, but then what is the differentiating feature is that these patients will have acute unilateral pain just around the orbit, like it doesn't go in the distribution of trigeminal nerve. And they also will have photophobia, phonophobia, other symptoms will be there. And even sometimes if there is a dental cause, it can mimic like trigeminal. So a good history and examination of teeth and gums will definitely rule out this. TMJ dysfunction, here the patient will mostly complain of earache and pain centered in front of the tragus. It usually doesn't go beyond that, It can be sometimes confusing, but that neuropathic nature is not there. It is more of a localized pain, dull aching type of pain. It is not shooting kind of a pain or shock kind of a pain in TMJ. So in post-traumatic trigeminal neuropathy, there is a background pain which is there, and then there may be attacks, maybe there the patients may have attacks. So continuous pain will be there in PTTN, and there is always a history of trauma or some dental procedure being done will be there. In sinusitis, unilateral pain may be mistaken for trigeminal neuralgia. Patients with glossopharyngeal neuralgia, again, here there will be pain which is there at the back of the tongue and throat. So it is going down, and they'll say that the foreign body kind of sensation in the throat which is there, and they will have difficulty in swallowing.
Post-herpetic neuralgia, it is associated with allodynia. There will be skin lesions that you will be seeing, and also there will be sensory loss, which is there. And multiple sclerosis as well as CP angle tumor, you will have blurring of vision, and the neurological sensory and motor deficit will be there in these. So now coming to the protocol, how do you, whenever the patient with unilateral orofacial pain is come as a leading complaint, so see whether it is in the territory of trigeminal nerve, and whether it is the character is paroxysmal in nature. If it is there, then definitely, means not definitely, possibly it is the neuropathic pain. And if it is not there, then it is unlikely to be trigeminal nerve. Then if it is there, find out whether the pain is triggered by the maneuvers, which we have already described. Yes, then it is mostly a clinically established diagnosis of trigeminal neuralgia. So now once clinically it is established, you have to find out what is the etiology, and that can be done by MRI, which can show the neurovascular conflict in the classical trigeminal neuralgia. And if there is a secondary pathology like multiple sclerosis or CP angle tumor, then you will see the that pathology will be seen in MRI, which will establish that diagnosis. And if it is not falling into these two categories, then it is an idiopathic trigeminal neuralgia. So now what are the treatment options? We have medical management, we have interventions like minimally invasive interventions in the form of radiofrequency ablation, percutaneous balloon compression, gamma knife surgery, and microvascular decompression are the surgical treatments that are available. Coming to the medical management, carbamazepine and oxcarbazepine, that is the treatment of choice in the trigeminal neuralgia. But also drugs like gabapentin, pregabalin, phenytoin, sodium valproate, baclofen, and lamotrigine have been tried, and topiramate. So carbamazepine or Tegretol, we popularly know as, it is in level A evidence is there. It's the first line or a gold standard, which is one of the most effective and cost-effective drug in the management of trigeminal neuralgia. It's almost effective in 70% of the cases with an NNT of 1.7. Initially, though the literature might say a higher dosage, but what I have found is if the patient comes in in the initial phases of the disease, you will definitely, I have started as low as even 50 milligrams BD, and it has responded even to that treatment. But mostly I will see that other physicians, they will start a very high dose, and the compliance will not be there for the patient, because that high dose will cause a lot of dizziness, drowsiness, and the patient will discontinue the treatment. That is how you need to talk to the patient. Once you are starting patient on carbamazepine, it is very important that you start little low dose and explain the patient the side effects, like drowsiness will be there. The patient, they have to be cautioned if they are driving or they are involved into the machinery job. So they have to know about that there can be a drowsiness. Weight gain can be there. There can be a memory loss in a higher as the dose is increased. And some worrisome side effects that are that have to be kept in mind when you are starting on carbamazepine is aplastic anemia, agranulocytosis, and Stevens-Johnson syndrome, and toxic epidermal necrolysis. So whenever you start the patient on carbamazepine, you should have a pre-treatment, get an CBC done, and tell the patient that you will have to get it done every 3 months. Because this Tegretol is not given only for 1 month, 2 months. It is a long-term problem and long-term management that the patient is going to take. It, like some patients I've seen for 6-7 years, they have been taking Tegretol. So it is very important that they know that what are the side effects, and they have to monitor. CBC is not a costly investigation. It is better that they are periodically monitored with this. Oxcarbazepine has a level B evidence. It is better tolerated and a better side effect profile. It can be started as 150 mg/d, and you can go up to 1,800 milligrams. So all these, both the medications, they are available as the continuous release tablet as well as the immediate preparation. So now next, the other drugs that are there is the gabapentin and pregabalin, which is shown to be very, very effective. Sometimes when the patient doesn't have good response, or may say that patient has more side effects of this Tegretol, then you can definitely add on. You can give it as an add-on treatment, or if the patient has some side effects wherein you want to stop the medication, you want to stop carbamazepine, then gabapentin and pregabalin can be started. And baclofen and lamotrigine also has been proven very good effect, because baclofen doesn't act on the blood cells, but it has a GI problems like vomiting and cramping. And lamotrigine, you have to be cautious about the Steven-Johnson syndrome. So topiramate is also been tried, and one of the drug that is Botox injection in the trigger areas have been found useful, but there is no clear-cut evidence for that. Then IV lignocaine. So I give personally IV lidocaine plus ketamine infusions are given in patients who are like severe painful and they are just not able to tolerate. So in such cases, I give an IV lidocaine plus ketamine desensitization infusions on a OPD basis to tide over the crisis. So if the medications are ineffective and there are intolerable side effects, then you go for the further treatment, that's interventional pain management. And now, if the patient is, suppose the medications are ineffective in a patient, or patients are not able to tolerate the side effects. Now, see, if the patient who's coming to you is young, and if there is a neurovascular conflict, which is evidenced, and a patient is young, then definitely surgery is the best option for that patient. Because if we are doing radiofrequency ablation, it is not a permanent solution, and you may have to repeat it every, maybe 5 years, 6 years, depending on how long it will last. So in younger patients, it is better that you advise for the microvascular decompression. Whereas patients who are elderly, who are like medically unfit, lot of comorbidities are there, and they're not fit for surgery, then definitely radiofrequency ablation is one of the best choice in such cases. So now, what do you have been hearing about interventional pain management? So what exactly is this? So it is these are some of the minimally invasive, non-surgical, target-specific procedures which are not only used for treatment but also to diagnose various painful conditions. So interventional pain management in trigeminal neuralgia. I know that Dr. Dhruv and Dr. Sanjeev have already given you the glimpse of all these nerve blocks, means the interventions. I'm just going to go through the interventions that are done only in trigeminal neuralgia. So these are the interventions that are done are peripheral nerve blocks, percutaneous radiofrequency ablation, percutaneous chemical neurolysis, and percutaneous balloon compression. So these are done under guidance, as Minel was telling just now, that we always prefer under guidance. So all the interventions are done under guidance. Some of them are earlier were done under LADMA guided, but they're also done by peripheral nerve stimulator guidance or fluoroscopy guidance. Mostly Gesserian ganglion RF is done under fluoroscopy. Some of them also prefer to do under CT guidance for precision, and also ultrasound guided procedures. So coming to the peripheral nerve blocks, you have already heard in the morning that supraorbital and supratrochlear nerve block, infraorbital nerve block, maxillary and mandibular nerve block. So supraorbital, supratrochlear, you can see that the supraorbital notch is there. You will have to identify the supraorbital notch, and with the patient in supine position, after identifying the notch, use a 23 gauge hypodermic needle and introduce at the notch. It is very, very superficial. Now also, if you just feel yourself, you will feel that one kind of a depression on the medial aspect of your, just below the eyebrow. And the notch is identified, you advance the needle medially towards the bridge of the nose when you want to go for a supratrochlear branch of to be blocked. And after negative aspiration, you inject 3 ml of local anesthetic. Either it could be 1% xylocaine or 1.25% bupivacaine along with steroid is injected in a fan-shaped manner. So that the same supratrochlear, supraorbital notch can be identified in ultrasound guidance, and the block can be done that way. So now coming to the infraorbital nerve block, why do you do this? This is because of the V2 isolated V2 division, and sometimes it could be, patients who are just having the initial phase, and then you want to do if you don't want to do RF, patient is not willing, completely unfit, I will talk why it is done. So in such cases, you can do infraorbital nerve block. You can see the infraorbital notch. Again, the 23 gauge needle is advanced into the infraorbital foramen, slightly in the medial direction till the periosteum is reached. You have to be little careful because you don't want to enter into the foramen. The moment you feel that you are entering, give way feeling, slightly withdraw, and give 2 to 3 ml of the drug with the steroid. Now coming to the maxillary and mandibular nerve block, here this is done by transcoronoid approach, and it can be done by using the nerve stimulator. I do it using nerve stimulator. Patient will be in the supine position with the head in neutral, not turning this side, that side. The coronoid notch is identified by asking the patient to open and close the mouth in front of the external auditory meatus, and then use a 5 centimeter 22 gauge simplex needle that is inserted until you hit the pterygoid plate, and you just withdraw slightly and redirect it posterior inferiorly for the mandibular branch and anterior superiorly for the maxillary branch. And then you will see the motor response. You can see here in this patient in the last video that motor response for the masseter muscle is can be seen in the form of jaw jerk for the mandibular nerve. Then the needle is 6 to 8 ml of local anesthetic plus steroid is injected. Now, when do you do or when do you opt for peripheral nerve blocks? Like in my practice, because I work for a medical college, I have certain indications wherein you can't do the blocks. For example, this is a patient who came to us, who was referred by neurologist because she had trigeminal neuralgia and she was pregnant. She was first trimester, and she was could not take Tegretol also. Being pregnant, she was not able to eat. It was a very bad condition that she had. She couldn't even talk for a while because every time she would talk, she would get those attacks. So we did a peripheral nerve block using a nerve stimulator for her because radio frequency ablation because it has to be done under fluoroscopy guidance, and she being in the first trimester, it was out of question for her. Though we explained to her about the radiation hazards, we thought also that we can do with the shield and this thing, but she was not willing for anything. So we just thought of going for a peripheral nerve block, and we had to give her throughout her pregnancy. We gave her twice, and she was good with it. And after her delivery, when her baby was like 7-8 months or something, she came and then we did the RF ablation for her. So you can see that this was immediately after the peripheral nerve block that this was there. And she was so happy. She said that I have brushed my teeth. Means that was one big thing for her, that she was able to brush her teeth. So this is another indication wherein I prefer peripheral nerve block, that is a post-herpetic neuralgia, wherein I would rather go for a peripheral nerve block. And again, not all the centers will have RF machines. So whenever you don't have RF machines and the patient come and you can't see their suffering, so you definitely want them to help in some way. So when we did not have the machine, this is what we did, the peripheral nerve blocks, which you have to repeat a few times, but doesn't matter, at least the patient will get relief. So this is another reason. And then another very peculiar patient who came to us, who was a case of interstitial lung disease. And she was not able to, she was on oxygen, she was just not able to even lie down. So the question of she lying down prone, and then her even, with oxygen, her saturation was somewhere around 85 or below 90. So we did not want, and she was also not willing for RF ablation. So in such cases, we have given peripheral nerve block. So these are the indications why peripheral nerve blocks are given in trigeminal neuralgia. So coming to the Gesserian ganglion RFA, we have already seen, and Dhruv has told already that what is to be done. This is the procedure which is quite a high-end procedure. You need to understand the anatomy very well. It has to be done with a proper pre-anesthetic, workup of the patient with following the standard guidelines. It is done in the operation theater. Sometimes you may require sedation or GA. Pre-procedure antibiotic is given. The patient is in the supine. This is definitely done in an operation theater with IV line monitoring and aseptic precautions. Patient is in supine position with neck extended, because you need to visualize the foramen ovale. For the Gesserian ganglion or the RFA of the Gesserian ganglion, the key factor is identification of foramen ovale. Once you do that, half the job is done for the procedure. So you take an submental ipsilateral oblique view, wherein you will identify the foramen ovale. And as Dhruv had already explained, that depending on V1, V2, V3 division, you will go lateral mid or medial part of the foramen. So for the RFA, you take a 22 gauge 10 centimeter 5 mm active tip, which is inserted just lateral to the angle of mouth. And then the needle is advanced towards the foramen oval in tunnel vision. Tunnel vision means it should be seen as a dot, like you can see there that you in the right side image, you are seeing the needle as a dot. So it is advanced in a tunnel vision, and you have to be careful because you're going through the cheek. The needle should not come inside the oral, it should not penetrate the oral mucosa. You should tell the patient that in case it happens, then the needle comes in the mouth, they are supposed to inform. And in the lateral view, you have to see that the needle is at the junction of clivus and petrous part of the temporal bone, and depending on the depth should be, depth depending on V1, V2, V3 can be decided. So for the RF ablation, you also do the sensory testing and motor testing. If it is a V3 division, you can see that there is a contraction of the masseter contraction is seen. And sensory testing, the concordant pain should be there on that concerned nerve distribution. Then once you have identified the nerve, confirmed that the nerve is the same nerve that you're near, then you are doing the lesioning. The lesioning is done at 65, 70, and 75 degrees centigrade for 60, 70, and 80 seconds. This is the RF machine, and you adjust. You can see all the parameters that are there, and then we are doing the lesioning here. You have to check for the bilateral corneal reflex in between the lesioning, and this is done only for V2 and V3. It is already explained that you cannot do RF ablation of V1 division, and steroids are always given to prevent the neuritis. There are certain complications of the procedure like decreased corneal reflex. It is very, very, very important to explain the patient, especially if it is a V3 division RFA, that you are going to have numbness, you are going to have complete, weakness of your masseters. You may not be able to chew or eat. The pain might go, but you will feel because if you don't explain, then they will come back and they will really make your life miserable. That I don't have pain, but then there is so much of it is like a stone. It has become so hard and heavy, and I have that numbness. I'm not able to eat from that side. But these masseter weakness will slowly go over a period of time. So it is always better that you explain the patient about what are the complications that are going to be there post procedure, so that they're more mentally prepared about it. So you can also have sometimes anesthesia dolorosa. The dreadful complications can be there, and temporary paralysis of third, fourth cranial nerves, which we have come across, which I am going to share. So another procedure which is done mainly if you have the combined division V1, V2, or for the V1 division trigeminal neuralgia, the preferred choice would be the percutaneous balloon compression. I'm not going to go into the detail of this, and but this is just that 14 gauge cannula is passed, and then through that you will have a 4 French Fogarty catheter is passed, where once it reaches beyond the clivus, the balloon is inflated, and you have to see the pear-shaped balloon contrast should be seen, and then the balloon is inflated for 90 to 120 seconds. This is one of the challenging procedures where invariably you may have bradycardia, and the balloon is deflated. So you have to monitor, and the patient, this is mostly done under GA. So the patient, once the balloon is inflated, then deflate the balloon after 120 seconds and remove the catheter assembly, cannula assembly, and apply the pressure and extubate when the patient is fully awake. Now, I just wanted to share this very interesting case that I came across. This was one of the high profile case, and we did the RF ablation, and we gave 1.5% lignocaine and 2 milligrams of dexamethasone. And once that was done, the patient suddenly started telling that, like when I asked that, are you all right? He started telling that I'm not completely hearing. There was no hearing at all for him. And then he also had dizziness. There was deviation of angle of mouth towards one side. There was blink reflex on the left side with double vision when looking towards the left side. And the corneal reflex was reduced, was absent on the left side. We diagnosed that there was involvement of these 6th, 7th, and 8th cranial nerves. It was definitely not a very good situation for her to know that the procedure had gone so well. But at the end, he started telling, you can see that when you see him like that, it was not a very comfortable situation. So we only advantage and only reassuring thing was the patient was completely awake, conscious, oriented, hemodynamically stable, and there was no problem other than that hearing and those reflexes which were there. It was all right. So patient was reassured and monitored, and then we consulted the ENT surgeon and neurologist, and we waited. By the time we were doing all those things, no. So yeah, after 45 minutes, patient had complete recovery from the cranial nerve palsy, and we also followed him up after 1 month, and there was no focal neurodeficit. So we also that this is something which we are going to report and publish. So this cranial nerve palsy is a really rare complication of radiofrequency ablation of the Gesserian ganglion with an incidence of 0.29 and 7.7%. So coming to the different procedures, how they are, we have seen that there is a balloon compression, there is an ablation, and earlier days, the glycerol injection also was done. So the effectiveness of RF ablation is very good. The relapse rate is moderate, like 99% with balloon compression, and the success rate is 99%, better success rate with balloon compression. And facial numbness is more with RF ablation, and corneal anesthesia is almost 7.7% with RF ablation. And motor deficit is much, much higher with the balloon compression. So coming to the end, so I would just like to say that trigeminal neuralgia is a complex condition, and it is a challenge to treat such patients. The oral healthcare clinicians must follow a systematic approach in eliciting the diagnosis and evidence-based interprofessional team approach for optimal treatment success. And interventional pain management is an effective modality in the management of orofacial pain, improving the quality of life. Thank you so much.
Thanks, Dr. Pratibha, for giving all the modalities for the treatment of neuralgia and trigeminal neuralgia. We have one question. Myalgia, if patient presents with mixed symptoms like continuous pain aggravating by wind and also by having masseter tenderness on the same side.
Is it in the chat?
Yeah, it is in the chat. How to differentiate trigeminal neuralgia from?
How to differentiate trigeminal neuralgia from?
How to differentiate trigeminal neuralgia from myalgia?
From myalgia?
Yeah.
Trigeminal neuralgia is a neurological condition. Myalgia is a, I don't know whether the person really wants to say myalgia or something else. In case if you are saying myalgia, then myalgia is something related to muscle. So there will be a different character for the pain. If it is a if it is coming from the nerves, the character will be like, patient will complain of electric shock kind of a sensation, or it will be burning, it will be pinprick sensation, it will be ant crawling type of a sensation. So tingling, numbness, paresthesia. So that is a hallmark of pain arising from the nerve. And if you are saying myalgia, then it is arising from the muscle. So if it is arising from the muscle, then it has a typical nociceptive nature. Pain will be there, which is a dull aching kind of a pain, or it is squeezing type of a pain. So the description itself will make you differentiate what pain it is there. But I'm still doubtful whether he wants to ask the same thing.
Dr. Manali Patel, she has asked the question. Dr. Manali, if you have further doubt, you can unmute and ask question. Okay. Okay, thanks, Dr. Pratibha, for joining.
Can I ask one question?
Yeah, please
go ahead.
It occurs more commonly on right side of the face, no? Trigeminal neuralgia.
Yes, yes.
Yeah, how to differentiate idiopathic trigeminal neuralgia from atypical facial pain?
Okay, so idiopathic, whether it is idiopathic or classical, the presentation doesn't differ. So it is only the etiology. The classic trigeminal neuralgia, they will have pain on the unilateral side and paroxysms of attacks with pain-free interval in between. So that is idiopathic or classical. If you do idiopathic or classical can't be differentiated on the basis of history. Only when you do the MRI, and if the MRI shows that there is a vascular loop, then you call it as classic trigeminal. And if there is no vascular loop, then you don't know why there is trigeminal neuralgia. There is no vascular loop, still the patient has the same symptoms. Then you call it as idiopathic because you don't know the reason for trigeminal neuralgia. So that is classic and idiopathic. This is the primary trigeminal neuralgia, which is divided into classic and idiopathic. Now coming to what you said is atypical. Atypical is usually the patient will have a background pain is also there. Like in these classical, you will have in between there is a complete pain-free interval, but some patients may have a background pain. Background pain is there, but still patient will say the attacks are there for them. In between, they will have attacks. Some they may say that I don't have pain in between at all. Some may say that, yeah, some background pain is there, but in between I get attacks. So that is atypical trigeminal neuralgia.
Okay, any more questions?
Okay, thank you.
And there is a traumatic trigeminal neuropathy, post-traumatic trigeminal. That's a different entity wherein you have an evidence. You know that there is dental extraction is done or some procedure. Even post RFA also there can be PTTN, that is post-traumatic trigeminal neuropathy, because you have done some injury to the nerve. There is some damage or dysfunction or something, some handling of the nerve has happened which has caused the neuropathy. So there they will have a continuous pain. It need not be the attacks. It is a continuous pain which is there. So that is post-traumatic trigeminal neuropathy, wherein there is an evidence of injury to the nerve.
If there is trauma to the nerve after extraction and there is numbness, how long it will take to become normal?
Like post-extraction numbness is there.
Yeah, because of injury to nerve.
Yeah, so it comes under the category of PTTN. So you will have to, for PTTN, you can always start on, gabapentin, pregabalin are supposed to be good. Then SSRI, SNRIs like duloxetine. You can also start them on lamotrigine,
How long?
valproate. So how long cannot be told. How long can be told only on what patient is coming. Like there is no formula like, that this patient will get recovered in these many days. There is no formula like that. So it all depends on how multidisciplinary approach you are applying for that patient. So if it is for a very long term, then he may not come because psychological issues have to be also addressed. If it is a short duration, then there is a chance that the patient may recover much earlier. They also have to do few, as I think from yesterday I've been listening that the most important thing is a multidisciplinary approach is very, very important in this.
Okay. Okay, thanks, Dr. Pratibha.
Thank you.
Thanks
Thank you so
again
much.
from on behalf of all organizing team of Nopcon 2023. Thanks for
Thank you.
joining us and throwing the light how to manage the trigeminal neuralgia, which is you said that the most complex to diagnose, and it's the multidisciplinary approach to treat it. Yeah.
Thank you so much.
Yeah. Thanks. Stay with us. We have we'll go next 3-4 sessions. So yes, you can stay.
Okay.
Doctors, I'm handing over to Dr. Sonal. Dr. Sonal, are you there?
Yeah, I'm there now.
Dr. Sonal, she is the organizing secretary of Nopcon 2023. So from now onwards, she will take you up to the end. She will give the vote of thanks, and then we'll conclude this 2023 Nopcon. Over to you, Dr. Sonal.
Yeah, thank you, Dr. Nurul, and good evening, everybody. Hope all of you are enjoying this session, and lot many questions are coming in, so that curiosity level, keep the curiosity quotient high, because the next speaker will try to demystify more about orofacial pain. We have Dr. T.P. Chaturvedi sir, who is a senior professor from BHU. He has donned many hats, right from being the dean to being the professor, to being the head of department, to being the warden of the university. And he has around 27 years of experience, with approximately 7 years at AMU before joining BHU. Dr. Chaturvedi did a PhD from IIT, and Dr. Chaturvedi has done BDS in 1993, MDS in 1996. Uh, He's been a member of various academic and administrative committee, and both international as well as Indian. He has published around 124 publications in various journals, cited more than 1830 times till date, along with 3 books and 3 chapters. Doctor, it's a privilege to have you here. He was an editorial member of various journal and enlisted in top 2% world scientist list prepared by Stanford University, USA. He has been granted 2 patents and filed one in cooperation with IIT BHU. He has been involved in the organization of various health camp conferences, seminars, and social activities. I can go on and on, but I think audience wants to hear from Dr. Chaturvedi sir more. So the stage is all set for you, Dr. Chaturvedi, and your screen is visible. So you may continue, sir.
Thank you, Dr. Sonal. Am I audible? Hello?
Yes, sir, you are audible.
Okay, thank you. Thank you for the giving me opportunity, especially Dr. Nurul. And I'm very glad to see that I'm from listening the lectures from yesterday to today. And excellent lectures you have organized. So very much thankful to all of the organizers who have organized such type of conference, especially Dr. Noor and Sonal. So most of the things which I want to cover, that has been covered by the speakers. So let me just, I'll try to conclude my lectures 20 to 25 minutes, although just slide is more, but I want to conclude the next 25 minutes. Yes, I'm not able to move the slide.
Doctor, if you could just press enter, your slide is visible, sir. First slide is visible. Just press enter. Maybe the next slide will come in.
It is not moving. Only whenever I used to give a lectures at the college, our residents are able to manage. Yeah.
Yes, it's
okay.
moving. Yeah,
it's
okay.
It's moved.
So next part of that, by seeing the figure, you could do not guess that I'm going to talk about the malocclusion. Of course, malocclusion has a definite role. Malalignment and malocclusion has a definite role for the abnormal uh, uh, abnormality in the temporomandibular joints. And if you see the symptoms of the malocclusion, then we can see that it is difficulty or discomfort when biting or chewing, speech difficulty, breathing through the mouth, inability to bite, normal appearance. These are the features of the malocclusion. And if you see the oral disease and a lot of the systematic factors and oral health, they are associated with each other's various factors. Coming to the temporomandibular joints, it is a very unique joint. It is only one joint which is connected by the single bone, the same type of joints. No other joint in the body which is two joints connected by the single bone. And these two joints are the similar types. It is one of the specialty of that things. One of the unique features of this joint is that. Second unique features of this joint is that is a head of the mandible is being covered by fibrocartilage, means rest of the condyle, rest of the joining point of the bone is covered by the articular surface that also make a uniqueness. Third features of this joint is that it bears a lot of the heavy forces, and that heavy forces, it look like a simple, but up to the 200 kgs, 150 to 200 kgs beared by the molars, and all that forces are transposed to the TMJ. So, and fourth point, uniqueness in that joint, it is a considered a secondary cartilage type joints, not a primary cartilage. It has embryonic, different embryonic origins, which is different as compared to the other embryonically origin cartilage of the bodies. So how the malocclusion, a lot of that repeatable things are happening, and that is happening since, you can say that since 50s, 1950s, a lot of the things are happening, whether the malocclusion or the positive factors or the MJ problems or not. And one of the model is recent things are that malocclusion model of temporomandibular joints, osteoarthritis in mice with and without receptor for advanced glycation in the products. Glycation in products are those products which is causes the aging or the causes the arthritis of the joints. So it has been carried out in the 2016s, and some of our researchers are also going on that. That is how the malocclusion can affect, even though we are doing that things on the rabbit and as well as the mouse. Some experiments are going on. So if you see the basic functions of the oral cavity, our jaw is the speaking, eating, swallowing, smiling, biting, parafunction. Parafunction is not a function, but also these are quite common with the bruxing and clenching of the tensor relieving phenomena. Then it is not a normal function, but a normal function, but it is happening, and sometimes it is noticeable and not. And every joint function of the temporal mandibular joint is the movement of the jaw. It is a basic function of the jaw, the basic function of any joints, and that is very true applicable for the TMJ joints also, the movement of the jaw. And most of the things we are aware how the gliding hinge type movements are happening in the jaw, and that happening very much affected by we can say the upper and lower teeth. Then just you see the different type of the movements, and that movements opening movements, closing movements, and all open movement, and centric occlusion, centric relations. These type of movement, if you see the envelope of motions, the different type of movements are there, and all these movements are affected by the tooth. Hence, we can say that if the joint is made for the movement, and the tooth are tooth are interfering that movement, it is not a smooth movement. If you see the envelope of motions, there are different types of the graph we can see. And then we can say the teeth are responsible for that movement. And in that way, I'm very much agree with the teeth are the responsible for temporomandibular disorder movements. Thus, we see that is how the function of the teeth that will affect the jaw, and here is how the inclination of tooth that by which the jaw is forcing forcing or applying the force to the tooth that will affect it, and that will affect the TMJ. Forces applied to the teeth during biting as relation to tooth position, the incisors, we can say 35 to 50 pounds, then the canine 47 to 100 pounds, molars 127 to 250 pounds. So much heavy forces are there, and in that way, the TMJ is very much affected. The occlusal forces should be directed down the long axis of each posterior teeth, and forces of occlusion borne by long axis of tooth, that is the proper things, and by which our TMJ temporomandibular joint will proper function. If you see the balance occlusion when functional and non-functional side contact simultaneously in exertive movements, and our natural occlusion that is not the case. Balance occlusion, just you see the moving the right and left side, that both sides should be connected with each other. That is a valence occlusion that is found in the artificial dentition. And if that is the various factors are affecting the opening and closing movement of the jaw, which will ultimately affect the temporomandibular joints. That is the posterior guidance, that is inclination of the fossa, then the guidance of the mandible is dictated by the anatomy of the TMJ, Then the anterior guidance is totally guided by guidance of the mandible, dictated by contact of the teeth. In that way, what is and then anterior guidance, then canine guidance, the lateral movements, and the canine and first premolar guidance, then the lateral movements, and the canine first premolar and second premolar, then the premolar and first molar guidance, and the group function where the multiple teeth are connected to each other's. Then we can say that if these type of movements are where, except the condylar guidance, all the types of movements, whether the canine protected or group function of the occlusion, that is a well governed by the tooth. Then we cannot say that the tooth is not responsible for any temporomandibular disorder. Of course, that is one of the since temporomandibular disorder or temporomandibular pain is a multifactorial. So we can say that the teeth is one of the components which may be a causative factors or may not be. That can be questionable, but it has a definitely influenced the function of the TMJ. And the group function, the most of our occlusion, we can see the most of the occlusion is a canine guided occlusion, and it is almost found that we have observed, we have done a prevalence study. And canine guidance occurs, especially in 12 to 20 years of age, is found that 70 to 80% of the cases of the 12 to 20 years of age are canine guidance occlusion. But that is not the case in the adults and at the adults and the adults and the old ages. Then we have to dispute these canine and first premolar guidance, and that is a group function guided. In that way, when our periodontal load on the tooth are very much, and the tooth are maybe mobile. In that direction, the group function type of the guidance is also available in the occlusion. Then definitely the occlusion has importance. So after these slides, we can say the occlusion has a definite role in the temporomandibular functioning, and in direct way we can say the temporomandibular pain, temporomandibular disorder. Our occlusal therapy, just occlusal therapy, we can say the orthodontic treatment, occlusal treatment, and prosthetic treatment are very much common. It is a splint, it's very much common. Plans is there. So in diagnosis of TMJ problem, patients are classified as being one or two of these large groups. Those with the masticatory muscles disorder, TM joint disorders, chronic mandibular hypomobility, and growth disorders. So symptoms of TMD that has been covered till now, that is the pain or tenderness in the jaw, joint area, face, pain in and around the ears, headache and neck ache, swelling on the side of the face, jaw getting stuck or locked in open or closed position, jaw pain when chewing, popping or clicking noise, and difficulty opening the mouth all of the way. Most of the symptoms are very much common in temporomandibular disorder, and patients suffering from temporomandibular disorder, they may tell one of the symptoms or the many symptoms or all of the symptoms. So malocclusion, a bite problem, just even though any crowded things or overbite, underbite, that it is influence the temporomandibular disorder. Scientific evidence is not much to confirm the association between deep bite and TMJ disorders. Further carefully planned randomized control trials between the moderate and severe deep bite and TMJ dysfunction are necessary to precisely establish the scientific evidence. But there, just whenever we go the literatures, then we can say that that is almost 60 to 70% of literatures, they do not relate any malocclusion with the TMD. But 30 to 35% of the literatures, they correlate that the malocclusions are also a caustic factor of the temporomandibular disorder. Existing epidemiological investigation have not been able to demonstrate any strong correlation between different functional occlusion and occlusion interference and TMD. Some weak but statistically significant associations have been found between the temporomandibular disorder and large cervical distance between detuated contact position, intercuspal contact position, as well as between TMD and lateral shift between the RCP and ICP. The temporomandibular disorder during orthodontic treatment, there is a significant decrease of sign and symptoms of the TMD and of the headache during the active phase of treatment. It has been seen, and it will demonstrate that some relations are there, but they tend to increase to pre-treatment level after treatment is finished. That is also true. And most likely explanation is that the teeth which are being moved from sensitive to occlusal loading, what causes a decrease of oral functions during time of active treatment. These are the debatable things, but sometimes we can say that we have to see that is even though during orthodontic treatment there are some problem with TMD, and if there is a problem of the deep bite and any malocclusion we treat, then we get improvements. So examinations as usual, and it has we are discussing. There's a just we are not going in detail. Masseter muscles, TMJ sounds, range of motion, and division mandible and occlusion. Of course, three things. In our orthodontic clinic, just we have a direction to our resident or myself also that we have to see these things. That is whether the TMJ sounds are there. Then we have to see the checking of the occlusions and what type of the occlusions are there and whether we are able to improve or not. The non-surgical management, we can say that is the orthodontic management, splint therapy, muscle exercises, muscle treatment, trigger point injection, and pharmacotherapy. It has been discussed. That is our occlusal therapy, that is appliance therapy, limited occlusal adjustment, occlusal equilibration, and removal of teeth. That is our limited area in our orthodontic fields for the TMD correction of the temporomandibular disorder. Drastic alteration of the occlusion by either restorative dental procedure, orthodontic is logically only if less invasive stress control and stress adaptation approaches have failed, and reducing the amount of stress, reducing the patient reaction to stress, and improving the occlusion. These are the criteria by which we can say that is our management part will start in TMD cases, having in cases those cases we're having who's having a malocclusion. These are the things, normal things. This is has been also discussed. Most of things, soft white cord worn at night, act as a habit breaker and protect occlusal surfaces of teeth. Then anterior bite plane and Lucia zig worn at night. It has a certain indications. It has been also discussed by the previous speakers, especially we have to see the disc position. If the disc position is the proper entirely placed disc position, even the closing of the mouth, then we have the anterior bite plane we have to make, and that is our mandible is slightly forward placed. Then the stabilization splint, hard splint, restoration of occlusion, minimizes abnormal muscles activities and restore neuromuscular balance. And the nephrological splint, that is a specialized splint, correct centric occlusal and centric relation discrepancies. These are the, we can say the splint therapy. Whenever we ask and we use the splint therapy, that is not only generally the people generally they consider that it is a soft bite god or something a guide bite that one. We can say that is all these splints that is applicable for the correction of the temporomandibular disorder. Here is the simple dental splint that we can make, and I'm not elaborating the method and all that things. Occlusal splint and removal artificial occlusal surface used for the diagnosis or therapy affecting the relationship of mandible to the maxilla. Sometimes temporomandibular disorders there, and putting the splint, we can say that where we can, it is because of that TMD pain or not there. And that is a temporomandibular disorder. Is that because of occlusion or not? That is it is a very much a diagnostic also. And of course, therapeutic aspect it has. That is a splint. And the TMJ disorder refers to group of the disorders with symptomatic include pain, clicking, vibrating the jaw joint, or problem chewing or operating the jaw. Occlusal splints are also known as a night guard or orthopedic appliances. Occlusal splints are used frequently in reducing tension, decreasing muscle activity, and preventing harmful effect caused by the bruxism and temporomandibular disorder. Here is one of the case history just we have taken, that is 6 years, that is 6 months. This case is there, follow-up case is there. Within 19 years old, came in OPD with a chief complaint pain on right side of the face over the TMJ region and difficulty in mouth opening. And extraoral findings, bilateral symmetrical face, pain and difficulty in mouth opening and closing, and palpation, mild tenderness present over TMJ region on the right side. The clicking sound absent on the right side. Then the teeth present up to the second molar in both halses, class 1 molar relationship bilaterally, class 1 canine relation, crowding in upper lower half, and increase overweight and overwide, and procline upper interior, especially the deep bite is present. And if you see we have done OPG and CBCT. CBCT is OPG and CBCT. OPG finding of right side condyle, so change in the normal conic shape of the condyle, erosion of condyle and pointed condyle as compared to the left side condyle. So shape of the condyle is not proper. Generally, if you see the shape of the condyle, they are just the oblong type, oval type shape is there. And the shape is not proper, but the rest of the no as a major finding we are able to see even though from CVCT also. That is, the CVCT report is not there here just, but we have to get the CVCT report of this one. The soft occlusal spleen made up of 1.5 mm soft bioclinic seed given by the maxillary arch, given for maxillary arch. It is also the things is that sometimes a single splint or the double splint, the both splints are needed or not. It is also we used to try that one, and a splint is given, and then we have said that is after 3 months follow-up, the pain reduced over right TMJ regions. And we have taken also consultation from the other departments also. So they all that is also. They have also prescribed the medicine, muscle relaxant, and the joint type glucosamine type tablets are there. And there's no as such results, proper results were there. But after giving this splint, he feels a drastic change, the pain reduced, the improvement in mouth opening and closing, and palpation, no tenderness present over right TMJ regions. And we have given a 6 month for it, and after that we have discontinued, and he's telling that the improvement are there. So most of the things are we have discussed that. That is why I've just reduced my slide. I've seen your lectures and all that things. So to summarize, we can say that multidisciplinary approach in TMD should initially begin with the conservative and pharmacologically management followed by minimal invasive methods. Surgery should be considered a last resort. Periodic follow-up is important to assess the effect of therapy. Comprehensive understanding of the occlusal principle, TMJ anatomy, muscles is essential. Patient for patient comfort, the restorative longevity, occlusal stability, improve aesthetics, and decrease sticks. These are the common factors we have to take care of. Once again, I would like to give thanks, Dr. Nurul, especially Nurul, that you have given me opportunity, since I've seen that most of the part of which I want to cover, you have covered, that is, I have reduced my slide. Thank you, Dr. Nurul. Any questions?
Yeah, thank you, Doctor Chaturvedi, and it was really an insightful synopsis, I would say, for the whole conference. I don't see any questions as of now, Doctor, but if there are any in chat session, then you can just go back to the chat
Hello.
section. See,
Hello,
yeah.
Thank you.
sir. Hello, sir.
Yeah.
I have one question.
Yeah.
Good evening, sir. Sir, during the active phase of orthodontic treatment.
Yes, sir.
One doubt.
Hello.
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 Let the previous doctor speak first, then the next question we'll take.
Hello. Can I ask?
Yeah.
During the course of orthodontic treatment, during the active phase, if the TMJ pain aggravates, so we need to treat the TMJ first, or we need to continue the treatment, ortho treatment?
Actually, during orthodontic treatment, if aggravating, pain is aggravating, it means we have changed something more occlusion pattern. and we have to take care of the occlusion. So any type of the most of the some orthodontic therapy is that tooth is extruded or intruded. In that sense, especially the deep bite or the open bite or something like happens, it might affect the opening and closing movement of jaw. First,
Yes, sir.
whenever we faces a such type of situation, we concentrate the occlusion of the upper and lower jaw. Try to correct the proper occlusion. That is only one of the criteria. Because most of the time, if it is aggravated, it means we have disturbed much more occlusion. We have to take care of the occlusion part.
Yes, sir. Yes. Okay. Thank you, sir.
Thank you.
There was one more question from some female participant. Doctor, could you ask the question?
Yeah, the splint is used for 6 months, no?
Yes, 6 months. Generally, 3 months is advisable, but I prefer to use a 3 to 6 months. And after 6 months, I have seen a drastic things. Whatever the symptomatic, unless until any other factors are not involved. Then we
Hard
have
or
got
soft splint is preferable more.
yeah.
Hard splint or soft splint is more.
Actually, initially we had to give the hard, but later on we changed to the soft. And bioacrylic, now the bioacrylic seats are there. There is a more, they have a features of more. Something hardness is there also, or softness is there. That is very much well tolerated and well suited.
Okay, thank you, doctor. Do we have any other questions from the participant?
Thank you, Dr. Nurul and Dr. Sonal. It's really Dr. Nurul. I'm very
Thanks.
pleased to see you, Dr. Nurul.
Let me in actually, sir. With the permission of Dr. Sonal, can I say something?
Please go ahead, sir.
Yeah. So Dr. T.P. Chaturvedi is our professor while I was doing my BDS in late 90s. He was there in a department of orthodontics and he taught us both dental anatomy and orthodontics. By the time, say, it's a long time, Dr. Chaturvedi, because last year we have made one program IOCCON. You were there, and then it's after 2 years we are connecting. Thanks for joining us.
Thank you. Thank you. I'm very pleased to see you in such a position. Then there's a major gain of any teacher than when his or her students visible like you. So that is my best compliments, and you can say best things which I am seeing that you are organizing such type of things. Very much. Very good. Very. I am very, very thankful to you that you have just provided me an opportunity. Okay. Thank you.
Thanks. Okay. Over to you, Dr. Sonal.
Yeah, now we have Dr. Vaishnavi Prabhakar. Dr. Vaishnavi, could you just start your camera, please? Dr. Vaishnavi, are you there?
Hi, Dr. Sonal.
Yes. So let me introduce Dr. Vaishnavi. Dr. Vaishnavi is a MDS postgraduate in prosthodontics, and she's done it from SRM University. She is one of the first to receive the fellowship in orofacial pain and temporomandibular joint disorders and dental sleep medicine from Smile USA. And thereafter, she finished her diplomate. She's a diplomate in the American Board of Orofacial Pain, and that's the highest form of accreditation anybody can get in orofacial pain as of now. So she is also a director at Dr. Prabhakar's Facial Pain and Family Dental Center in Chennai. And as I know personally, also she's a very well published author also, and she has published many articles. So Dr. Vaishnavi, welcome to Nopcon 2023, and you may start your presentation. All the best.
Thank you, Dr. Sonal. Thank you, Dr. Nurul, for having me here. I hope you can hear me.
Yes, we can hear you. You can start
Yes.
sharing your screen.
Yes, okay. Okay.
Yeah, your screen is visible now. You can share share the screen. Yeah, go ahead.
Okay. So good morning, everyone. I'm Dr. Vaishnavi Prabhakar. Today, I'm going to present about non-odontic toothaches. It's a privilege to be a part of such a huge group of dentists and other professionals who are taking care of orofacial pain patients. Is my slide moving?
Yes, press
Yes,
again. Yeah.
Yeah. So I'm Dr. Vaishnavi. I'm a Bachelor of Dentistry. I've done my Bachelor of Dentistry and I'm a Master's in Prosthodontics and Crown and Bridge. I did my fellowship in 2017 and 2019 we did a mastership with a few other courses sitting next in the panel. And then I went on to get the diploma from the American Board of Orofacial Pain. So today we are going to discuss about non-odontogenic toothaches, whereas when we are dentists, any toothache that we find, we tend to think it is of odontogenic origin. So when we are completely blinded by the fact that there are other causes of toothache. So when there is a non-odontogenic toothache, you have to observe whether there's presence or absence of any clinically evident teeth or periodontal issues that are present. So what is odontogenic pain? We are all expert at diagnosing these odontogenic factors and pain. They should have some odontogenic origin. They should be pulpal or periodontal origin of pain. There should be a dull aching throbbing pain which aggravates towards the night time. It's unilateral in nature, mostly towards the affected side. Pain is eliminated with a local anesthetic injection. So what is the prevalence of toothaches or odontogenic pain and non-odontogenic pain is 88% of toothaches are all odontogenic, whereas 9% is non-odontogenic and 3% is a mixed type of pain. So when we come to the pathophysiology of non-odontogenic pain, it is a heterotopic type of pain, whereas there is a projected pain and there is referred pain. Projected pain is when there is projection of pain from the nerve terminal throughout its distribution. It can be felt at any part of the nerve. And then heteropic pain is due to the convergence of two or more of the trigeminal nerve fibers into the trigeminal spinal tract nucleus, which can be felt as separate pain. So the site and source of pain may not be the same. So what are the types of non-odontogenic pain? It includes myofascial pain referred to the tooth or teeth. It can be neuropathic toothaches. It can be idiopathic toothache, neurovascular toothaches, and that can be sinus referred pain to the teeth, cardiac referral of pain, and psychogenic, and toothache caused by various other disorders. So pain of muscular origin is the most common form of non-odontogenic toothaches. It's primarily associated with non-odontogenic pain. 11% of myofascial pain, masticatory muscle pain, produce toothaches in the non-odontogenic region and can produce toothaches in masseter is the main causative muscle and temporalis is the other muscle that can cause these pains. It's characterized by spontaneous and dull aching. Masseter, that is a superficial masseter, refers pain to the upper posterior molars and the lower posterior molars on the same side. And it can also refer pain to other regions, but this masseter is can predominantly cause non-odontogenic toothaches. Again, temporalis can refer pain to the upper anteriors, the laterals, and the canines, and the posterior temporalis referring to the posterior molars, upper molars. The anterior digastric can refer pain to the lower anteriors. This is always misunderstood and confused with neuropathic pain, and can a lot of unnecessary root canal treatments are done due to this anterior digastric muscle referral. Then when it comes to neuropathic toothaches, toothaches due to any problems in the nervous system. Pain caused by a lesion or disease of the somatosensory nervous system is the definition of neuropathic pain. Neuropathic pain indicates either a structural or functional abnormality in the peripheral nervous system or the central nervous system. It can be episodic neuropathic pain. It can be continuous neuropathic pain. The episodic neuropathic pain is paroxysm of pain which is evoked by a peripheral stimulation. It can be an extraoral or an intraoral site which can refer pain to the molars or the anterior teeth. Pain is described as excruciating and electric and brief pain with pain-free periods. Whereas a continuous neuropathic pain, it can be due to herpes zoster infections, which can result in pain in the teeth. These can present with sensory abnormalities such as paresthesia or hypersensitivity or allodynia. The diagnostic test for these would be intraoral examination and an IOPA, which should rule out any dental form of lesions or periodontal lesions. We can give a topical anesthetic to the trigger area. If the pain doesn't subside, then we give a topical and local anesthetic to the tooth. The pain still doesn't subside, then we have to look at paroxysmal origin of neuropathic pain. Treatment for episodic is carbamazepine is the first choice of treatment. Oxcarbazepine is the second choice, and baclofen and lamotrigine are the third choices. When it is continuous, if it's due to herpes zoster, you have to give a vanciclovir or acyclovir or a valacyclovir. The first line of treatment will be topical anesthetics. We try topical anesthetic. If they don't work, we give DCAs and anticonvulsants. Next, we have the neurovascular toothaches. This is due to interaction between the neurovascular system and the nervous system. We have neurovascular headaches, where these headaches can present as toothaches also. A migraine can be a spontaneous throbbing maxillary pain that is mostly felt in the maxillary region if it is related to the orofacial part. This maxillary region pain can also be felt in the tooth. The attacks can last from 4 to 72 hours. It can have typical migraine symptoms such as photophobia, phonophobia, nausea, vomiting. Similarly, TACs or the trigeminal autonomic cephalgias. This can have cluster headaches or episodic intense periorbital and maxillary pain. This can last from 15 to 180 minutes. This can cause lacrimation, that is eye tearing, rhinorrhea, scleral injection, and pupillary meiosis can be present. There's another form of TACs called as CPH. This is acute and episodic periorbital pain, and this is associated with dysautonomia. Apart from this, sinus pain can also be felt in the maxillary teeth. This is due to the dental plexus, which is present right on the sinus floor, which is induced by cold stimulation or mastication. Dysesthesia can arise during clenching. How would you find out that this is sinusitis related pain? You can first give a local anesthetic to the related teeth and find out if the pain is getting relieved. If not, you can give them some decongestants, and you can also do a CT and histopathological examination. If not, please refer to the CT specialist. Then there can be a cardiac origin pain. There is no known cause as to why the cardiac pain is referred to the teeth, but there is some vagal interaction in relationship to the trigeminal system that it is gives rise to a toothache. It is tight and burning sensation. It is aggravated by exercise, and improvement with rest and bilateral symptoms may be present. Diagnostic test is you can probably do an ECG. You can try a sublingual glycerol trinitrate. If it helps, please refer the patient to a cardiologist. This is a case that we had at our clinic. This is a 35-year-old Indian male. He's married. He's got 2 children. He was doing agriculture in Ooty, which is a hill station near Chennai. He complained of TMD. On further asking him what is your actual complaint, he said headache on the left side of the face. So he has chronic progressive pain. Daily headaches were present with exacerbation in the last 6 months with no pain-free periods. Left side, mid-face, temple, preauricular, postauricular, neck and shoulder pain was there. 7 out of 10 pain was there, which is burning sensation and dull aching pain. The left temple had pain, orbital, retroorbital, and periauricular, lower border of the mandible was painful. This was a different pain, which was 10 out of 10 in nature, and stabbing, boring pain. Other associated features was when the 10 out of 10 pain was happening, he used to wake up at 2 a.m. in the morning with 2 to 3 hours of pain with eye tearing and nasal congestion. Past treatment, he was given an anterior repositioning splint and a deprogrammer, which gave him relief for only 2 days. Then the dentist too had given him a TM joint steroid injection with pregabalin 75 milligram for the next 2 days. He had relief for the next 2 days when he was consuming the pregabalin. Dentist 3 gave him dental caps and local anesthetic on the 2-4 region, which he complained of a non-odontogenic pain, which gave him 70% relief during the local anesthetic. The neurologist gave him propranolol 40 milligram once a day, which didn't help. The second neurologist gave him naproxen sodium, which gave him severe gastritis. So he discontinued, but it gave him mild relief. All the previous efforts to relieve the pain lasted for 2 days, followed up with familiar pain. His posture, gait, and cognition were all within normal limits. There's no asymmetry and there's no palpable lymph nodes. There was generalized fatigue. There's nasal septum deviation, which was there. Positive history of headache since 15 years of age. Cranial nerve screening, temporomandibular joint evaluation, and joint palpation was all within normal limits. The muscle palpation on the left superficial masseter referred pain to the gingiva above the 2-4 region and the zygomatic region. The intraoral examination was also within normal limits. Different diagnosis was given: myofascial pain with referral. Then we gave him a TAC, hemicrania continua, and trigeminal neuralgia was given as a differential. MRI investigations was done previously, which was within normal limits. MRI and CT was done previously. We did some blood investigations and we found out that vitamin D was insufficient. Trigger point injection was given as a diagnostic test. It relieved 70% of the toothache and the gingival pain. Then we followed up with indomethacin gel 75 milligram BD, which gave him 100% relief of the headache. This patient was given a diagnosis of myofascial pain with referral. It's a non-odontogenic toothache and attack. We later referred this patient to the neurologist for further management. Next case is a 45-year-old Indian female. She had a left-sided facial pain for the last 6 months again. Intermittent sharp shooting pain with diffuse background dull aching pain she had. This pain was 6 out of 10 dull aching pain and 8 out of 10 sharp shooting pain. Pain was on the 2-4 and 2-5 region. All extraoral examinations was all within normal limits. Intraoral examination was again within normal limits. Cranial screening was within normal limits. Muscle examination, we did superficial masseter, showed some trigger points that was referring to tooth number 2-4 and 2-5. 50% of the familiar pain was present with diffuse pain near the left cheek region. Temporomandibular joint screening was also within normal limits. She had been on splint therapy. Root canal treatment was done on 2-4-2-5. Post root canal, the pain increased to 8 out of 10. No history of dental decay. Periapical lesions were absent and periodontal lesions were after the root canal treatment. There's no sign of a caries or a dental lesion or a periodontal lesion. Then we gave a local anesthetic which showed no spray, which had no response. The local anesthetic infiltration with 2 ml of lidocaine and adrenaline took away 50% of the pain on the tooth, and the later trigger point injection on the superficial masseter took away the rest of the pain. Later, the patient was also referred to the endodontist because we were suspicious about the previous root canals. The endodontist reattempted a root canal, and the 50% of the pain that was due to failure in the root canal procedure was relieved. And the remaining pain was managed with the trigger point injection. Currently, the patient is absolutely pain-free. The post-endodontic procedure picture. So what are the potential identifiers for a non-odontogenic toothache? There should be spontaneous multiple tooth pain. You have to be doubtful. Then there's no lesion or a dental cause, and it is electric burn lancinating pain and non-pulsatile toothaches. Constant, persistent, unremitting toothaches are there after persistent treatments and even extractions. Failure of local anesthetics to significantly reduce pain. Failure of toothache to respond to reasonable dental therapy. Pain referral to the region of tooth frontal trigger points. Associated with autonomic symptoms such as conjunctival injection, regional sweating, and other vascular phenomena, regional pain and paresthesia, and severe headaches. So when this is a simple diagram which is from the Bell's textbook. This shows when we are injecting the source of pain, the patient doesn't have, at the source of pain, the patient has good relief. But when it is injected at the site of pain, there's no change in pain. So the process is, start with your good history taking, perform a detailed clinical examination, do your investigations, find out if there is any dental causes of pain, If there's absolutely no dental cause of pain, before doing any invasive and non-reversible procedures such as root canals and extraction, please take a referral and opinion from another specialist, an orofacial pain specialist or a neurologist, and then you can proceed with further treatment procedures. Thank you. This is Chennai. I'm from Chennai. This is my clinic's logo. Anytime anyone wants to come to Chennai, you're free to visit me. I would love to have you all here.
Thank you, Dr. Vaishnavi, for that lovely presentation and also the invite that you have sent across. So I will definitely visit you. Hope everything is okay
sure.
there.
Yes, good.
That was a very insightful presentation. The person who would like to start with orofacial pain practice should know that this is how we go about doing it. Okay, thank you, Dr. Vaishnavi.
Thank you much, Dr. Sonal and Dr. Nurul, for having me here. Nice to meet you, Dr. Maithili. After a long time, I'm seeing you, ma'am.
Hello.
Hello, ma'am. I was a student of Dr. Maithili also.
Oh, that's a nice
Wonderful presentation.
Thank you, ma'am. Thank you so much, ma'am.
Okay, so now next speaker we have Dr. Maithili Kalakkad. I'm sorry, ma'am, for the mispronunciation. Kaladka. Sorry. Okay, so Dr. Maithili, it is a privilege to talk to you because I've been wanting to talk to you since a long time. She's currently an assistant professor at the Department of Orofacial Pain and Temporomandibular Joint Disorder, University of Rochester, USA, and she's actually a dental surgeon from Government Dental College, Bangalore. And she's completed a fellowship in orofacial pain from the University of New Jersey, USA. She has completed a master's in dental sciences with specialization in orofacial pain from the University, in New Jersey as well, from the University and Medicine of Dentistry, New Jersey, UMDNJ, USA. She has completed her master's in dental sleep medicine. She's a board certified American board specialist by ABOP, and she's into teaching temporomandibular joint disorders and mentoring all across the internationally speaking, as well as in Indian as well as international courses. And she's on the editorial board of several journals and lecturers in international conferences as well. So thank you, Dr. Maithili, for coming here and sharing your knowledge. Thank you so much. You may start presenting your screen, Doctor. The share
It's
screen
not
option.
allowing me to present.
No, there is a share screen option below. You can see a green button.
But
Okay.
it's just saying one participant can share at a time.
Doctor, is there any previous participant who is sharing the screen? If they can reduce,
No,
is
there
there
is
any?
no one is sharing this screen.
Okay.
And Dr. Maithili is a co-host, so she can share her slides.
Now you can share, Doctor, please.
So it's still not allowing me.
You are coming by Maithili Kladka. You are the co-host on the second most. If you look at the participants on the right side, or you are coming with a different name. What's the?
No, I'm coming in with the same name. Maithili Kaladka.
Just hold on.
But it's just not allowing me to share the screen. It's saying host disabled participant sharing.
That's good. Now, are you able to do that? That just go for the share slide screen on the green phone in the bottom
Right,
of
but it's still not allowing me. It's just not allowing me.
I have made you co-host, and you can.
Should I just leave and rejoin once?
Yes, that would be better. Right, you just leave and rejoin to the same link.
So participants can see the link that Dr. Nurul has shared on the chat box. That is the link for the YouTube upload of the whole Congress. Yesterday's link he has already shared. So you all can visit and go back to lectures which you all want to visit again. And it's been, we have 2 more speakers to go, and I'm sure you all have great insights on orofacial pain now. So ma'am is connected again. Ma'am, you're unmute yourself, ma'am.
No, please try.
It just is not allowing me to share the screen for some reason.
I have made you the co-host.
Yeah, I think now it's open now.
Yes, yeah.
You're able to see this, right?
It's just coming.
Yeah, it's just coming, buffering.
Yeah.
It's
Yeah.
visible.
Thank you so much. Apologies for the confusion. It's in a full screen mode, right? Or it's
No,
still
please go ahead with full screen mode.
Yes.
Yes, ma'am.
Yeah.
It's
So I'm Maithili Kaladka. I'm an assistant professor at Eastman Institute for Oral Health in Rochester, New York. And the topic of my presentation today is going to be episodic neuropathic pain. At the onset, I'd like to thank the organizing committee for having me here. It's been a fantastic and really well executed conference with a multidisciplinary approach, which is really wonderful. So the topic of my presentation today is on episodic neuropathic pain. I'll be beginning with a brief overview of what neuropathic pain is and what are the specific features of episodic neuropathic pain. And then we'll be going into specific episodic neuropathic orofacial pain conditions. And then we'll be going to the diagnosis and finally ending with the evidence-based management paradigms. So at the end of the lecture, the objective of the lecture is to familiarize the participants with the diagnosis of orofacial episodic neuropathic pain conditions. So you should be familiar with the clinical features, the diagnosis, and have an overview of the management strategies that we generally use. I have no conflict of interest and there's no disclosure. So neuropathic pain, the International Association for Study of Pain defines neuropathic pain as pain caused by a lesion or a disease of the somatosensory nervous system. Now, there are several classifications of neuropathic pain. The prominent ones are the ones proposed by the International Association for Study of Pain, the International Headache Society, which has the ICHD, or the International Classification of Headache Disorders, the ICOP, or the International Classification of Orofacial Pain, and the ICD, or the International Classification of Diseases. So these are broad, widely accepted classifications for neuropathic pain conditions. Now, in 2020, for the first time, we had 2 major breakthroughs in orofacial pain in the specialty, because 2020 was when we were recognized as a specialty in the US. And the second wonderful thing that happened in 2020 was, for the first time, we had a wide classification of orofacial pain, starting from acute odontogenic pain disorders, going to the other end of the spectrum to idiopathic facial pain disorders. So that's called the International Classification of Orofacial Pain. The International Classification of Orofacial Pain imbibes parts of ICHD and the ICD as well in its classification. It's still an ongoing process because we just have the first edition. And the most common conditions, orofacial pain conditions, are included in this classification. So we have pain due to cranial nerve lesions attributed to the trigeminal nerve and the glossopharyngeal nerve only in the ICOP, whereas the rarer episodic neuropathic orofacial pain conditions have still not been included in the diagnostic criteria for ICOP. And the ICOP commonly refers the ICHD3 classification for a little rarer episodic neuropathic orofacial pain conditions. So in my presentation today, since I'm dealing with multiple common and rare episodic orofacial pain conditions, in my presentation today, I'll be using the ICHD3 classification. So ICHD3 classification is based on a consensus from the IASP and the ICD as well. And it broadly classifies neuropathic pain based on the location into central or peripheral. And I'll be dealing with that specifically in the next couple of slides. Based on the etiology, they're classified into classical, idiopathic, or secondary. And based on the syndrome, it's classified into neuralgia or neuropathic pain conditions. Now, when I say peripheral episodic neuropathic orofacial pain, it's basically peripheral pain caused by a lesion or disease of the peripheral somatosensory nervous system. And in general, it's again subclassified into episodic and continuous. And the second category is the central neuropathic orofacial pain conditions, which is caused by pain or lesion or a disease of the central somatosensory nervous system. So when it affects the peripheral nervous system, it's called peripheral neuropathic pain. And when it affects the central nervous system, it's referred to as central neuropathic pain. That's the broadest classification. So under peripheral neuropathic pain conditions, you would have diabetic neuropathy and post-herpetic neuralgia. Whereas under central neuropathic pain conditions, you can have multiple sclerosis or pain secondary to post-stroke conditions. So it's basically modulated by the central somatosensory nervous system. The second classification is the one which we use in most neuralgias, and that is basically dividing it into classical, idiopathic, and secondary. And Dr. Pratibha had spoken about this as well. She dealt specifically with trigeminal neuralgia, which is the most common and most widely studied episodic neuropathic orofacial pain condition. But in my talk today, we'll be dealing with diverse episodic neuropathic orofacial pain conditions, not just limited to trigeminal neuralgia, but also including glossopharyngeal neuralgia, nervus intermedius neuralgia, and occipital neuralgia as well. So generally in most cranial neuralgias, you classify it into classical, idiopathic, and secondary. Now, the difference between classical and idiopathic is that when you have an MRI and there is neurovascular compression, which is causing morphological changes such as atrophy or displacement of the nerve, only then it is referred to as classical neuralgia. So it's imperative that you have morphological changes and not just neurovascular compression. So when there is just plain neurovascular compression with no morphological alterations, you would classify that neuralgia as idiopathic and not classical. This is very important because when we go to management strategies, particularly surgical modalities such as MVD, that's when you would have a greater success with classical neuralgia cases compared to idiopathic neuralgias. Okay, idiopathic neuralgia may have neurovascular compression, but it's not associated with morphological changes, and neither the MRI nor the electrophysiological test will show significant abnormalities. So neurovascular compression may be seen in a certain amount of population without neuralgia as well. Hence, it's very imperative to look for morphological changes before referring the patient to surgical or interventional procedures. The third group is called secondary neuralgias, and this is secondary to underlying diseases such as multiple sclerosis or space-occupying lesions. So in general, whenever you encounter a patient with neuralgias, based on the MRI reports, you would be able to classify them into classical or idiopathic or secondary. So again, idiopathic and classical, both in ICOP and in ICHT classification, they can present in two different ways. The first is where there is only paroxysmal pain with no intermittent pain in between the attacks. So the patient can have one severe episode of severe sharp lancinating pain, and until the next episode, the patient is basically pain-free. In the second subset of patients, you can have concomitant background pain, and these are the patients which generally present a dilemma with diagnosis. So the patient can have one episode of sharp shooting pain, and then he has an episode of dull, burning, aching kind of pain until the onset of next episode of sharp shooting pain. So when you have a patient with concomitant continuous pain, it's really essential that you spend some time taking a detailed history so that you can differentiate neuropathic pain from odontogenic pain or other orofacial pain categories. So in general, the guidelines for diagnosis of neuropathic orofacial pain conditions include episodes of neuropathic pain. Just like the name suggests, the patient has episodes of severe, sharp, shooting, electric, or stabbing like pain. And the pain is basically confirmed to the distribution of the affected nerve. So for instance, if you're speaking about the trigeminal nerve, it would be confined to the distribution of the trigeminal nerve territory. And if it is the glossopharyngeal nerve, you would see pain within the territory of the glossopharyngeal nerve. Characteristically, the episodes of pain last from few seconds to up to 2 minutes. The longest documented case is about 2 to 3 minutes, which has been reported in literature. The pain is really very severe, and you need to rule out other conditions which can mimic neuropathic orofacial pain. And the important thing is that in neuropathic pain, particularly episodic neuropathic pain conditions, the pain can be triggered by innocuous stimuli such as a cold breeze, shaving, applying makeup, brushing your teeth. So innocuous stimuli, which are not normally responsible for causing pain, can cause pain in these conditions. So let's begin with a small case that I saw 6 months back. So this was a patient who had a history of left facial pain of long-standing duration for more than 35 years. So 35 years back, he had an MRI, and he was diagnosed with trigeminal neuralgia, and he was treated with carbamazepine, and after a period of time, he was non-responsive, and he underwent 2 radiofrequency ablations. Okay. So when we begin with any case, particularly neuropathic orofacial pain, the key is your history. Just like Dr. Pratibha was telling, neuropathic pain relies on a good history for diagnosis. So when we speak about diagnosis of orofacial pain, we generally say there are 7 magic questions: the location, duration, quality, intensity, frequency, precipitating and ameliorating factors. So getting a good history gives you 70% of the diagnosis. So in general, when a patient with episodic neuropathic orofacial pain presents, the history that you get is that the patient has brief, sharp, shooting, electric-like, stabbing-like pain, and it's confirmed to the territory of the affected nerve. It can be out of proportion to the stimulus, and generally they are poorly responsive to analgesics. And you often see trigger zones in these patients, which may be intraoral or extraoral. So in several of these episodic neuropathic orofacial pain conditions, the patients can also have a brief period where they have dull, burning, aching pain before the actual onset of classical neuralgia symptoms. So if you go back in history, looking at the time frame that the condition manifested as sharp shooting pain, just prior to that, a lot of patients do report a period lasting for a few months or a few weeks where they could have had dull, aching, burning sort of pain. Neuropathic pain, orofacial pain, particularly the episodic neuropathic pain, is generally associated with periods of remissions. So the patient can have a period when the condition is very active and he's having severe attacks of facial pain. And out of the blue, suddenly he can end up with a period where there is, he's in complete remission and there is no pain. But generally, the periods of remission tend to get shorter as the condition progresses and advances. Also, like I mentioned before, there can be brief episodes of severe sharp pain with no pain in between the intervals, or the patient can have dull background pain, and then he can have episodes of sharp shooting pain in between these episodes. So two classical groups of patients may be seen in episodic neuropathic orofacial pain conditions. It's very important when you're dealing with orofacial pain in particular to have a good understanding of anatomy, and particularly with neuropathic orofacial pain, because the diagnosis relies on your knowledge of anatomy of the cranial nerves. So depending on the distribution of these nerves, the patient can present with pain in these territories, and that would lead you to the diagnosis of either trigeminal neuralgia, glossopharyngeal, or nervous intermedius. So one of the things at today is I would really advise all of you to go up and brush up on the anatomy of orofacial pain structures, because I know all of us have read it in anatomy in the first year of undergrad or in your master's, but post that, once you get into clinical practice, we kind of tend to forget the basics. So it's imperative we know the distribution of these nerves and the areas that they supply. So trigeminal neuralgia, it's one of the most common neuropathic episodic orofacial pain conditions. In spite of being a common condition, it's still it's a lot of work in progress when you see scientific literature. And among neuropathic orofacial pain conditions, this is the most widely studied condition. And the current guidelines that we have in episodic neuropathic orofacial pain conditions are basically based out of guidelines that we have for trigeminal neuralgia. So if you see the prevalence, it's still very low. It's just about 0.001 to 0.3% of the population that can have these disorders. But this is one of the most important conditions for us as dentists, because a majority of the patients do come to the dentist first because it's pain in the face and in the teeth, and most of them assume it is odontogenic pain, and hence it's imperative for the dentist to have a diagnosis before proceeding with treatment. So if there's one take-home message, I think, from the entire conference that everyone is stressing about, that's having a good diagnosis before starting any sort of treatment. Like Dr. Mayekar said, is there something that I would do to myself to my parents or to my relatives or to my patients. So think of it and have a diagnosis before you start initiating any kind of treatment. And if it's something beyond your realm, I would definitely suggest taking a second opinion, a third opinion, meet up medical personnel, a physician, a pain physician. There's nothing wrong in taking inputs before beginning any invasive kind of procedures. So again, the classification is classical, idiopathic, and secondary. And secondary constitutes about 10% of cases of trigeminal neuralgia, and amongst these, multiple sclerosis is about 2 to 4%. So like I said, in episodic neuropathic pain, you have all the characteristics, and the main thing, you differentiate each neuralgia like trigeminal, glossopharyngeal, or nervus intermedius is based on the nerve that is affected. So in case of trigeminal neuralgia, the pain is limited to one of the 3 distributions of the trigeminal nerve. So you can have it in the maxillary, mandibular, or ophthalmic division. Ophthalmic is relatively rare, and maxillary and mandibular division is more common. Generally, it's unilateral, and generally it affects one nerve territory. When there is bilateral involvement accompanied by sensory changes, or when it involves one or more nerve distribution, that's when you need to think particularly of investigating the cases. The second thing we also need to distinguish is between something called trigger points and trigger zones, because in a lot of conferences, I see even a lot of faculty confusing these two things. So trigger points are something that are seen in myofascial pain or myalgias, where there are hyper-irritable spots in muscles causing local pain or referred pain. Okay, and trigger zones are areas that are seen in neuropathic pain conditions, and touching these zones, you can stimulate the neuropathic pain condition, and it can be extraoral or it can be intraoral. Glossopharyngeal neuralgia, in comparison to trigeminal neuralgia, it's even more rare, and the prevalence in women is slightly higher. And again, secondary neuralgia is very common in multiple sclerosis patients. Okay. So in glossopharyngeal neuralgia, remember in trigeminal neuralgia, pain was limited to one or more distribution of trigeminal nerve. In glossopharyngeal neuralgia, basically it's pain in the ear, the base of the tongue, tonsillar fossa, or the angle of the jaw. And common triggers are swallowing, talking, coughing. So sometimes it becomes very difficult to differentiate glossopharyngeal neuralgia from myalgia. And in that instance, one of the common things we use for differential diagnosis is we ask patient to sip cold water using a straw, and that way you're not stimulating the muscles of mastication, and you're looking to see if you can stimulate the neuropathic pain episode. Another thing that you can also do in case of glossopharyngeal neuralgia is topical local anesthetic application, and see if the pain disappears when you apply it to the tonsillar fossa and the throat. Nervus intermedius neuralgia, and in this, the pain is felt basically in the auditory canal, and sometimes it can radiate to parieto-occipital region. It's again commonly seen with neurovascular compression, and in rare instances, it can be seen as a complication of herpes zoster. Again, stimulation of the auricular region or the posterior region by light touch or innocuous stimuli can trigger pain in these conditions. The last one, which is again relatively rare, is the occipital neuralgia. And it basically presents in the posterior scalp distribution of the greater and the lesser occipital nerves. And in this condition, it is sometimes accompanied by sensory changes. So you can have positive or negative sensory signs and symptoms. And in several instances in occipital neuralgia, you do get these sensory changes and tenderness in the involved area. And again, it's very important to differentiate it from myalgia and myofascial pain with referral from the cervical region as well. Okay. So again, the diagnostic criteria is very similar. And in addition, you can have dysesthesia or allodynia and tenderness in the affected region as well. One of the most underrated and underutilized diagnostic tool is a local anesthetic block or an infiltration. And in orofacial pain, it does have a very important role. And like Dr. Vaishnavi said, it's very important to distinguish site from the source of pain. And local anesthetic injections, blocks, and infiltrations do play an important role, particularly in distinguishing neuropathic pain from musculoskeletal pain conditions. So what are the red flags that you would look out for when you suspect a patient with neuropathic orofacial pain? Generally, when you see it in a patient younger than 40 years, because it's a condition that generally affects middle ages, 50, 60 years is generally the age group that you look for. There's absence of refractory period. So generally in between attacks, so immediately after an attack of neuropathic orofacial pain, if you touch the same trigger zone or the same area which stimulated the pain, the patient is unable to experience a second bout of pain, and this is because of the refractory period. Like I mentioned before, when it's bilateral facial pain, involvement or two or more divisions of the trigeminal nerve, it's accompanied by sensory changes. You have the patient is awakening from pain. He's poorly responsive to your management strategies. Those are generally red flags that should start alerting you either to investigate the case further or refer the case to an appropriate specialist. Okay, so I'm not going to go much into the details of conservative and interventional management because Dr. Vijay Bandikatla and Dr. Pratibha Mache have done an extremely good job. And it was an excellent presentation where they went into details of all these. So I'm going to go a little quicker in these slides and focus more on our case and what are the clinical pearls we should be taking home from this presentation. Whenever you're thinking of medical management of patients with neuropathic orofacial pain, remember that patient education is very important, because a lot of patients present with anxiety, depression, they're thinking that they've been to multiple healthcare providers, assuming that this is a condition no one has dealt with. So patient education is very important. Once you diagnose the condition, start with the appropriate first-line medication. Dose titration is very, very important. And like Dr. Pratibha mentioned, you would start with the lowest dose and then slowly titrate the patients. Combination with first line, second line medications may also be essential in some cases. And remember the medical history of the patient and the drug interactions. These play a very important role as well. So a lot of our patients are middle-aged and older age, and you can't titrate them as fast as you would a younger patient. And the side effect profile is also much higher in these patients. So you need to individualize your treatment and then go slow and add medications as and when necessary. The American Academy of Neurology and the European Academy of Neurology have come up with certain guidelines. And the first line is, again, carbamazepine. But remember, carbamazepine is associated with a lot of side effects. And genetic profiling is also necessary in some patients because particularly patients from Southeast Asia are more prone to conditions such as Stevens-Jones syndrome or toxic epidermal necrolysis. And this is because of genetic variations in HLA-1302. So it's very important that you know your patient and you start very low and you start looking for side effects, and you regularly monitor these patients with regular blood work because they're known to cause aplastic anemia. They're known to have side effects on the liver and kidney. So careful monitoring of these patients is extremely important. You also have gabapentin, pregabalin, phenytoin, baclofen, and lamotrigine, which can also be used as a single therapy or in combination therapy. And generally, you would use the lowest dose possible to reduce the side effect profile. Interventional surgical modalities, like Dr. Pratibha and Dr. Vijay mentioned, there's a host of interventional and surgical modalities. And when the patient generally fails medical management or conservative management, you've tried the first line medication, second line medications, that's when, or if the patient is still exhibiting symptoms, definitely a referral at this point is very essential. To rule out other causes or to start with interventional and surgical modalities. So, like I mentioned, getting a good history is very important before starting our case. So, remember our case, he presented with facial pain, which was in the maxillary and mandibular division. It presented as brief episodes of sharp shooting pain lasting for a few seconds to a few minutes. He was getting multiple attacks in a day. As the condition was progressing after radiofrequency ablations, he recently had also noticed that pain was getting stimulated by either itching his ear. He was having bouts of vertigo, dizziness, and he was also having headache conditions. And so it was at that point, and he was also having pain during swallowing as well. So at this point, we realized that the MRI that was done was about 30 years old when, MRI was still in its infancy. And so we ordered a repeat MRI. And what we saw was that he had bilateral internal carotid artery agenesis. And I don't think there's any case that's reported in literature with bilateral agenesis. And this is a case we are in the process of publishing. And so secondary to that, there was vertebral artery, vertebrobasilar artery dolichoectasia. And that basically means there was swelling of the vertebral artery, and that was placing pressure on the trigeminal nerve and multiple cranial nerves. So it was not just the trigeminal nerve, it was affecting cranial nerve 5, 7, 9, and 10. And hence he was presenting with the multiple symptoms. And at this point, so before the MRI was done, we had started pregabalin, and the patient exhibited a good response to pregabalin, 75 milligrams twice a day. So at this point, once the MRI and the MRA came in, he was referred to a neurologist, and the neurologist was monitoring him, and he was also referred to a pain physician and a neurosurgeon. And unfortunately, he had 2 episodes of transient ischemic attacks. And secondary to that, the pain physicians and the neurosurgeon felt that he was not an ideal candidate for MVD or interventional procedures. And since his pain was controlled with pregabalin, they decided to continue that and monitor him. And in addition, he was also put on anticoagulants, and statins to continue to control his high cholesterol, and he was put on antihypertensives as well. And with these measures, the pressure on the trigeminal nerve started reducing, and he was responsive to 75 milligrams pregabalin. So the neurologist and the neurosurgeon are still monitoring him. And so far, he's been doing good, like 6 months post his initial visit. He's pain-free and he's doing well so far. So the European Academy of Neurology has come up with practice guidelines, and this is in association with the International Association for Study of Pain. So these are current guidelines for management and diagnosis of trigeminal neuralgia. So one thing that they have concurred with, so in earlier recommendations, whatever red flags that I mentioned, people believe that just looking for those was sufficient to dictate whether or not you require an MRI. But the current guidelines suggest that there's no clinical feature which can exclude secondary TN. So as much as possible, if the patient can afford and if there's no contraindication, definitely advise a MRI, and that gives you peace of mind, and it gives the patient peace of mind as well. Sometimes when the patient is non-responsive to a treatment and the MRI report concludes an idiopathic TN, it is also better to have a second opinion or a third opinion from multiple radiologists, because sometimes patients present with just reports of MRI scans. And what we've seen in our practice is a lot of times there is a misdiagnosis, and it is possible that there is a factor of human error and secondary TN is missed out. So when the patient is non-responsive, I would suggest relooking at the films and the sections with a second set of eyes. If MRI is contraindicated, then trigeminal reflexes may be used. Using just evoked potential to distinguish primary and secondary, just like clinical features, there's a strong recommendation against doing that. And when it's also important using an MRI to distinguish whether it's classical or idiopathic, because there can be neurovascular compression in both. So only when the neurovascular compression is associated with morphological changes, these are the patient subsets that would respond more to microvascular decompression. So when there is an acute instance or an emergency of patient, there is a weak recommendation to use of lidocaine or IV fosphenytoin, and this has to be done in a medical setup with admission of the patient. Chairside, you can use topical anesthetics and give an infiltration, and may help the patient temporarily till they reach the hospital. And carbamazepine, oxcarbamazepine, definitely have a strong recommendation. Do go over the medical profile of the patient. Lamotrigine, gabapentin, pregabalin, baclofen, and phenytoin, you can use it as monotherapy or add-on therapy. Again, Botox has been studied, and all these have a weak recommendation. And again, there's low level of evidence that medical management is suggested prior to surgery. So if it is a case of classical trigeminal neuralgia or secondary trigeminal neuralgia, the current guidelines suggest that we should not waste too much time trying different medicines, but rather refer the patient to a specialist. And if required, surgical management may be a better option, and the patient may have a better prognosis if it is early on. Among the surgical techniques, microvascular decompression has the best long-term prognosis, and it's preferred particularly in classical trigeminal neuralgia. And multidisciplinary management is often required in these cases. And in secondary trigeminal neuralgia, the management is going to be similar to idiopathic or primary classical. But if it is secondary to a space occupying lesion, then you may require surgical consult early on and surgical procedure early on.
I'm sorry to interrupt, but we are short of time now.
Yeah, I'm done. Yeah.
So much.
So I'd like to thank the organizing committee and my professors and my colleagues. Thank you.
Yeah, ma'am. Thank you so much, ma'am.
Sharing 1 second.
Thank you so much, ma'am, for this insightful lecture, and it has been a pleasure having you here. Is there any question from the audience side now for ma'am? I cannot see in the chat box, but yeah, ma'am, if you could wait for some time, if there is any question, please anybody can type in the chat box. You can answer them there itself.
Sure. Thank you so much.
Next, we have Dr. Sumit Gupta. Dr. Sumit did his master's in orthodontics from Government Dental College and Hospital, Ahmedabad in 1998, topping the Gujarat University in all the branches of dentistry and was awarded a gold medal. He cleared the US National Dental Boards in 2002, did a fellowship followed by a master's program in temporomandibular joint disorder, orofacial pain, and dental sleep medicine from Smiles USA. Thereafter, he finished his diplomate and from the American Board of Orofacial Pain. Dr. Gupta has been running a successful multi-specialty practice in Ras Al Khaimah, UAE, since 1998 as an orthodontist and TMJ orofacial pain and dental sleep medicine specialist, and consulting in clinics in Dubai and Abu Dhabi. He is the founding member and director of Indian Academy of Dental and Facial Pain. He has presented in many conferences worldwide and taught his academic through his academic running courses on TMD and orofacial pain and dental sleep medicine. And to top it all, he's been awarded the Orthodontist of the Year 2023 from the prestigious World Dental Conference held in Bangkok last month. Congratulations, Doctor. So welcome to Nopcon 2023, and it's a privilege to have you on board. Doctor, can you just share, unmute yourself and share your screen, sir?
Yeah, thank you, Dr. Sonal, for the kind introduction. I'm just sharing my screen.
Yeah, we can hear you.
Okay.
Yeah, your screen is visible. You can go to the slide share mode.
Yeah. Okay. Are you able to see my screen and I'm audible?
Yes. Please go ahead, sir.
Thank you, Dr. Sonal, for the kind introduction. Good evening, everyone. First of all, a big round of applause for the organizing committee, Dr. Nurul, Dr. Sonal, Nopcon, for putting up a great show, having pioneers and stalwarts in orofacial pain from across India, bringing them together on this platform. And I'm really thankful for Nopcon for giving me this opportunity. A real pleasure and honor being here. We have had some excellent presentations in the last couple of days. And as per the organizing committee's request, I'm here for the final presentation, the concluding presentation, and let's wind up with some clinical pearls as takeaways, which will help us to start thinking out of the box for the betterment of our pain patients, for the betterment of our profession of dentistry, which I'm very, very passionate about. And I've been practicing for the past 25 years here in Dubai. So let's get going. This is my disclaimer. Yeah, so what do you see here? This is something known as the homunculus, which in Latin means a diminutive person or a little man. And it is nothing but a graphic depiction of the functional areas of the somatosensory cortex. So if I take you to undergraduate year one, we studied anatomy and all of us read Chaurasia, a great textbook. And this is what I read. I'm not very sure what the curriculum, today's curriculum students are reading. Well, I'm not going to bore you with anatomy. I know we are very much short of time. So we were taught that the brain has a motor cortex, which controls the motor movements of the body, as well as a somatosensory cortex, which controls the sensation of different sensations, including the sense of pain. So every part of our body has been designated a specific area in the brain And you'll be surprised to see, if you look carefully, that about 45% of this area of the homunculus is dedicated to nothing else but the face, mouth, oral structures, and the throat. So this shows how much importance our body, our brain in particular, has given to this area. And we dentists are the only healthcare providers who can manage problems, especially pain problems in this area. We dentists are considered to be masters in managing acute pain, whether it is pulpal or periodontal. But what about chronic pain? When it comes to chronic pain, our knowledge is very much limited because our education has been very limited as far as chronic pain management is concerned. Orofacial pain is much more beyond teeth, much more beyond occlusion, much more beyond TMDs, and it is typically chronic. And hence, orofacial pain is a specialty to manage these chronic pain patients for improving their quality of life as well as their overall well-being. So let's forget about anatomy now. Let's go clinical. Let's see some patients. I'll be showing about 8 different cases of various kinds. We'll be discussing the diagnosis of these cases in the coming slides, later slides. But with each patient, I'll be throwing some clues, some hints, which will help you to diagnose at least, or maybe make a differential diagnosis or provisional diagnosis in some cases. So let's see how challenging these cases can be. So our first patient is a 39-year-old Vietnamese female who complains of pain in the lower left posterior teeth area. So this is the area of her pain, as well as a diffuse pain on the lower border of the mandible on the left side as well. So it started about 9 months back. It's a chronic pain lasting for about 30 to 40 minutes. The intensity on a visual analog scale, where 0 being no pain and 10 being the maximum. The intensity of her pain ranges from 5 to 8 on 10. And she describes this pain as a dull ache. The patient's pain is increasing progressively since it started. It's more in the morning and is aggravated by mandibular movements. What are the past treatments done by this patient? She's seen a dentist who did scaling, localized scaling in this area, went on to do root canals in tooth number 18 and 19, which is the lower left first and second molar. Patient felt better for a couple of months, went back to the dentist with the same complaint. The dentist went on to extract both these molars. Patient's pain improved for another couple of months, went back again. The dentist did give her an RPD. Patient's complaint continues. Thank God an implant wasn't done or a bridge wasn't done. And this is the OPG of the patient who came to us with complaint of pain in this particular area. The patient gives a history of sleep bruxism. She's been happily grinding her teeth for the past 10 years, and she hasn't consulted any doctor for this. Nobody has even spoken to her about her sleep bruxism, and she considers it to be very much normal. On examination, her left masseter muscle shows acute tenderness on palpation. So once you have discovered an acute tenderness on palpation in the left masseter muscle, what is the most diagnostic logical question you're going to ask the patient? Well, the next question you ask your patient is this your familiar pain? Is this the pain you're coming to me for? A diagnostic test using a local anesthetic block of the left inferior nerve gave no relief to the patient. What do you think is the diagnosis of this case? And yes, that was her familiar pain. The left masseter muscle, which showed acute tenderness on palpation, was her familiar pain. So we'll see the diagnosis later. Let's move on to our patient number 2, who is a 24-year African-American female complaining of pain in the lower incisors. So this is where her pain is, as well as a diffuse pain in the mid-symphysis area. It started as a sudden onset following an episode of yawning. The patient felt a stretching sensation in the jaw and then developed pain. It's been there for the past 6 months. Intensity on the visual analog scale varies from 2 to 7 on 10. It's more or less a continuous pain and described as a dull ache. It's aggravated by yawning as well as stress. What are the relieving factors? Rest gives her some relief. Past treatments, she has seen a dentist who did deep scaling and curettage in the lower anterior region. Multiple desensitization toothpaste were prescribed. Root canals was done in the lower left incisors. 3 months later, root canals were done in the lower right incisors. Multiple analgesics and antibiotics were prescribed. Finally, the dentist saw that this is not odontogenic, and thinking it to be neuropathic, referred the patient to a neurologist, who, thinking it to be trigeminal neuralgia, started with carbamazepine, which is the drug of choice for TN. Still, the patient didn't get any relief from these treatments. The patient doesn't have any known medical history, is of a stressed personality, which is type A. And on examination, her cranial nerve screening, TMJ exams, as well as intraoral exams are all within normal limits. Panoramic X-ray showed no significant finding. Neither did topical anesthetic or local anesthetic infiltration give any relief to the patient. So what do you think is a differential diagnosis for this case? Okay, I'm just moving on with the patients. We'll be discussing the diagnosis later. Patient number 3, a 28-year-old Korean female, complains of pain on the lower left side of the angle of the mandible, anterior temple, as well as the supraorbital ridge on the left side. The pain started, as well as the headache started 4 years back. It was a gradual onset. Location, it starts at the angle of the mandible, supraorbital ridge, and the temple on the left side. And finally, it becomes a full-blown headache. A point to be noted, the patient works as a music teacher, plays the piano, mouth organ, and sings. It's about 5 to 6 times a week, lasts for hours. Intensity varies from 2 to 9 on 10. Described as a dull ache. Past treatments, the patient has seen ENT for her pain because it was referring from it was at the angle of the mandible. So the ENT said everything is normal. Seen a neurologist for headaches. Seen various dentists. The last dentist thinking the erupting partially impacted third molar being the culprit, went on to do an operculectomy. A couple of months later, the third molar was extracted. Still, the patient's pain continued. And this is when the patient came to us with a recently extracted third molar on the left side. It's aggravated when the patient is on empty stomach, stress, as well as a disturbed sleep. Menthol oil application and massages give her mild relief. She has an associated feature of nausea and numbness in the neck. She has past history of whiplash injury in 2012, as well as hypothyroidism. What do you think is the differential diagnosis of this case? And is there any significance of these two, whiplash injury and hypothyroidism? Well, this could have been an initiating factor, and hypothyroidism could have been a perpetuating factor for her cause of pain, and which we'll be seeing later on. Patient number 4, a 45-year-old married Emirati female, presented with a chief complaint of pain in the upper left teeth, above the lips and the cheek since 1 year. She also has additional concern of headaches, pain around the eyes, and sometimes around the chin. It started as a gradual onset, started in tooth number 14 and 15, which is the upper left first and second molar. It was 2 years back. Since 1 year, similar pain in tooth number 12 and 13, which is the upper first and second premolar. It lasts for about 10 to 30 minutes. It's a throbbing, pulsating kind of a pain. It's aggravated by cold foods and drinks, and is relieved by sleeping in a quiet, dark place. So what do these two mimic? Throbbing, pulsating, and aggravated by cold foods and drinks. Definitely pulpitis. So is this a case of pulpitis? We'll be seeing in the next slide. The past treatments, the patient's pain had started, as I said, in the molars, first and second molars. Deep scaling and curettage was done. Didn't get any relief. A month later, root canals were done in both the molars. 6 months later, both the teeth were extracted. Still, the patient is in pain. And now the patient's pain is in the first and second premolars. So definitely pulpitis is ruled out. Root canals were done. Even after extractions, the patient is in pain. She has an associated feature of nausea, sensitivity to light and sound, and feels as if her cheek is swollen on the left side. When severe, the pain is referred to the ipsilateral gum and the vestibule. This is the imaging of the patient, the OPG, when she came to us and extracted first and second molar. And now the patient's pain is in this area, the first and second premolars. Throbbing, pulsating pain increased with cold foods and drinks. Local and infiltration with 2% lidocaine as well as infraorbital nerve block didn't give any relief to the patient. However, cold application with using ethyl chloride on a cotton pellet increased her pain. What do you think is this case? Well, this is a picture taken by me in Vienna in Austria last year when I was attending the European headache conference. It was an excellent conference, a beautiful city with snow and winter Christmas markets all around. And a personal milestone for me because I was one of the only dentists presenting amongst world-renowned headache specialists and neurologists. And I had not just one, but 3 presentations. So it was an excellent conference, really had fun there. Okay, moving on to our patient number 5. A 28-year-old Kenyan female presents with complaint of pain on the right side of her TMJ area. It's more in the on the inner side of the ear. She also complains of numbness on the right side of the face. It started as a sudden onset, approximately 4 months back. It was in front of the right ear, a little bit inside the right ear. The duration is less than a minute. Intensity is 8 on 10, but recently a background continuous pain of low intensity of 4 on 10 has started. The less than a minute pain is shooting and electric in quality, and the continuous pain which has recently started is a stabbing dull ache. The patient's pain is aggravated by sitting in front of the AC with a cold blow of air. So what are the red flags in this patient? She's a young patient, 28 years old. The pain has started suddenly. It was a sudden onset of pain. There's a change in the pattern of her pain. Initially, it started as an electric, less than a minute pain. And now a recent continuous background, low intensity, dull pain has started. And she also has numbness on the right side of her face. So looking at these red flags, what immediate investigation you'd like to do for this patient? We'll see what investigation was ordered for this patient later. Patient number 6, a 75-year-old American male complains of difficulty in chewing and gets tired while chewing. And he also complains of pain around the temple and in front of the ear. It was a sudden onset. Location is, as I said, left side of the temple, preauricular area. When severe, it refers to the ear, to the neck, shoulder on the same side. It's a daily continuous pain, and recently the patient has developed a blurred vision on the left side. Past treatment, because of he was having difficulty in chewing and was getting tired on chewing, he's consulted a so-called TMJ specialist who gave him a splint. Didn't help, went on to see a neurologist for his headache who started with gabapentin and anti-epileptic. Didn't get any relief from this as well. So what is the red flag in this patient? Well, it is a blurred vision, which has recently started, and we should never ignore these associated features and really need to dip deeper onto these associated features, because these are the red flags which really need concern. The patient has metabolic syndrome with diabetes, hypertension, and hyperlipidemia. Clinical exam, there's the left side temporal artery is tortuous and has a feeble pulse and is painful on palpation. Lab tests show an elevated ESR of 68 and elevated CRP of 74. Any other tests or referrals you like to do? And before you jump onto these referrals or differential diagnosis, again, the next logical question you ask your patient is this your familiar pain? The left side temporal artery, which was painful on palpation. And yes, that was the familiar pain of this patient. Patient number 7, a 29-year-old Emirati male complains of pain in the maxillary molars, upper jaw, and in the right eye on the right side, on the same side. It was a gradual onset, started 3 years back. Location, as I said, the right side periorbital area, cheek, and tooth number 2 and 3, which is the upper right first and second molars. It's about 3 to 4 times a day, lasts for about 30 to 60 minutes. It's severe in intensity, 8 to 9 on 10, and it's stabbing, throbbing kind of pain. What are the past treatments done? The patient has seen a dentist because he had pain in the upper molars. The dentist did deep scaling. Root canals were done in the first and second molars. Crowns were done twice. First, a PFM crown was done, followed by a zirconia. Seen a neurologist who started amitriptyline, which is a tricyclic antidepressant, duloxetine, which is an SNRI, and gabapentin, an epileptic. A patient didn't get any relief from these treatments. Patient's pain is aggravated by alcohol and has an associated feature of redness and tearing from the ipsilateral eye, ptosis, which is drooping of the upper eyelid, and the patient is very restless and agitated during the attacks. Patient's sleep is disturbed. The attack typically occurs during 3 to 5 a.m. at night, wakes the patient from sleep, and what does the patient do? He goes to the balcony, walks around, and feels better. So what do you think is making the patient feel better in the balcony? Patient has a past medical history of severe snoring and sleep apnea. TMJ exam, mandibular range of motion, cranial nerve screening, even blood tests and panoramic X-ray were all within normal limits. What do you think is this case? This is the panoramic X-ray of the patient. A root canal is done in the first and second molars, crowns done, still the patient is in pain. This is our last patient. This is courtesy of my friend, Dr. Nilesh, who is an oral surgeon and orofacial pain specialist in Aurangabad. Just look carefully what this patient is doing. She complains of these weird, involuntary, uncontrollable movements, which have been going on for the past 1 year and which have progressively increased. The patient is undergoing treatment for depression and is on antipsychotics for the past 4 years. And now recently she started complaining of pain on her left TMJ. She says because of her excessive mandibular movements, the TMJ started hurting. And because of that, she consulted a so-called TMJ specialist again, who went on to do arthrocentesis, gave a splint, initially a soft splint, and then a hard splint. The patient's complaint has increased tremendously after wearing the splint. What do you think is the diagnosis of this case? Here she's pointing out at her TMJ. Okay, so what is the differential diagnosis for these 8 cases which I've shown? Are these odontogenic? Well, definitely not. The patients have seen numerous dentists, various treatments being done, no relief achieved. Are these temporomandibular disorders? Are these myogenic or arthrogenous? Are these neurovascular, something like migraine? Or are these neuropathic, something like a neuralgia? Or is there a space occupying lesion sitting right in the brain which is referring these pains? Or is it something systemic going on in the body causing these pains? And if not, are they psychogenic? So whenever we don't understand our patient's problem, we tend to label them under the category of psychogenic pain. This is what I used to do a long time back when I didn't have any clue what these patients were going through. And as they say, you can never diagnose something what you have never heard of. And your eyes cannot see what your mind doesn't know. So please, please never ever doubt your patients and call them crazy. It's our ignorance and lack of knowledge which makes us think so. So let's start thinking out of the box, do our diligence in diagnosing these challenging cases. So all these 8 cases which I've shown, none of them had any dental pathology. So the lack of local dental pathology is the key to diagnosis in these cases. All these 8 patients we saw had been wandering from specialist to specialist, seeking a relief for their pain. Most of the dentists whom they saw did not treat their pain, and even if they did, they didn't treat it efficiently. They tried whatever they could do, and when they had done enough, they started referring. And whom did they refer? They started referring amongst each other. So a general dentist referring to a specialist, maybe an orthodontist referring to an endodontist referring to an oral surgeon to an OMR guy. It is like none of them had any clue what was going, and it is like the blind leading the blind. So with such referrals, these chronic pain patients end up in a circular trap, and which is one of the worst part of ineffective and unethical management. So this is why chronic pain patients needed a specialty, and that's why orofacial pain has come up as a specialty. And at present, orofacial pain encompasses temporomandibular joint disorders. It can be the myogenic or arthrogenous. Myogenic disorders form a major chunk of these temporomandibular joint disorders, especially in my practice. 70 to 80% of the patients who complain of TMDs have a myogenic origin. Masticatory musculoskeletal pains. So let's see our patients. Our patient number 1. If you remember, patient complaining of pain in the lower molars. Patient was happily grinding her teeth throughout for the past 9 to 10 years. No treatments done. So this was a case of myofascial pain in the masseter muscle with referral to the molar area. So this is taken from myofascial pain textbook by Travels and Simons, which is an excellent book on myofascial pain. And this here it has been described that each muscle has a typical referral pattern. The masseters are the most robust muscles in referring pain to the teeth, and this was the case of myofascial pain because of her continuous bruxism, sleep grinding. She developed trigger points in the masseter muscle, which led to a referral pain to the mandibular molars. Patient number 2 complaining of pain in the mandibular incisors. Patient's pain was increased during yawning as well as during stress. Which muscle plays an important role for yawning? It is the anterior digastric, which is one of the suprahyoid muscles important for forced opening. And this was a case of myofascial pain in the anterior digastric with referral to the mandibular incisors. Remember patient number 3, a music teacher playing the piano and mouth organ and singing, had a history of whiplash injury as well as hypothyroidism, whiplash injury was an initiating factor, hypothyroidism was a perpetuating factor, as well as an occupational hazard with this patient complaining of pain in the angle of the mandible. This was a case of myofascial pain in the upper trapezius with referral to the angle of the mandible and a typical reverse mark question mark referral pattern. Cervical musculoskeletal pains, neurovascular pains. So if you remember patient number 4 complaining of pain in the maxillary molars. Initially it was in the maxillary molars, got those extracted. Now the patient has similar pain in the maxillary first and second premolars. Patient's pain is increased with cold food and drinks. Similar features of migraine. This is a case of midface migraine, also known as neurovascular orofacial pain. Similar case was shown by Dr. Ruchika in the morning today. Neuropathic pain, if you remember patient number 5, a young Kenyan female complaining of pain inside the ear. She had red flags, sudden onset, numbness on the face. A stat referral for an MRI was done. The MRI showed a space-occupying lesion at the cerebellopontine angle. And this was a case of nervous intermediate neuralgia, which Dr. Maithili was just talking about, secondary to space-occupying lesion at the cerebellopontine angle. Sleep disorders related to orofacial pain. Sleep and pain have a bidirectional relation. When pain is increased, sleep quality disturbs, which leads to increased pain. So we dentists need to identify this association between sleep as well as pain. And for orofacial pain specialists, the sleep disorders of main concern are sleep bruxism, snoring, as well as obstructive sleep apnea. Orofacial dystonia. So if you remember patient number 8, a patient with mandibular movements which are uncontrollable. Patient was undergoing treatment for depression, was on antipsychotics. This was a case of oromandibular lingual dystonia secondary to antipsychotics. So antipsychotics have known to precipitate oromandibular dystonia, which is a neurodegenerative disorder, something similar to Parkinsonism. Headaches, with primary as well as secondary headaches are included under orofacial pain. So if you remember patient number 6, a 75-year-old man complaining of pain in the temple, difficulty in chewing, getting tired on chewing, recently developed a blurred vision. A stat referral to an ophthalmologist was needed. This was a case of giant cell arteritis, which has infiltration of giant cells in the tunica media of the temporal artery. stat referral to a rheumatologist is also needed because blindness is one of the major complications of giant cell arthritis, and the patient needs to be pounded with heavy doses of steroids. And our last case, a 29-year-old Emirati male complaining of pain in the molars as well as around the eye. Typical attack during 3 to 5 a.m. wakes the patient from sleep. He goes to the balcony, gets oxygen there, makes him feel better. This was a case of cluster headache, which has been very much shown to be presented as toothaches. It is one of primary headache, a trigeminal autonomic cephalalgia, and certain systemic causes which can lead to orofacial pain. So what is the success ladder to manage this orofacial pain? We start with an accurate and thorough history taking, which includes the patient's chief complaint, past medical and surgical history, past and current medications, a detailed family, psychosocial, as well as sleep history, followed by a comprehensive clinical exam, which should be very gentle, thorough, well narrated, system-based, and trauma-informed. And only after these two have been done thoroughly, we go for appropriate diagnostic testing, and it should be scientifically valid and should only be done if it's going to aid in reaching our diagnosis and designing a management plan. With these three, we arrive at a differential diagnosis and thereby formulating a multidisciplinary, evidence-based management plan. So teamwork makes dreams work. What is the importance of multidisciplinary care? We should understand the concept that pain crosses over all healthcare disciplines, and pain is not unique to dentistry or to any medical field. It crosses all barriers, and hence the importance of multidisciplinary management comprising of all these specialties. We need to integrate all these different specialties for the betterment of our patients and for improving their quality of life. So what is the take-home message from this? We dentists are physicians of the stomatognathing system and not just mechanical dentists. Manage each patient as a whole, looking much more beyond their teeth, beyond occlusion. Start evaluating every patient who enters right from who's entering your operatory, looking at his gait, the demeanor, his posture. The moment the patient enters, don't just pounce on him with your dental armamentarium. Remove your dental hat, put on a medical hat, and start thinking from a physician's point of view. And I like to again stress on history, history, history. As all my fellow speakers have stressed on the importance of history taking, history is the key which is leading you to the diagnosis. Do your diligence and determine the etiology of the patient's chief complaint. Since we are dentists, we need to rule out odontogenic cause first. And the golden rule states that if it's not dental, think of muscle, which comes next to your mind. Reproduce the patient's chief complaint, which is the familiar pain. Identify the source of pain, reproduce it, and reconfirm it. Ask the patient, is this the pain you're coming to me for? The patient might have different complaints of pain which are not bothering the patient. So you need to address the patient's chief complaint, which is the most bothersome to them. And always remember, as our fellow speakers had spoken, for treatment to be effective, it should be directed towards the source of pain and not towards the site of pain. Always identify the red flags and keep them on top of the priority list. We follow something called the Snoop 10 criteria for identifying the red flags. So if anybody is interested, let me know. I could send the article across for Snoop criteria for identifying the red flags. Always identify the comorbidities, check for any medical disorders, sleep issues, anxiety, as well as depression. Avoid doing irreversible damages to teeth. Start with the most conservative, reversible, and the least invasive treatments first. Know when to treat, as Dr. Maikar was talking about the 3 W's yesterday. And more important than that is when not to. Always identify your limitations, know when to stop, and when you have learned to stop, learn to refer as well. So what is the most potential tool for managing and diagnosing orofacial pain? Are these your handpieces, your lasers, occlusal appliances, T-scans, imaging, or even artificial intelligence today? Well, there are none of these. The first and the foremost tool is to listen carefully to your patient because he's leading you to the diagnosis. And the second most important tool is what God has blessed everyone with us is our brain. So if we cannot use our brains, what are these fancy, expensive gadgets going to do for you? And effective management of orofacial pain is achieved more by thinking than by doing. And as Dr. Jeff Occasion says, who is the pioneer in orofacial pain in US, treating orofacial pain is a thinking man's sport, and a thinking man needs to be empathetic. So don't have a tunnel vision, look beyond, think out of the box using your brain, and believe me, you'll never go wrong. So from today, I'll urge you to start thinking beyond teeth, observing beyond occlusion, practice beyond position, and care beyond cure. And once you start doing this, this makes you a top clinician. And as they say, a good clinician treats the disease, whereas a top clinician manages a patient who has a disease. With this, I end my presentation. Thank you very much. Thank you, Dr. Sonal, Dr. Nural, for giving me this opportunity. These are the
Thank you, Dr.
references.
Sumit. Thank you,
Yeah,
Dr. Sumit. And our conference could not have ended with such a beautiful lecture. I mean, I would say this was a synopsis of the whole conference and the purpose with which we have started this Congress. What 8 cases you showed, actually, those are the golden pearls. Like those are the conditions what we've been wanting all the dentists to refer to or have come out of the tunneled vision. That's what I would say, that you have correctly put it, what the Congress was all about. So I'm glad that I'm glad that you were the last speaker for the day, because you actually summarized the whole conference for us. And thank you so much, doctor, for that.
Thank you so much. And I would not like to stress on the management part at all, because the main thing is for our dentists, our fellow colleagues, to identify these patients and stop doing these irreversible therapies. Management is like, there are other lot of specialists who are there sitting there to take care of these, but the dentist should just identify these and stop doing any treatments for these patients.
Yes, what not to do would be the main key to take care for.
Absolutely. Absolutely.
Thank you so much, doctor. Thank you so much.
Thank you
Thank
so
you
much.
for gracing us with this lecture of yours. So with this lecture, we come to an end to our Congress, and it has been overwhelming 2 days of Congress. From yesterday 3 o'clock we started, and non-stop we were online till around 7:30, I guess. And Dr. Nural has been working at back end continuously. So thank yous are in the order. First and foremost, to all the speakers and all the panelists who have been who have been the innumerable source of inspiration as well as source of knowledge. All the participants who have actively participated in such huge number and made this Congress such a huge success. Nevertheless, the first moderator for the yesterday, that is Dr. Anupriya Lakshmanan, oral and maxillofacial surgeon from Chennai, and Dr. Mrinalini, senior lecturer from Manav Rachna Dental College, Faridabad. She was our moderator for today. And we cannot thank enough the IT team, that is Ashraf Ali, who was behind from MedSkill, head MedSkill. He was the brainchild behind everything what that was happening at the back end. And and the man of the hour, that is Dr. Nural Anwar, and he was the one who got everybody together. Though he's a medico, I mean, I'm actually surprised at this man, who is himself a medico, but takes care, or who's so keen about dentistry as well. He's always been participating in so many other extracurricular activities for dentists also, that it's overwhelming to see that we as dentists have been recognizing and we are able to bridge this gap between dentistry and medicine. Thank you everybody for making this Congress such a huge success. The links are provided, and on if you all visit our Facebook page, you will be getting the links that are available on YouTube for you all to share and view. Thanks everybody for participating and coming in such huge number. With this, I would say this Congress is at end. And Dr. Nural, any last words from you?
No, you have said, and actually this is the, it's a brainchild of, me, but Dr. Sonal is working for last 1 month, and, he is helping us out from back end. So it's not visible, but, she is the organizing secretary, so she is doing all from back end. And there is a one announcement I would like to make. There are the participants are, we will be reaching out them through WhatsApp, through SMS and through emails. But those who are here, they can get the certificates of participation tomorrow in the first half. And they're supposed to go www.medskill.in. This is the, and we have putting it in the home page. So it's very simple. You supposed to, there would be one link. You're supposed to write your name and then select the category, whether you are UG, PG intern or senior resident or general practitioner or a faculty. Because sometimes in a hurry, people are, typing, there will be error while registering. So we are giving another opportunity. So write your name. You can write doctor before your name because we are just putting it a blank. So write whatever Dr. XYZ. Those who are UG, they should not write DR, but those who are intern, PG or faculty or general practitioner, they should write prefix doctor before his name and select the appropriate category and submit, and you will be getting that certificate on your screen. You can just control P and you can download it from there. So this is from my side. Over to Dr. Sonal to close the event.
Yeah, with this last word from Dr. Noodle, I would say this Congress is closed for now. So see you all soon with another different topic, another with us. And I would always want all the same speakers to come again with a fresh mindset. So see you all soon, very soon. And you all have motivated us to work much more better now. So thank you so much. Thank you so much.
Thanks. We are signing off. Yeah. Okay.
Yeah,
With
bye.
your permission, Dr. Sonal, should I sign off today?
Yes, yes, please go.